Доброго дня, шановні колеги. Сьогодні в нас вже триває третя міжнародно-канадсько-американська місія для допомоги пацієнтам із пораненнями голови і шиї. Ця місія почалася в нас ще в неділю міжнародним симпозіумом з реконструктивної хірургії голови і шиї для лікарів. В понеділок був проведений такий самий симпозіум для медсестер. А сьогодні в нас відкриваємо перший операційний день. Всього ми плануємо оперувати 4 дні. Операції будуть проходити в 3 операційних одночасно. Ви будете мати можливість подивитися операції, які транслюються з 2 операційних. Ця місія і цей захід відбувається, звичайно, завдяки нашим партнерам. Це є Face the Future Foundation із президентом Пітером Адамсоном. Це Разом for Ukraine, пацієнти України і, звичайно, Карл Шторц, Матеріалайз, Українська асоціація ендоскопічної хірургії голови і шиї і благодійний проект Still Strong. Бажаю вам сьогодні і нам плідного дня. У нас буде сьогодні 4 операції і запрошую Кунаха Тараса Григоровича, щоб він представив вам першого пацієнта. Задавайте, будь ласка, питання, будьте активні, ми постараємося по можливості на них відповідати. Так само, будь ласка, пишіть в чат. Все, гарного всім дня і плідної праці. Дякую.
На етапах допомоги у грудні 2022 року були видалені осколки на шиї. В березні цього року він оперований спільною командою канадських, американських, українських хірургів під час попередньої місії в Івано-Франківську. Була проведена ендоскопічна хірургія синусів і були розкриті лобні пазухи по типу ДРАФ-3. Також був закритий зовнішній шкірний і кістковий дефект в ділянці спинки носа, перенісся і спинки носа. От фотографії до попередньої місії, до хірургії. Ви бачите норицевий хід на спинці носа, який був закритий. Це ситуація зараз перед операцією. Ви будете зараз бачити із операційною трансляцією. Норицевий хід закритий. План операції. Ринопластика через доступ на спинці носа з висіченням рубця. Буде використаний реберний хрящовий аутотрансплантант для збільшення проекції спинки носа з великою ймовірністю. І буде для закриття ділянки рубця буде використаний шкірний клапоть з глабели, буде мобілізована шкіра зміщена для закриття і для зменшення натягу. Так, і зараз коротко комп'ютерну томограму, хоча тут ендоскопічний етап не планується. Бачите, було поранення і верхньощелепних, стінок верхньощелепних пазух. Бачите, дві лобні пазухи об'єднані в одну, в лівій ще залишається набряк, але в принципі пневматизація задовільна, набряк тільки в нижніх відділах лобної пазухи. Дякую за увагу. І зараз я попрошу переключити напевно, на заставку і представити наступного пацієнта Євген Валентинович. Мені теж з Канади, український хірург Кудерський. І, можливо, я по ходу операції буду підключати обладнання. Нам фірма Шторц надала екзоскоп Вітом 3D. Він буде давати хорошу картинку. Меттью Брейс, можливо, буде використовувати в тому числі і для операції це обладнання. Але, у всякому разі, ви зможете дивитись за ходом втручання в високій роздільній здатності. Під час нашої трансляції, знову ж, яку забезпечує фірма Карл Шторц. Модерувати дану операцію буде директор клініки «Нове тіло» доктор Ющенко Віктор Миколайович. Дякую. Якщо можна, тепер на операційну.
Значить, зараз відбувається однією командою забір реберного трансплантата, який буде мобілізовано, виділено та встановлено в ділянку назіона для відновлення контурів спинки носа через невеличкий розріз. Хірурги обережно виділяють реберний хрящ. Я так розумію, буде розділено його на графти, змодельовано так звані спредер-графти і укріплено спинку носа і, можливо, навіть зафіксовано до самого назіона, а не тільки до верхньолатеральних хрящів. Насправді це досить кропітка робота, тому що виділення хряща завжди поєднується з ризиками ушкодити легені, да? Тобто треба обережно, щоб не зробити пневмоторакс, але як ми бачимо, досить майстерно хірурги справляються з цим через зовсім невеличкий доступ. Як правило, використовується шосте, сьоме, у жінок частіше п'яте ребро, для того, щоб можна було заховати цей розріз під грудною складкою. Але у чоловіків, як правило, робиться трошки нижче. Ми бачимо, що шукається складка на животі, і в цій складочці виконується розріз. Перевірити, де зробити розріз, щоб він був менш помітний. Просять пацієнта сісти, зігнутися, і в тій ділянці, де є складка, робиться розріз. Ми бачимо вже майже повністю виділений один край ребра. Він розрізаний поперечний. Зараз хірург відділяє від охрястя. Бачимо зріз всієї товщини ребра. Досить кропітка робота. З великою обережністю потрібно підходити до тканин. Також інколи відбувається забір не тільки ребра реберного трансплантанта, а і охрястя. Бачимо, вже достали частинку ребра. Насправді великий шматок не потрібен, достатньо там 3-3,5 см для того, щоб відбудувати практично весь ніс. Зараз хірурги перевіряють гемостаз. Бачите, якраз те, що я казав, дивиться, що там охрястя. Можливо, буде забор теж охрястя. Що дає охрястя? Охрястя гарно камуфлює нерівності. Але вони, бачите, не будуть цього брати, вони просто ушивають ту ділянку, звідки було забрано хрящовий трансплантат. Але як ми бачимо, що хірурги доволі обережно з невеличкого доступу забрали цей хрящ. Зашивають розсмоктуючою ниткою внутрішні шари. І, як правило, використовується вікріл або К. До речі, є такий гарний діагностичний тест для того, щоб зрозуміти, чи ви своїми діями по видаленню хряща не зробили пневмоторакс, в рану наливається фізрозчин і спостерігається, чи немає міхурців повітря. І якщо ми бачимо, що міхурці повітря з'явилися, це може свідчити про те, що повітря виходить з плевральної порожнини і з'являється ризик пневмоторакса. Да? Це один із таких важливих тестів. Ми в своїй практиці зазвичай їм користуємося. пошарове ушивання ложа, звідки було взято реберний хрящ, воно бажане і обов'язкове для того, щоб в даній ділянці не було западіння, і для того, щоб виникало тобто для більш рівних контурів після вилучення хряща реберного бажано гарненько співставити тканини для того, щоб були рівні контури в післяопераційному періоді, не було западіння в цій ділянці. Для більш грубих пацієнтів, які мають достатньо підшкірно-жировий шар, це не так важливо, а для худеньких пацієнтів, особливо для жінок, обов'язково потрібно гарно підставляти всі тканини для того, щоб отримати гарний контур в післяопераційному періоді без западінь. Насправді, коли використовується цей реберний хрящ, можна не ушивати рану до кінця втручання, тому що, як правило, весь цей реберний хрящ він не застосовується для закриття цих всіх дефектів на носі, щось залишається, якісь шматочки. Його також можна укладати назад в те ложе, звідки було забрано цей хрящ, закривати його охрястям, залишками, які там залишаються після N-подібного розрізу, або англійською H-подібний розріз. І тоді в тій ділянці вони зростаються, фіксуються до залишків реберної дуги і виконують свою там функцію, і це досить непогано. Тобто можна повертати зайві хрящі, які не використалися, повертати назад в ложе або частину того хряща, який не був використаний. Як ми бачимо, розріз зовсім невеличкий, буквально 3-4 см. Це доволі акуратна робота хірургів. Хоча, в принципі, на сьогоднішній день навіть є методики ендоскопічного взяття реберного трансплантанта, який через невеличкий отвір 11 мм можна взяти 3-4 см реберного хряща на всю довжину. І це обумовлено гіпотетично можна із 4 мм, якщо ендоскопічна товщина ендоскопа 4 мм. Але вийняти цей шматок не вдається, тому що товщина його у маленьких жінок десь приблизно в діаметрі січення цього хряща 11 мм. є світовий відомий хірург День. Він показував в своїх майстер-класах, як він ендоскопічно за півгодинки бере реберний трансплантант довжиною 3,5 см на всю товщину через такий невеличкий розріз 11 мм. І на питання, а чому ви робите такий великий розріз, якщо можна через 4? Він каже, я можу і через 4, але витягти його не можу. Тобто взяти можна, а витягти все одно потрібен трошки розріз для того, щоб достати цей реберний трансплантант. Але насправді те, що ми зараз бачимо, це досить гарний результат буде косметичний, тому що хірург використав розріз близько 3, можливо 3,5 см. І зараз укриваються залишки реберної різьби м'якими тканинами. Я так розумію, що інша команда, можливо, вже приступила до розмітки на обличчі. Якщо Євген нас чує, Євген Медведський, може він нам покаже картинку на обличчі, чи є там розмітка, чи є там якісь дії. Ага, розмітка вже є. Ми бачимо, що хірурги вже зробили розмітку Габела Флеп, розмітили ділянку, де була колись нориця, де там є рубець. І якщо ви уважно подивитесь, гарно розмічені юніти, це частини носа. Бачите, кінчик окремо таким кружочком виділений. Бачимо спинка носа такою полосочкою, прямокутником виділена. І бачимо 2 трикутника справа і зліва. Це скати носа, і бачимо крила носа. Це такі субодиниці носа, які визначають, скажімо так, анатомічні контури носа, і при використанні там флепа будь-якого, або це лобний клапоть, або як в даному випадку це буде габела флеп, переміщення цих клаптів бажано використовувати, враховуючи ці юніти. Тому що якщо, наприклад, зробити переміщення клаптя і не закрити один там повністю юніт, то після того, як все приживеться, візуально буде гірший результат, тому що ці всі юніти, вони розроблені так, що це візуальне сприйняття носа. Якщо заміщується частина юніта, то візуально після загоєння воно буде мати перехід. Ці всі лінії – це якраз тіні, які падають на ніс, які формують при погляді на ніс, формуються у нас у візуальному сприйнятті носа. І вважається так, що якщо втрата до 1/3 юніта, то тоді можна частково заміщати. Якщо більше однієї частини, то краще весь юніт міняти, незважаючи на те, що більша частина або половина його ще ціла. Тому якщо втрачається частина ніздрі, то треба міняти там клаптем, заміщати там всю ніздрю. Якщо втрачається там кінчик, можна кінчик разом зі спинкою. Якщо це кінчик трошечки пошкоджений, частково заходить на спинку, краще поміняти зразу і спинку, і кінчик. Те саме стосується там бокових скатів носа. І візуально тоді ефект буде краще. До речі, на обох ніздрях ще відмічені м'які трикутники, так звані soft triangle. І ці трикутники теж розглядаються як юніти, їх треба при потребі міняти. В принципі, дуже швидко хірурги взяли ребро і вже зашивають рану, схилилися над раною, що нам практично нічого не видно, але вже діло йде до завершення. Як ви бачите, практично безкровно все. Дуже акуратно працюють хірурги. Це, до речі, говорить про велику майстерність, що не в крові довіряються, а обережно з дотриманням гемостазу. Буквально 2 серветочки, які використані, це дуже-дуже добре. Хоча насправді там зона достатньо кровоточива. Ми знаємо, що там є м'язи, які вкривають реберну дугу. При виділенні там є артерія, нерв і вена, які потрібно не пошкодити, коли ви від'єднуєте цей хрящик від нижньої поверхні ребра. Хірурги дуже добре впоралися з даним завданням, і зараз я так розумію, що цей реберний хрящ вже буде хірургами розділятися на графти. Доброго дня. Та можна зараз, якраз зараз ні о чому можна починати, да, представляти. Там ушивання просто і все.
Добрий ранок, колеги. З вашого дозволу я зроблю презентацію нашого наступного пацієнта. Це дійсно дуже непростий випадок. Ви можете бачити по фотографіям. Пацієнт наш військовий отримав поранення під час захисту нашої батьківщини. 25 травня цього року він отримав мінно-вибухову травму, посттравматичну деформацію зовнішнього носа, перелом, множинні переломи верхньої щелепи, дефект на орбіти, перелом лобної пазухи, річичного лабіринту і травматична ампутація кінцівок обох рук, верхніх кінцівок. Були проведені складні реконструкції. Він більше 2 місяців майже був з інтубаційною трубкою, трахеостомічною потім. Такий план наших хірургів на сьогодні. Це реконструкція нижньої стінки орбіти за допомогою пацієнт-специфічних імплантів, які виготовила компанія Materialize. Це використання дермального жирового трансплантату. Також буде перероблений рубець на спинці носа з використанням на спинці носа, як ви бачите, великий рубець деформуючий. Буде переміщений графт. Поки що план з надключичною ділянкою. І буде виконана септопластика для відновлювання носового дихання. Такі імпланти підготувала компанія Materialize, ви можете побачити. І по можливості через деякий час ми спробуємо вивести більш детально план, щоб ви могли роздивитися разом з КТ. Дякую за увагу. Повертаємось до операційних.
Повернулися до операційної, бачимо, що зараз вже ушивається ложе ушито, зводиться підшкірно-жирова клітковина, смоктуючими нитками. Причому, бачите, зрізали тільки що одну ниточку, тобто хірург буде використовувати безперервний шов, не вузловий. Це теж як варіант, це пришвидшує роботу, враховуючи великий об'єм операцій, який планується, клапоть, графти, це все не так швидко, тому, як то кажуть, сідайте зручненько, можете зробити каву, чай і приємного перегляду. Безперервним швом. Зараз закриють підшкірну жирову клітковину, після того вже будуть шви на шкіру для зведення країв і отримання максимально косметичного результату. Як ми бачимо, хірург прошиває на всю глибину для того, щоб закрити мертвий простір, щоб не було ніяких порожнин. До речі, важливим елементом є усунення всіх цих пустот, тому що там може скопичуватися сирома. Були такі випадки, коли пацієнти після операції активно рухалися, і в тій ділянці, звідки було забрано хрящовий трансплантант, скопичувалася сирозна рідина або гематома. Тому в рекомендаціях таким пацієнтам після операційному періоді рекомендовано не активізуватися дуже сильно, тому що оці всі рухи і цей залишок хряща або кістки, якщо вони брали близько до місця переходу хрящової частини ребра в кісткову, з'являються рухи тертя, і це сприяє тому, що може утворитися або гематома, або сирома. І це не досить добре в прогностичному плані, тому що це може призвести до запалення, нагноєння. І також інколи, коли ми бачимо, що пацієнт ще до операції проявляє неабияку активність, ми обов'язково зауважуємо, що треба вести себе досить помірковано, не дуже робити активні рухи, особливо там згинання, розгинання корпусу, повороти, щоб уникнути цих ускладнень. І ще важливим моментом є те, що після ушивання перших шарів в ділянці хрястя інколи ми встановлюємо дренаж. Ну, ми побачимо тут точніше не дренаж, а випускник резиновий або силіконовий. Це сприяє виходу залишків рідини, які можуть утворюватися в ділянці ложа, звідки забирається цей хрящовий трансплантант. Тому побачимо, чи будуть хірурги встановлювати.
Шановні колеги, ще раз включилися ми. Я сподіваюся, ви бачите. Це реконструкція комп'ютерної томограми, те, що ми отримали. Ви можете побачити цю діляночку. Оце якраз ділянка дефекту. І зараз що і як планується робити. Отак будуть розташовані імпланти. Отак будуть вони закріплені. Щоб максимально повно відновити пошкоджену ділянку нашого пацієнта. Ще я хотів би сказати декілька слів про операційну бригаду, яка сьогодні буде працювати, про хірургів, які приїхали. Перше, це Раймонд Чо. Це хірург з Сполучених Штатів Америки. Йому буде допомагати Джонатан Трейс з Канади. Також до команди приєдналася Тетяна Павличук. Це щелепно-лицевий хірург з Києва. Побажаємо нашим колегам успіху. Дуже дякую всім за увагу. Переключаємось на операційні.
Як ми бачимо, вже рана зашита внутрішньошкірним швом. Хірург протягує ниточку до кінця. Хоча це, можливо, ще й не рана, можливо, це субдермальний шар зашитий. А може вже і рана. Поки ми дивилися КТ, ми трошки опустили цей момент. Навірно, рана. Да, як ми бачимо, випускничок не поставлений, значить, хірург впевнений в тому, що гемостаз дуже добрий, що там нічого не скопичиться. Ну і пацієнт, відповідно, буде вести себе досить обережно і не буде у нього ризику розвитку ні гематоми, ні сероми. Значить, післяопераційний період має відбутися досить спокійно, гладко, без ускладнень. До речі, ви бачите, що відрізняється трошки школа хірургії в Сполучених Штатах і в Канаді. І на минулій місії, і зараз ми спостерігаємо те, що під час зашивання шкіри в нашій школі хірургії, як нас вчили ще в університетах, ми перед зашиванням обов'язково обробляємо шкіру бетадином, да, для убезпечення потрапляння мікробів зі шкіри в ранньову поверхню і виникнення якихось ускладнень там запального характеру. В даному випадку ми бачимо, що не відбувається обробки антисептиками перед зашиванням шкіри, але, як показує досвід, нічого поганого не відбувається. Можливо, пов'язано з тим, що ще в той час, коли ми вчилися, не було такого різноманіття антибіотиків, антибіотикопрофілактики, і тому використовувалися ці всі моменти. Зараз заклеюється ранньова поверхня наліпочкою Тегадерм. Вона убезпечить будь-які контакти інфекції з ранньовою поверхнею, з раною, яка зашита. Тільки що ви бачили, як хірург приміряв до носа графт, хрящовий трансплантант, він дивився, чи достатня довжина цього графту для того, щоб виповнити дефект назіо на спинці носа, тому що його треба фіксувати до переділки носа і верхньолатеральних хрящів. Він приміряв і далі пішов нарізати, я так розумію. Якщо є можливість показати, як хірург нарізає зараз хрящ, це було б досить інформативно. Якщо камера може повернутися на операційний стіл, можливо, нам було б цікаво подивитися, як саме хірург, якими інструментами хірург виконує нарізання цього хряща. Було б досить непогано. Бачите, хірурги схилилися над столом і, на жаль, лише широкі плечі оперуючого хірурга. Але там досить зараз цікавий момент вимірювання довжини, товщини і висоти цих графтів для того, щоб зробити їх реімплантацію вже в ніс. Як ми бачимо, багато молодих хірургів в операційній спостерігають за процесом. Кожному цікаво побачити, як відбувається нарізання, навіть фотографують, тому що це доволі такий цікавий процес. Мене почули, трошки повертають стіл, щоб було щось видно. О, гарно дуже видно. Дякую, Євген, і Валентинович, і Медведський, молодці. Я бачив, що всі приймали участь в тому, щоб було видно нашим колегам. До речі, використовується, бачите, така підкладочка біла, да? Вона з такої плотної резини або навіть поліуретан, наприклад, да? Тобто такий міцний, схожий на плотну резину матеріал. На ній дуже зручно різати. Як ви бачите, використовується звичайний скальпель, хірург витончує цей граф до потрібних розрізів. Бачимо залишки того хряща, який залишається на столі. І цей графт уже після моделювання буде встановлено в спинку носа. Залишки цього хряща ми бачимо і в баночці, і на столі. І це досить такий творчий процес. Зараз хірург вже виконує розріз в ділянці дефекту назіона. Я так розумію, що встановлення цього трансплантанта буде відбуватися якраз через цей дефект, що в принципі логічно, навіщо відкривати весь ніс, якщо можна зайти через цей дефект. Хоча я вам повинен сказати, що через доступ зверху не так зручно встановлювати ці графти, тому що ми не маємо доступу до верхньолатеральних хрящів, які скажімо, закінчуються біля кінчика носа. Тобто от ми бачимо, зараз хірург виділяє рубцеву тканину в ділянці назіона, буде через цей доступ встановлювати цей трансплантант. Ну, насправді це непогане рішення, тому що цей графт зробить, ну, судячи з того, як ми побачили, він змодельований, він зробить досить велику проекцію спинки носа і зробить ніс не таким запалим в ділянці назіона. Він має назву цей трансплантант солідний графт, тобто з цільного куска хряща буде підставлений під шкіру і залишки охрястя, яке покриває ділянку спинки носа. І таким чином буде аугментовано, тобто збільшено проекцію спинки носа. Із недоліків такої імплантації є те, що він може відчуватися пацієнтом на спинці носа. Якщо він пальчиками буде трогати свій назіон, то він може відчувати, що там стоїть цей солідний графт. І другий момент, який може бути при створенні достатньо широкого карману, він може трохи зміщуватися там праворуч, ліворуч. Тому в таких випадках, як варіант, можна використовувати розрізання його на більш маленькі, тоненькі графти і встановлення його вздовж переділки носа. Праворуч та ліворуч, під'єднавши верхні латеральні хрящі, можна встановлювати, фіксуючи до залишки переділки носа. Але в даному випадку можливо, там є пошкодження цих структур, хірург прийняв рішення, що солідний в даному випадку дасть більшу аугментацію, більше буде піднята спинка носа, це теж має місце бути. До речі, кожен хірург, він приймає рішення самостійно, як в даному конкретному випадку краще буде вчинити тому чи іншому кейсі. Бачите, зараз від'єднуються м'які тканини від ділянки травмованої біля назіона. Робиться така невеличка дисекція для того, щоб м'які тканини не були такі ригідні. Ця зона достатньо кровава, тому що там, як ми пам'ятаємо, є назальні м'язи, які роблять зморшки у нас на носі, коли ми робимо емоцію відрази, коли нам щось не подобається. Ми робимо такі от рухи, і ці м'язи роблять так звані заячі лапки, чи косметологи, до речі, знають, це входять туди в цей м'яз ботулотоксини. І от в цій зоні воно в ділянці цих м'язів може підкровлювати достатньо так, ощутимо. Тому хірург зараз виконує гемостаз. І рухається в ділянку спинки носа. І я думаю, зараз буде виконувати тунель. Бачите, він йде в сторону спинки носа. Залишок м'яза. Пробує. До речі, теж цікавий факт роботи американських та канадських хірургів. Якщо ви уважно подивитесь за роботою, то ви не побачите тут жодного шарика. Бачите, дивіться, яка здорова серветка. І ці серветки рахуються медсестрами. Кількість до операції і кількість після операції. А у нас шарик, тампончик, ще якась там салфеточка, да? А тут тільки серветки, все, або відсмоктувач. Якщо щось маленьке, треба там забрати невелику кров, або серветка, якщо щось велике. Все, іншого варіанту немає. Причому ці серветки, вони прошиті ниткою, рентген-контрастною, можливо, там для щелепно-лицевої хірургії, пластичної хірургії, обличчя це не так важливо, а для абдомінального покажу граф зараз хрящовий і зону, куди він буде його заправляти, для того, щоб підняти спинку. Міряє. Ще бачить, що малувати трохи тунель. Пробує, да? Дисекцію продовжує до кінчика носа. Звісно, цей трансплантант не буде, скоріш за все, заведений аж на кінчик носа, але трошечки подовжує дисекцію, ще раз приміряє граф. Солідний, причому, бачите, нижню частину він залишив, верхню частину він залишив напівокруглою, для того, щоб вона була схожа на спинку, а нижня пласка, щоб вона лягла на ту поверхню. І це, в принципі, логічно. Тоді буде кращий естетичний результат. Бачите, як він гарненько зайшов на спинку носа. Ось коли він робить такі рухи вказівним і великим пальцем, бачите, він і пробує рухати. От цей рух, це якраз те, що може відчувати пацієнт, трогаючи свій ніс, коли використовується солідний графт. Але треба віддати належне, що це якраз варіант корекції, коли треба зробити велику аугментацію, тобто значно підвищити тканини в ділянці назіона. трішки страждає, скоріш за все, що вирішують, до якої межі опускати цей трансплантант на спинці. Ми бачимо на камері в лівому верхньому куті, що тривають дебати, як краще його там можливо зафіксувати. Це рішення з проведення аугментації спинки вирішується інтраопераційно, виходячи з того, яка раньова поверхня, які підлежачі структури, до чого можна прифіксувати, як в даному конкретному випадку краще вчинити, щоб отримати максимально косметичний результат. До речі, ми бачимо ще розмітку на лобі. Да? Це вертикальна лінія, і потім вона загнута в правий, перепрошую, в ліве око, да? Ліве око пацієнта, в ділянку, скажімо так, трошки вище від кантуса. Буде створено клапоть, який буде спущено вниз, і таким чином буде закритий даний дефект. Відповідно, буде кращий естетичний результат. І потім це все буде ушито косметичним швом, що дасть підставлення тканин, зробить підставлення тканин оптимальним. Поки десь наш хірург пішов, я думаю, що можливо ще підганяє цей трансплантант на столі, можливо, підрізають його трошки ще, конфігурують для того, щоб, да, бачите, він скальпелем трошечки ще його підшліфовує. Я думаю, що він хоче його зробити трошки тоньшим, для того, щоб він більш гарно ставав ділянку спинки. Можливо, він трохи загрубий. Він трошки його витончує. Тобто була перша примірочка, він побачив, що по довжині він стає чудово, але по ширині він трохи виступає за спинку. Бачите, він забирає невеличкі шари цей трансплантант, він трошечки його стоншує. Як ми бачимо, зараз ще трошечки підшліфовує трансплантант хірург, трошки зменшує його проекцію. Я так розумію, що під час пробного встановлення хірург помітив, що він трохи загрубий і дуже сильно контурується. Тому зараз прямо на столі він його витончує. І зараз, скоріш за все, знову буде примірка, знову буде встановлення. Євген, якщо ви чуєте мене, переведіть, будь ласка, на пацієнта. Да, бачимо, хірург встановив його. Зараз знову перевіряє, чи він правильно стоїть. Цей трансплантант має бути конгруентним до підлежачих тканин, тобто підходити адекватно і не сильно виконати. Із цікавих моментів для тих, хто тільки починає працювати з реберним хрящем, обов'язково потрібно використовувати пінцети Hudson Brown. Hudson просто не підходить. Да? Hudson, щоб хто не знає, це пінцети з зубчиками, а Hudson Brown це пінцети з такою щіточкою, тобто там дуже-дуже міленьких і багато тих зубчиків. І от пінцет Hudson Brown, він не пошкоджує, не розчавлює, не проколює цей графт, іншими словами, не псує його. Це ощадливо допомагає встановити цей трансплантант, його можна вставляти, доставати там безліч разів, і це нічого не зашкодить цьому хрящу, на відміну від пінцета Ацена. Тому використання даних таких дуже важливих речей, так, правильного інструментарію дозволяє зберегти трансплантант. Це стосується не тільки там роботи з реберним хрящем, це стосується також звичайної естетичної ринопластики, для того, щоб не пошкодити. Зараз, до речі, теж цікавий момент. Бачите, хірург виконує остеотомію. Остеотомію за допомогою долота ендоназально. Є декілька варіантів остеотомії. В даному випадку хірург використовує назальне долото. Бачите, вказівним пальчиком він контролює ту зону, де зараз знаходиться його долото, і по нижньому краю апертура піріформіс або грушовідного отвору він від'єднує кістку носа до рівня кантуса. І зараз, бачите, він проламав вже, да? Тобто, по типу зеленої гілки зараз відбувається.
Камери роздільної здатності 4К забезпечують картинку. Ми можемо спостерігати операцію в об'ємі на великому хорошому екрані, використовуючи стереоокуляри. Хірурги, правда, використовують зараз свої хірургічні лупи, тому що вони так вважають, що більш мобільні в даному випадку. Тому в цій операції вітом використовується для трансляції, для спостереження. Зараз ми можемо бачити все те, що бачать хірурги, можливо, навіть кращі роздільні здатності, дивлячись, спостерігаючи за картинкою на екрані, не нависаючи над операційним полем. Дякую. Далі можна переключати на Віктора Миколайовича на подальшу модерацію.
Хірург продовжує роз'єднувати кістки. Це так звана остеотомія low-to-low, тобто по краю грушовидного отвору заходить долото і далі піднімається, від'єднуючи назальні кістки від верхньої щелепи до рівня кантуса. Що це дає? Це дає можливість трошечки звузити спинку носа, для того, щоб ніс не був такий розплющений, а для того, щоб в ділянці спинки носа надати йому мануально потім бажану ширину. Тобто кісточки носа трошечки медіалізуються. Зараз правий скат носа пропрацьовується, роз'єднав долотом ці з'єднання. І я так розумію, зараз буде з лівої сторони те саме. Можливо. Хоча, якщо там з того боку кістка стоїть більш правильно, а тільки ця була пошкоджена і латералізована, можливо, тільки з одного боку. Ну, зараз побачимо. Так от, бувають різні остеотомії. Зараз ми побачили остеотомію через ніс трансназально, а є остеотомії, які можна використовувати, наприклад, перкутанна, коли робиться прокол в ділянці ската носа і долотом, так само через невеличкий прокол 2 мм тоненьким долотом хірург роз'єднує ці кістки для того, щоб зменшити ширину носа. Ось ми бачимо, вже хірург взяв шовний матеріал і фіксує цей хрящик до м'яких тканин, до окістя, до окістя назіона. Як ми знаємо, що найбільш міцні структури, до яких відбувається фіксація трансплантантів або, скажімо, переміщення тканин, коли відбувається це до фасцій або до окістя. Це найбільш такі міцні. Також можна до кісток, але це треба сверлити, треба шурупи, теж можна робити за допомогою так званого металоостеосинтеза або пластиночок з мікрошурупами. То в даному випадку хірург обрав фіксацію за допомогою шовного матеріалу і до окістя носового відростку лобної кістки або залишку його, який стався після травми. Бачимо, був праворуч накладений один шов, і зараз ліворуч хірург фіксує. Ну, логічно, що для того, щоб тканини були зафіксовані більш міцно, одного шва, як правило, недостатньо. Треба. Це стосується не тільки там тканин в носі, да, будь-що ви фіксуєте, чи ви там майструєте вдома і робите, наприклад, якісь там дерев'яні вироби, да, тобто одним цвяхом, як правило, ніхто не фіксує, да, треба там 2, можливо, 3, так і тут з обох боків праворуч і ліворуч зафіксовано. І цей трансплантант буде стояти стабільно, не буде рухатися в ділянці назіона і дасть нам гарну проекцію для фіксації. В принципі, як ви бачите, до речі, внизу, якщо ви там звернули увагу, нічого не фіксується. Да? Тобто він там просто в тунелі цей стоїть трансплантант, він стоїть під шкірою, під шкірно-живою клітковиною і охрястям. І лежить на хрящі зверху на верхньолатеральних хрящах і на залишку переділки носа. Зараз хірург пробує натягнути тканини, бачить, що дефект достатньо великий, і тому їхня попередня розмітка, яку вони запланували для закриття дефекту, буде досить доречний і зможуть змістити тканини. Зараз хірург дивиться, чи потрібно ще мати, можливо, трохи тканин для того, щоб вони краще співставлялися, але це вже буде вирішуватися безпосередньо на столі. Бачите, вони опускають шкіру з лоба, пробують її натягнути вниз, але бачать, що залишається діастаз і нічого не вдається дотягнути. Тому ця розмітка, яка була зроблена напередодні операції, це якраз вихід в даній ситуації для того, щоб дотягнути м'які тканини. Бачимо, шкіра достатньо мобільна. Перевіряю зараз хірург пальчиками зводить, каже, для того, щоб коли буде переміщений цей клапоть, щоб було зрозуміло, що тканини зведуться, да, зведуться. І розріз хірург починає Зараз ми бачимо, що відбувся розріз м'яких тканин вертикально і до ранньової поверхні, де утворившись такий клапоть. Він мобілізований від кістки лобної, і хірург пробує зараз стягнути його вниз. Дивиться, чи достатньо буде. І ось далі ще один такий кутовий розріз, який дозволить змінити траєкторію руху. Да? Тобто ми отримали такий клапоть на ніжці, який буде переміщено. Зараз. Бачимо, що клапоть мобілізується і до кісті. Далі буде переміщено. Ця зона якраз там, де зараз відбувається дисекція, досить кровава. Там проходить мускуліс процес.
Доброго дня, шановні колеги. Паралельно ми розпочали роботу в нашій другій операційній. Розпочали нашу роботу з дуже складного клінічного випадку, який був продемонстрований. Перш за все відбувається підготовка до встановлення індивідуалізованих імплантантів в ділянці нижнього краю лівої орбіти та передньої стінки. Перш ніж це робити, нам потрібно висікти масивні рубці у пацієнта в ділянці медіального краю лівої орбіти, та який прямує до верхньої губи. Для пацієнта це створює колосальні дискомфорти в аспекті рухів верхньої губи, в аспекті розмови, прийому їжі. Він постійно відчуває дискомфорти в цій зоні. Крім того, був травмований інфраорбітальний нерв, втрачена чутливість в цій ділянці і змінені прикріплення в ділянці нижньої повіки та в ділянці медіального телекантуса. Наші колеги з Америки та Канади будуть сьогодні пробувати це виправити. Цей колосальний рубець буде сьогодні висічений. Після того заплановано встановлення індивідуалізованого імпланта на дно орбіти. Після того, для того, щоб створити якусь підтримку для м'яких тканин, буде встановлений індивідуалізований імплантант в ділянці передньої стінки синуса. Але м'яких тканин для того, щоб замістити м'якотканинний дефект своїх власне у пацієнта не вистачає. Тому трошки згодом ми побачимо, як наші колеги будуть проводити забір надключичного клаптя для того, щоб його протягнути в тунелі та замістити дефект в ділянці медіального кута ока. Дуже складно відбувається відділення рубцевої тканини, тому що самі по собі тканини дуже скомпрометовані, запалені, постійно кровоточать. Тому доводиться працювати дуже обережно, покроково і повільно, для того, щоб постійно проводити гемостаз. Dr. Cho, could you make some comments for
Yes.
our colleagues?
So I've started out making an incision along the edge of the scar that is causing downward traction on the medial commissure. And so we can see that the scar is starting to be released here. So the medial commissure, which was down here, is now returning to a more normal position as I release this scar tissue.
Thank you very much. And is it just difficult in this kind of trauma because we have a lot of scarifications, because we have a lot of inflamed tissue in that area, and of course our doctors are talking about that is not usual cases when we have a lot of powder, mine powder
So this
in.
looks like the medial commissure has returned to its normal position here. So we're going to leave this for later, and I'm going to go ahead and do the subciliary incision, which I've already started with the 15 blade.
От зверніть, будь ласка, увагу, який доступ використовується в цьому клінічному випадку. Тому що встановити орбітальну пластину зазвичай можна за допомогою транскон'юктивального доступу. Але в цьому випадку було прийнято рішення використовувати підочний субцилярний доступ з тією метою, щоб по-перше, для того, щоб виправити прикріплення в ділянці медіального кута ока, а по-друге, для того, щоб створити додатковий об'єм тканин для переміщення. Він буде трошки подовжений, цей субцилярний доступ, і за рахунок цього ми зможемо краще і легше маніпулювати тканинами і змістити їх в ділянку медіального кута ока після операційному періоді, після операції, коли будемо вже між собою тканини зшивати. Дуже складно працювати на таких скомпроментованих тканинах, тому що анатомія надзвичайно порушена. Ми не можемо знайти, от зверніть, будь ласка, увагу, під час препарування немає чітких шарів, які би мали бути в цій анатомічній ділянці. Тобто фактично він їх зараз створює заново і працює в ділянці рубців.
I know what it is.
So at this point, I've gone through the skin and the orbicularis, and I'm dissecting the preseptal plane to the orbital rim. Now, this is not my usual approach. Are you translating, Tatiana, or somebody else?
Yes, of course,
You
I
are?
will.
Okay.
Доктор Чо якраз зараз говорить про те, що це не є тим доступом, який використовується зазвичай при таких оперативних втручаннях. І він зараз дістався уже до фасції і пробує проникнути під неї, там, де вже буде знаходитися у нас окістя та нижній край орбіти. Але кажуть, що кістки немає. Єдине місце, де є кістка, це латеральний край орбіти.
So my usual approach to the orbital floor is through a transconjunctival approach. But in this case, I decided to use a subciliary approach because we are going to be doing some work in this eye socket, and I want to decrease the risk of any fistulization occurring in the socket.
Пояснюється, окрім того, що ми вже обговорили, зазвичай доступ у доктора Чо до дефектів на орбіті – це транскон'юктивальний, але в цьому випадку він використовує субцилярний доступ. Не тільки те, що ми з вами проговорили, а й для того, щоб уникнути в майбутньому інфікування структур очниці. Тому що в даному випадку ми встановлюємо титанові імплантанти, і титановий імплантант встановлюється не тільки на дно орбіти, а титановий імплантант буде встановлюватися і на передню стінку орбіти. Це інфікування з гайморовою пазухою, це інфікування з порожниною рота, і в разі, якщо у пацієнта щось піде не так після операції, величезні ризики того, що ми отримаємо інфекцію в структурах орбіти, яка може мігрувати, зрозуміло, в інтракраніально. Тому з точки зору безпеки прийнято таке рішення.
Yeah. Yep. feel anything? Right there. So here's the gap. Here. Tattooing is really deep.
Ну, зараз якраз обговорюють те, що цей порох після мінно-вибухових поранень проникає дуже глибоко всередину тканин. І це є величезною проблемою для наших пацієнтів, тому що його не можна ліквідувати ні за допомогою хірургічних маніпуляцій, ні за допомогою косметологічних маніпуляцій. От зараз вже дійшли до ділянки кісткової тканини, і доктор Чо буде пересікати окістя. І це буде нашим орієнтиром.
I'll take a Dean.
So minimal bruising. The only time I'll use like a 5 or 4 mil is like a really thick bone.
Sometimes you just have to because the bone's so thick.
Yeah. But intranasal continuous osteotomies with a 2 millimeter seems to work in 90% of cases.
So are you still doing it high to low to high, or you
Yep.
change that too? You're not
I'll do high-low.
done percutaneous, have you?
Only once in a while will I do percutaneous, and that's usually in somebody that's having a revision, because I find, you know, that shatter effect is less with little perforating.
I guess I've generally always done the high, low to high, just because I like the smoothness of it.
Yeah.
Rather than, thinking, postage stamp, chip here, there, everywhere. But
Yeah.
I know there's a lot of aficionados of the percutaneous, and would never do anything. As long as the results are good, what the hell,
Yeah. Absolutely. I don't like using percutaneous, especially if I'm doing an a closed rhinoplasty. If I'm doing a closed, I find it funny to make an incision on the nose up there if you're not going to open the nose anywhere else.
Remember all the complaining goes on about friggin' side of non-scar.
Yeah.
The same people are happy to put scar on the side each side of the nose, which is fine, but I'm just saying there's not much logic in it.
No. Yeah.
Not much logic. So you're gonna be done here soon.
Going to be done very soon. Yeah.
Oh, that's great. Good stuff.
Yeah. Thank you.
When you are closing, to teach you there,
Yep.
we're always gonna be hundreds of people
Yep.
listening, so you can, just, little tips about what you're doing here, how to prevent your tissue cones or how much to blood, whatever.
Yep.
Whatever comes to mind, it's gonna help.
I'm using a 50% rule here just to avoid a standing cone deformity. And I'm trying to use up every last piece of this Vicro or this Monaco because I don't want to open another one for one stitch. But I might have to. Might use one of the leftover. Yep. Do we have any of that 4 Vicro left? I don't want to open a new Monocro.
I have a Goro on a larger needle right here.
Oh, you do? Okay. If there's a Monocro open, just don't open a fresh one. So I don't know if you guys want to show the profile of the nose now, but he actually has a nasal profile. It's been built up quite significantly.
Показати спинку носа збоку.
So I'm using the 50% rule here, and by that I mean. Sure, yeah. The 50% rule, I'm sure you know it, is just when you have an incision, you go to the middle of it and you close the middle and try to make the excess the same on both sides, and then you go to both sides. Yeah.
Вау. Покажіть, будь ласка, фото так збоку.
And a cut, please.
Це легше як за скопом, напевно.
Oh, yeah, that's okay.
I got that one in his hand.
Jack, I'm putting a needle on
I'm
the
not worried that it's in the incision.
sharp up there.
Але то треба нижче. Треба от на цій площі. Саме нижче, як можна. Ще нижче.
Do you have a wet gauze, Jackie? We can clean the face for this view before we close? I don't need it sopping wet, just. You can show, I'm trying to make it look, yeah. So you can see now the profile is built up. It was down here and now it's up here. Yeah, so nice and straight. All the scar tissue is gone. We're just gonna close that with some, I think some Proline.
I do have 5 Pro.
Yeah, perfect. I redid the osteotomies because his nasal bones were very, very wide and his whole nose was kind of collapsed. So I used the 2 mm osteotome and did a
Я використав 2 мм.
lateral. Nope. No, it was the medial nasal bone was all crushed, so it didn't need it. So I did a high, low, high. So I came in and went down, across, and back up, and pushed the nasal bone in. And so now, I don't know if we have his photo, it's on the door, but he had a very, very wide portion here, and now that's been pushed in. So his nose has been narrowed and lifted up by bringing the bones in and putting the rib in, both combined. Yeah. Thank you. Yeah. So here, I think the key thing is not only no tension, but also eversion. You want the skin edges. Do you have a jeweler forceps? A jeweler forceps, the little Castro? I love the jeweler forceps for closures because, yeah.
Good enough?
Good enough, yeah. This tiny little instrument because it lets you be really, really precise with grabbing skin edge and closing. So I think I'm going to do a little a little vertical mattress here. Just because this is wanting to involute. Again, I leave these stitches in for 6 days usually, and then take them out.
Стоять 6 днів зазвичай.
And the reason I take them out at 6 days is because it's long enough for the skin to be adherent, but short enough so that you don't get train tracking. You don't get the little dots.
Через 6 днів, через те, що це достатньо для того, щоб шкіра зрослася. І якщо тримати довше, може бути слід від шва залишатися.
Again, I'm going to get this corner perfect.
Цей кут гарно тут виходить.
It's going to do it interrupted here. So I'll probably run most of the suture, but after I get a few key stitches in to make sure I have the skin sitting the way I want. Yeah, just both, yeah. You can steri-strip the incision after the stitches come out. I'm happy with that. And I like your little tiny bites.
Старі стріпи після того, як накладемо шви.
You usually only need 1 of the 5 O's or?
Yeah, I should be okay. When I tie my knot, I try to keep the knot to one side of the incision. I'm going to run this guy. So not sitting right in the middle, but off to the side. And that helps push the skin edges up rather than tying the knot down and pushing them down. So you want that pull to pull the skin up and everted. And everted, well, all scars will contract as they heal. So an everted scar will contract down as a flat scar. So that's what we want. A perfect scar would be flat, thin, and a good color match. So I'm doing a running horizontal mattress here. This makes it hard on your nurse who has to take these out.
Горизонтальний безперервний шов.
But it really ensures that the skin edges come up.
Ставити правильні краї для того, щоб не було надлишку в зоні рубцювання.
Usually just polysporin, honestly. Yeah. Actually, sorry, no. In this case, so in skin incisions, usually just polysporin. In this case, because we have a graft and osteotomies, steri-strips and a nasal splint. Yeah. Yeah. And one of the splints. Priya, do you have any pearls of wisdom?
I think it's a great case, and I think I like the glabella flap
Yeah.
choice. I think it's just with the amount of scarring he had, I think one boy would have just, you would have always been wondering, I think,
Yeah.
if you brought in far enough away tissue.
Yeah. I made that decision, like as we talked about, because I think the rhomboid was going to pull his brow too far medial, and the glabellar flap kept the rotation of tissue more vertical rather than side to side.
He had no breathing concerns, right? It was just the
Yeah.
aesthetic, but I think even your dorsal graft did kind of give him a little more structure even to his super tip area.
It did, yeah.
Just just into the tip as well, which is really nice.
So it looks a little funny when you do this closure because the edges sit proud, but that's exactly what I want them to look like. For anesthesia, we're probably 10 minutes out. If they need to do anything. It's always important to communicate with your anesthetist. They don't like it very much when you say, I'm done. And they haven't lightened the patient.
What kind of things can we expect for post-op for the patient? So the edema of the eyes.
Yes, he's going to have...
What kind of things do you like them to do, not like them to do?
So this guy's going to have probably bruises under both eyes and some swelling. His nose is going to be very swollen. For a couple months, it will take a whole year for the scar to mature and probably likely the swelling to completely resolve. One of the risks with this rib is that it could warp, so it could twist with time. And it could move. So we really want it to be scarred in place, which is one of the reasons I'm putting this splint on. And the splint just stays on for a week, 6 days, to help prevent that from happening. You really don't want to bury any skin here because you'll create a cyst. With any closure, you want to make sure that you have the skin edges up. And this is tending to want to involute in, so again, I'm going to put mattress stitch here. And hold them up. And I'm doing a running horizontal mattress, really everting the edges here. This will be watertight, I tell people, usually by 72 hours, 3 days. But with a splint on, I tell them not to get it wet because I don't want the splint to fall off.
That's one. You take splint after 24 hours, yeah?
Splint off in a week.
Week.
1 week.
Сплинт буде стояти протягом одного тижня.
And how long do you put them on? 1 week as well?
Yeah.
Nice bit of swelling, but also
Is there a problem?
reminds them not to roll over on their face.
Yeah.
They had trouble in Mercury, so Natalia is another hour and a half off.
Як ми бачимо, зараз хірурги ушивають рану в ділянці надіона, клапоть був зміщений вниз. І тепер ми маємо закриття дефекту, причому лінія, яка
I'd
утворилася
have to go talk to her
в
and just
ділянці
find out what her
надіона,
plan
вона
was. I can.
попереджена. І це дає гарне
Yeah,
естетичне
no, I just,
змоги. Там є у нас складка, коли ми пускаємо брови вниз.
I want to know what her,
коли ми
her front, her incision plan. I want to know.
гарний,
And then,
є гарний
yeah, I'm happy to.
естетичний результат.
Yep, it is. So what was it? It was the frontal bone plating, the PSI.
If you pull up this photo, it'll be pretty memorable.
I can't get anything, sorry guys. So I have a frontal bone defect recon with PSI, right cheek scar revision with possible fat.
Хірург підхоплює в один
Yeah,
шов
so I can
зразу.
harvest fat. I can do a scar revision. I can start. I can do that case. That's fine. Yeah.
Гарну фіксацію.
It's just that scar on his cheek, right?
Yeah.
The depression of this of the. Yeah, I can do that totally. So
So Natalia's in room 3, so when you're done here, go talk to her.
I think she was thinking that previous scalp incision come down over the
Yeah, it's
the defect.
1.5 centimeters post cephalad from the actual defect so that we don't just end up in the brain.
Yeah, and then just a real delicate elevation over the dura.
Exactly.
Okay,
I think
dab.
that was sort of the biggest point for that case. I don't think we have to do that. I think we're going to see if we need to use that. So we wanted the fat available. Yeah, I think we wanted the fat available, but not.
Is there any other fat grafting today?
I don't think so, but
If there's no other fat grafting today, I think there's nothing to lose doing fat, and we should probably put some because he was pretty depressed, and that will also give us something to teach. So we'll just need tunescent for that. I'm just thinking of special equipment we need. Tulip set tunescent, and then probably my facelift tray because it has some brow elevators on it. Can you cut that out? Yeah, cut the whole thing out. I think so, yeah. And then just cut that knot off, just under the knot. Yep. Yeah.
Привіт, привіт. Що?
I missed the last part.
Well, I just said the facial tray we can use because it's good for the case.
Or you John?
Ага, я так розумію, я можу відключити трошки, так?
Yep. Yep. So let's create a different plane here. Why don't you grab this something again?
Добре.
Can I change them?
Perfect. Thank you. Yeah, that's a better plane there. There's a little bone, so that must be the strut. Kind of toe in.
No, it's not a good. Колеги, ми за час нашої відсутності провели уже доступ до дна орбіти. І зараз доктор Чо намагається видалити маленькі дрібні фрагменти в ділянці медіальної стінки правої орбіти, тому що вона абсолютно фрагментована. І для того, щоб спозиціонувати і встановити наш пацієнт-специфічний імплантант в цю зону, нам потрібно ці маленькі фрагменти видалити. Відшарування тканин не таке, як відбувається зазвичай при травматичних переломах дна орбіти. Зазвичай це дуже легко робиться за допомогою розпатера. Ці тканини піднімаються нагору і встановлюється пацієнт-специфічний імплантант. Зараз дно орбіти цього пацієнта схоже на величезний рубець і зміксовані між собою анатомічні структури, тому, на жаль, тут провести цю елевацію м'яких тканин за допомогою розпатера неможливо. І прийнято рішення працювати над тонкою насадкою коагулятора, що дозволяє, в принципі, нам провести цю елевацію таким самим чином. Відбувається це за рахунок того, що в якійсь зоні медіально або латерально доктор Чо пробує знайти кісткові структури і далі вже рухається вздовж кісткових структур, намагаючись візуалізувати окістя і піднімати його догори для того, щоб потім спозиціонувати наш імплантант. Трошки маємо проблему зараз з кровотечею судинок, медіальної стінки немає, він абсолютно вільно може провалитися в порожнину носа, розчищастий лабіринт, і так само в ділянці дна орбіти він може провалитися в верхньощелепний синус. Всі ці дефекти ми спробуємо вам продемонструвати, і потім вони будуть заміщені уже індивідуалізованим імплантантом. Доктор Cho, if it's possible, our colleagues would like, maybe you can tell something about what happened now.
Yeah, so now I am dissecting, I'm trying to find the posterior ledge for my implant, which is usually found at the posterior aspect of the floor in the medial wall.
Зараз спробує доктор Чо знайти нашу задню опору, куди буде встановлений пацієнт-специфічний імплантант. Зазвичай вона дуже легко візуалізується під час відчарування м'яких тканин в цій зоні, але структури змінені, і тому візуалізувати цю ділянку, де буде спозиціонована задня лапка нашого імплантанта, дуже-дуже складно.
In this case, though, he has a displaced fracture of the medial wall. So I am going along the inferomedial strut, or the ethmoid maxillary strut, in order to find the posterior ledge.
В цьому випадку вона фрагментована між собою ця стінка. Він не може зробити це в традиційний спосіб, і тому рухається вздовж цього підвищення, яке йде в ділянці решітчатого лабіринту.
And I think I found it.
І, здається, уже його знайшов. Це дуже-дуже важливо знайти цю задню опору при позиціонуванні орбітальних імплантантів, для того, щоб потім він був правильно встановлений. Всі м'які тканини мають бути припідняті наверх, і ця дистальна опора дозволяє нам встановити наш індивідуалізований імплантант в єдине попередньо сплановане
Hey, did you
положення.
have a strung out bratic?
Тому що в разі, якщо ми його змінимо або не знайдемо цю опору, наш імплант просто не сяде. Тому це є однією з найбільш ключових точок операції в ділянці орбіти. Перше, потрібно рухатися вздовж окістя, візуалізувати кісткову тканину, а після того обов'язково знайти дистальну опору, на якій буде спозиціонована наша найвища точка нашого імплантанта.
So what are you telling our audience, Tatiana?
Я розказую, що дуже важливо знайти... excuse me. I am joking that this is not a regular situation and this is very difficult to do it.
Can we have the bipolar on, please?
And even if you are very experienced, it's very difficult to find where you should place the distal part of your orbital implants, because this is very, very important part of the operation, because the positions of distal part of implant, this is the way how we can be successful in this type of surgery, because we can find the distal large, and this that you are talking about, I just commented a little bit wider.
Or a bayonet bipolar. So Tatiana, if you feel, let's grab and push, if you push down this way, you can feel I'm on a stable bony ledge.
Yeah,
That's
this is
that's the posterior ledge there.
posterior large.
Can I see a snap and a ruler again? And that should be around snap. That kind of. And I would expect this to be around
Оце
40
дуже.
millimeters.
Could you comment this?
Yep, that's about 45. Yep.
Could you comment to our doctors, because this is a very, very essential tricks, how you...
So this method of measuring, so I have the tip of my suction is on the posterior ledge, and so I'm placing my clamp at the anterior rim, and then measuring what's beyond the clamp.
Doctor,
So that's around 40 millimeters. So that's where I expect the posterior ledge to be.
Це дуже цікавий метод оцінки, де саме знаходиться лікар під час препарування дна орбіти пацієнта. І от він винайшов такий метод оцінки. Зазвичай до вершини орбіти ми маємо 35-38 мм. І тому він позиціонує слиновідсмоктувач в ділянку дистальної опори, там, де він відчуває кістку. Далі москітом приблизно визначає місце, де знаходиться у нас передній край орбіти, нижній край орбіти, її передня ділянка, і після того лінійкою виміряє. І зараз на лінійці ми знайшли 38 мм, тобто він приблизно може зрозуміти, що він знаходиться у вершини орбіти і може на цьому етапі зупинитися. Dr. Cho, do you need to decrease the blood pressure?
Can we do that?
Transition.
Are we able to decrease the blood pressure? And maybe, are you okay with tranexamic acid?
Анестезіологи, скажіть, будь ласка, а можна вас попросити трошки знизити тиск пацієнту?
Can we have the bipolar on, please?
Щоб хоча б 100 на 60, щоб було. Хоча б 100 на 60, 90 на 60, щоб було.
Put it on 30.
Дякую. І вести...
Ми не можемо екстраполювати те, що на нозі міряємо, тим, що на руці міряємо. Розумієте? Раз, друге. Що ми пробуємо?
Дуже дякую вам. І скажіть, будь ласка, можна попросити ввести пацієнту транексанову кислоту?
And do we have the PSI up?
Ні, тільки я сюди, може, перейду, коли будуть вже ставити, щоб допустити. Може, якщо він високий буде.
Якщо вдруг ви будете переходити, вам буде заважати поговорити, то ставити.
Так, звичайно, без проблем.
Я довго не питаю.
Я розумію.
Ти відлучився, то що там?
Я розумію абсолютно.
Please.
Sweaty hands. So coming to yours. So when you can, if you're not
Ми зараз виключені. Ми зараз виключені.
Take it out.
Угу.
Yeah. You put some pressure.
I think just the power equipment and screws.
Just screws.
Drills. Oh, they're
They're self-tapping? Yeah. Mhm.
Tell me the size and I'll open it up.
So this is the orbital part of the PSI,
We want to be close so we don't.
and this is the maxillary part. So,
I think it should be like this.
yeah. So the holes for the maxillary part are lower, right?
So you can try to navigate through the foramen exit,
Uh-huh.
right? Because there won't be any screws here, and then
So both the screws are on the bottom. Or do I have this upside down?
that's the top part.
That's, yeah, just like that for the patient. Yeah.
So it's like this.
Yes.
Okay.
The notch for
There we go.
foramen.
Nice.
Okay. So they have designed this implant so there's a breakable portion on the posterior part in case you don't have trouble dissecting that far posteriorly. I think we should be okay because we found our posterior ledge. Let me see the ruler again. That's about 30, 35. Yeah, 35 from the rim there. So, yeah. So I think we should be good. It's just
Робіть все, що вам треба. Без проблем, без проблем.
Do we have anything like gel foam and thrombin? No. Okay, yeah, we can use Surgisol. Yes, please, thank you. See where that's coming from? Thank you. Yeah, like 2 centimeters.
Yeah, right close, sorry, right down there. Shoot. Yeah, I think it's coming from right back down there. Maybe give that away for me.
I feel like it's more interior.
Thanks. Is up here flowing down or is it back
I
there?
think it's flowing down.
Oh, okay, something in there. Yeah, yeah. The fragment right there. Frick. You want to take that fragment out?
Yes, sure.
Можете мені оцю вниз потягнути трохи штуку, сам мікрофон, бо він вже на носі. Дуже дякую. Все, дякую. Дякую. Так, все добре. Да, включайте, ми попросимо зробити. Скажете коли? Доктор Cho, could you make some comments for our colleague because we on now?
At this point, we've almost completed our dissection. We're just trying to obtain some hemostasis.
Зараз під час відшарування орбіти майже закінчене відшарування стінок орбіти і маємо невеличку кровотечу, тому зараз намагаються її скоагулювати судинки. Це невелика кровотеча, вона не створює великих проблем, але для того, щоб бути впевненим, що не буде післяопераційної гематоми чи якихось проблем в майбутньому у пацієнта, хочуть зробити лікарі, щоб все було ідеально. Трошки складно це зробити, тому що дуже сильно рубцево змінені тканини. Ці рубці надзвичайно кровоточать, навіть під час висічення і проведення доступу ви це бачили. Тому, на жаль, ми маємо чекати, коагулювати. І зараз ми просто затампонували ділянку кровотечі і чекаємо на протязі 5 хвилин, поки відбудеться гемостаз. Маємо в арсеналі всі інші методи гемостазу, такі як Surgicel, тахокомб або інші види гемостатичних засобів, але наразі в цьому немає необхідності, так як в нас немає великої кровотечі. Зараз маємо просто чекати. І вже через декілька хвилин ми побачимо, як буде встановлений орбітальний імплант. Поки ми чекаємо,
Go with Tatiana.
She makes it look much better.
Is this going to be in your way?
No, can I have a knife, please? Thank you.
поки ми чекаємо гемостазу, ми будемо продовжувати висічення рубця в ділянці носу, що прямує до верхньої губи, та створювати місце для нашого майбутнього клаптя. Could you make some comments about this?
Absolutely.
Thank
Yeah,
you.
we've got a dense scarification. You mentioned that word. I think it's a good word. And now we're just going to try to remove it because it's actually causing quite a bit of problems with the nose, the upper lip, and the lower lid. And I think we're going to try to release this as well. Release the... I might get you to just retract that mosquito, please. Thank you.
Зараз доктор Транс пробує висікти цей надзвичайно в жахливому стані рубець, який створює проблеми в ділянці лівого крила носа та верхньої губи. Коментує, що вони надзвичайно потужні і надзвичайно поганої якості рубці. Спробує висвободити ліве крило носа для того, щоб пацієнта покращилося дихання та верхню губу.
I did think that maybe that would improve his nasal ala some. Just so scarred, and we're certainly not cutting all the scar tissue out, just the absolute worst parts of it.
Лікар видаляє не тільки ділянку самого рубця, а й навколишні патологічно змінені тканини.
Nice little. Okay.
Зверніть увагу, як кровоточить. Перед тим, як провести будь-які втручання, звичайно, пацієнт був промаркований, відмічені краї, де буде проводитися висічення рубців, а також тканини були інфільтровані розчином місцевого анестетика для того, щоб також зменшити кровоточивість рани під час висічення.
Yeah. Hope I haven't caused more bleeding.
Do you need the...
Are we good for this, or do you want to keep going?
Let's give it a look.
Yeah,
Keep
okay,
going.
knife back, please. We're gonna need a few of these knives, just because it's so hard. Really? Wow. Thank you. Let's go right up here.
Not a 50, please.
Dr. Trites, when you do the scar excision, do you bevel the incision in any particular way?
I do sometimes, not today as much because we're really cutting through so much traumatic tattoo, and we're going to have a wound, an unfriendly wound. So if we're going to do a layered closure, the scarring, sorry, the beveled incision. I do when it's trichophytic incision, when we're near the hair-bearing skin, just to preserve some hair follicles, but not really here. This is good though. Okay, could I have a single skin hook, please? I do like to try to use hooks and stuff instead of tooth forceps because I think the tooth forceps are sometimes really quite traumatic themselves. This doesn't matter because this is just going in the garbage, but it's the adjacent tissue.
Лікар використовує зазвичай такий крюк для того, щоб підтримати тканини. Не любить використовувати два пінцета, тому що це досить травматично для навколишніх тканин. І плюс ці тканини самі по собі є не такої гарної якості, щоб їх підтримувати пінцетами. Це може створювати проблеми, вони можуть ці рубці рватися, і їх не дуже зручно буде тримати. Тому такий крючок – це найкраще при висіченні рубців. Але в даному випадку вони не витримують, тому що самі рубці надзвичайно поганої якості. Тому немає інших варіантів, крім того, щоб підтримувати їх пінцетом.
Sorry, delicately dissect. Not hack.
Зробити це за допомогою скальпеля майже неможливо, тому що він не витримує. І тому так само, як в ділянці орбіти, буде висічення цього рубця за допомогою коагулятора. Зверніть увагу, наскільки глибоко проникли фрагменти пороху в тканини пацієнта. If you don't mind, I translate what you're talking about.
Absolutely. So we have a cut and a separate coag function, right? I think. I'm trying to use cut here, but it's really.
That's pretty. What is the bovion?
The monopolar setting, please.
Emma, what setting the Bowie's on? It's on 15, and right now you're on cut is 30.
Okay, could you maybe put that down to 20? That's just a lot of smoke. Can I have the knife, please?
Okay, it's on 20 now.
Thank you.
You're welcome.
It's nice to see some normal tissue.
Yeah, right there though. Yeah, you're right.
Зверніть, будь ласка, увагу, який великий шкірний дефект у нас виходить у пацієнта після висічення рубців. І можливості звести тканини на себе, навіть якщо б навколишні тканини були у пацієнта інтактні, майже неможливо. І зараз звертають увагу на те, що тканини під рубцем надзвичайно глибоко уражені. Це особливість мінно-вибухових поранень. Те, що молекулярний струс тканин набагато глибше, чим ми можемо побачити оком. І проникає дуже-дуже глибоко в усі шари цієї ділянки. І от якщо на щоці ми бачимо якийсь жир і трошки збережена пошаровість тканин, то в ділянці от ближче до кута ока і латеральної поверхні носа ми бачимо, що тканини досить глибоко відсепаровані, але все одно виглядають ще як рубець.
Little depression, like a little divot. I think you were able to see that on the 3D recon.
There's some normal fat. Thank you. Thanks. Now take those forceps. That's right. Yeah, I think so. Okay, so yeah, so there's lots of room for more resection, but none
You
of
can
that.
already see, you see that? Lay this over, you can see how large the defect is compared to the original
Yeah.
scar. You can see how much tension it was under.
Зараз доктор Чо коментує про те, що ми з вами обговорювали, що рубець порівняно з тим дефектом м'якотканинним, який утворився, набагато менше. Тобто це не істинний дефект м'яких тканин, який був у пацієнта, а після висічення і розслаблення трошки тканин ми бачимо, наскільки цей дефект збільшився в об'ємі.
How are we looking with your side?
Well, let's see.
That? Yeah. This here? Yeah. Thank you. I'll take that Army Navy back, please.
See the ribbon, please?
And the malleable ribbon jacket. Which side do you want to use? Oh, hang on.
See it?
Yeah,
Yep.
I absolutely see it. It's coming from north. You see that right there?
Yep. You got it? Top down?
Sorry.
Bipolar on, please?
Oh, it's right down there.
30.
Oh. Good. I'll try it.
Maybe try with this
Yeah,
one.
try. Good. Nice. Should help a little bit.
Still one more bleeding
Yeah.
deeper. Yes, something here. Do you want?
BB, are you straightening out my ribbons? No. No? No? Okay.
Yeah, you did that one.
Huh?
The one you used, maybe I did. I used it already. You want me to take that?
No.
It's too deep.
There's definitely something up here too, right? Like up immediately. I don't know if I can find it. Okay, some of that is me, maybe. Right there.
Excuse me.
That's why.
Yeah, some of those guys. What does that mean?
No, it's not help.
Another one.
Bipolar, please.
Bipolar. Nice. Yep, much better.
Want to switch to the orange one, or okay with this one?
Oh, the orange one for this, yeah. I suppose. Well, unless we're happy. Are you relatively happy with down in here, or? Because you'll need that one for that,
I can
right?
have a look, yeah. Ribbon?
Yeah, sorry, I got it right here. Oh, yeah, I see something.
You do?
Nasal-like. No, I just in terms of
Oh.
mucosa.
Okay. Well, that's definitely the nose.
Right.
See that being a problem? This big-
No.
No.
Well,
It's never ideal.
No,
No.
you would like to leave it?
yeah, just cut that out, or
Okay.
we can hot stick it out. Good.
That's better.
Much better. We can see.
Always a plus. Let me see the implant, please.
Really hard to separate the, as you said, what's supposed to be in the orbit from sinonasal.
Let me see a.
Dr. John, maybe you would like to use
forceps?
the pre-drill guide for positioning or...
Yeah, do we have the drill guide?
Mm-hmm. Yes, we
yeah,
have a small, oh, okay. Yes, we have one for this.
let's find our rim here. Maybe switch to the sun.
Send, please. Thank you.
All right, let's see those guides. Okay, which color is the?
The same color as the infant.
Same color as the. Okay.
Yeah, so just like orbital.
Yeah, we have to dissect more along here, I think. See that sun? Can I get a freer, please?
Take another send, please.
So Materialize has made us these cutting guide or drill guides.
Матеріалайз
For,
створив для нас навігаційні шаблони для того, щоб ми мали орієнтири для позиціонування нашого імплантанту. І от ці два отвори, які сплановані в нашій частині імпланта, вони будуть нам трошки допомагати в позиціонуванні.
Now we don't actually have to do any drilling because the screws we use are self-tapping, but this is just a good guide to know where we're going to put our screws.
Зазвичай для фіксації орбітальної пластини не потрібно використовувати засверлення, тому що для фіксації використовуються самозасверлюючі гвинти, які не потребують попереднього засверлювання. Але в даному випадку це набагато полегшує життя хірургам створення таких шаблонів для того, щоб точно знати, що цей імплант встановлений правильно.
Right.
Yeah, nice.
So that's where these two holes go,
Okay.
right there.
Can we mark them or something?
Maybe a bovie, maybe the
Yeah,
needle
sure.
tip. And yeah, can I see the? So you have the drill guide.
So that's
And,
the orbital.
That it is, okay. So that goes just right up to the edge.
Yeah. Almost to the top.
Oh, okay. Oh, so it actually is not at the edge of the fracture.
it's a
It's
little
actually a
more-
little bit more lateral. Okay. So it's kind of like right about
But it's not so
There.
much.
Lateral, I think, yeah.
a little more lateral than that.
About
like
roughly
that?
there, yeah. I think
Okay.
that's nice.
All right, so this is going to go
Yeah.
something like that.
Hello.
Let me see the bovie, please. I don't know if this is
Yeah,
going
right
to
there.
make a mark, but let's see. Suction.
Good. Yeah, nice.
Дуже цікаво використовується методика для позначення за допомогою коагулятора.
And where did our implant go?
Implant's here.
Oh, there it is.
Mhm.
Some scar tissue over here, so maybe I'll take that loose.
Army Navy, please. Interesting. So do we need to resect some of that scar tissue? Like there?
Resect or just get underneath it
Get
somehow.
underneath.
Can I see the Dean, please?
Yeah, okay.
Is there any bone medially that this implant's supposed to be resting on?
This one I don't think so it may be small, it may have a small contact here, but other than that, no.
Yes.
A wee little contact.
Yeah.
But not a screwable contact.
No.
Yeah.
I don't think screwable is politically correct.
I wasn't sure. Ray, only you picked up on that.
See the Adson, please? Check this one. need to dissect a little bit more
Posteriorly or?
laterally. This stuff right here.
Laterally.
Okay.
Yeah. I'll take the bogey, please.
Thank-
Hot stick, I like that.
Yeah, that's definitely nose up there.
Yeah. So that's probably just scar tissue there.
Yeah, I think so.
So just gonna
Yeah.
slice through that. And some nice supple orbital thing.
Do you want me to pick that up?
Yeah.
Pick up, please, Addison.
There we go. That's what I like to see. Some little bone fragments in there.
Hey, buddy. How'd your day go? Great. Amazing. What was that?
You're done, Matt?
I'm done. That is like.
Your case is done, or you're doing with your part of the case?
No, he's done.
Oh, what was it?
Way to go, buddy.
Beautiful. All right.
We're over there.
For a repair.
I wonder if he's had a chest like somewhere, or you never know. Yeah. He was a younger guy, but this.
well.
Good. Oh, super. We're fixing.
Deep in the orbit.
It's really a mess in there.
So I think that's our ledge there.
Yes, it should be. Because very stable part.
Yep. All right. See the implant?
I love
Putting that in, fixing the scar background.
Okay, yeah. I mean, we're gonna be a bit yet.
Yeah, sounds like
Thanks, man. Okay. Oh, we're nearly there. So this medial part has to drop down a little bit more.
Yeah.
Looks like. Oh, it's getting close though. That's really nice. How you did that? With the drill guide, I don't think I'd seen that used before. In the orbit anyway. You're pretty much there, aren't you?
Feels good.
That's really nice.
Can I get a 4-screw, please?
4?
4-screw.
4 screw. Please.
4. 4.0.
Mm-hmm.
Nice. This is good. This is great.
I'm gonna
Number 4.
4 millimeter.
4 millimeter.
Oh, the width? That's the smallest one. That's
1.5.
1.5. Yeah.
No, just a regular 1.5. Craniofacial, self-tapping.
Now, are we going to be opening this up to get to the maxilla? Right here?
Do you want to just do that?
Допоможе, якби тиск
You know,
був
this
на
feels
120.
terrible, especially right here.
Трониксан
This
вели.
feels not too bad, actually. This feels terrible. You want to just open it up?
Відключені чи
your call.
включені?
I mean, this is our exposure to the next
Yeah.
one.
Well,
Fine.
here's the thing.
Do you think you're going to go through now?
So yeah, let's open it up.
Чи ні, воно нормально.
Are you happy if I just do that now?
Yep.
Can I have a double skin hook then?
It'll help me.
You. All right. Sorry about the smoke. There's just nothing normal there at all.
Nope.
All right, now.
And then we'll go underneath this to
Okay.
get to the next one. That is normal.
I'd love to stay out of his mouth.
Yes. Okay.
We have some terrible scar tissue here, though. I
Мгм.
might intersect that. But I don't have to do that right now. If you
Flap
want.
it or resect it?
Actually, resect it.
Yeah. Do you want a little bit more coverage for the PSI over the?
Maybe
that's a
we
good-
can-
You know what?
maybe-
Let's slap it.
Maybe we
great
can use it for
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 coverage?
covering.
Yeah.
Yeah.
Okay.
Because
Can I-
if
can I
it
come
was-
across- Sorry, Ray. Can I come across here then? Or-
Yeah, I like it. I like how we're making two separate flaps
Yeah.
of tissue. We've got skin, and then we've got subcutaneous or scar that is passing as subcutaneous.
All right. All right. All right, here we go. Double hook, please. Double skin hook. Did you give it to me already? Maybe I have it up. Thanks. It's wide. You gave me a nice, okay, no. Okay. Okay, thank you. Now, I don't think we were making an effort to save the infraorbital nerve, were we?
No. I don't think he has enough of it.
Now, in terms of bone,
Can we see the CT again, please?
okay, here's one for sure.
What are you interested in?
Hmm. That's helpful.
Which part? They want to
The upper maxilla, the light blue, yeah.
zoom in.
So, look at that. So that's not too far above the tooth-bearing segment, right?
Mm-hmm.
Down there.
Are you
So-
concerned about that?
No,
Okay.
but if we're gonna stay out of the mouth, which
Mhm.
I'd want, which I'd prefer,
Maybe we can make the additional scissors inside the mouth since it will be easier for
yeah.
us to, because we should put our or maybe we can find it
I
here.
think we can find it.
It would just be nice to decrease the infection risk.
Mhm,
Yeah.
mhm.
I'm feeling. So this is,
You see that, Dean, please? The Dean?
This is the
Moment.
apertura. Yes, yes,
yeah,
apertura.
right there, yeah,
And we should put our guides here.
great idea.
Because
Yeah, it's right above his
because we should place
second
our
bicuspid, yeah. There. Yeah, I can get you down to the bone there. Gee, not a ton of it though. Yeah, nice.
You guys don't have Molt 9s in Canada?
We don't have what?
These Molt 9s?
Yeah, we
You
call
do?
them something else though.
Or Dean?
I call
What
them
do you call
number 9 elevator.
Number 9, yeah, Molt 9.
elevator.
Yeah.
Never an elevator.
Number 9 implies that there's a number 8 and a number 10. I've never seen one of those.
Yeah.
We just call
Number
it,
9 is special.
Number 9.
right, Emma? Yeah. You call it something else. Something 9.
Dean, I call it a Molt 9 is what I've been,
MOLT.
M-O-L-T, yeah.
MOLT.
So what is all this stuff?
I think that's thin air. That's nothing. But like I said, I'd love to stay out of his
Yeah.
mouth. I think, yeah,
I'm gonna keep this
come
stuff.
across. Not really.
No? Okay.
Let's come across that.
Maybe
Forceps,
some
please.
some
Add
hooks.
So we're trying to bridge this gap, right?
Right.
Okay, and maybe suck them right up in here. Thank you. Okay, I don't think that's pretty good in terms of wooding. But yeah. Yeah. That's nice. Yeah.
So we gotta get lower here, right? Because there's another
Correct,
bony.
Correct. Like Ray.
I think that's it right there.
Okay.
Maybe just a little bit more cutting. Right there.
Yes, I think you're right. That's nice. Can I see that thing you said?
Yep.
Just to come over here, right? Because this part over here would make me. Good shot. Okay, that's starting to be the tooth, I think. Prominent. Good. Thank you. I'll take that. And I can take a Army Navy, please.
So that'll cut across here then, right?
Sure. Thank you. Now, can you feel some bone down there at all?
There should be some bone, right?
Yeah. let's
Isn't
see if I
there?
can Release this.
Right? Isn't there bone down there?
I think so. Yeah, oh gosh, actually got a fair bit of bone there. All the tooth. Yeah, okay.
Or is that where the gap starts between the gazagoma and the maxilla?
Here, we should go here laterally, and we should move down. This is the big fragment, this is the
So
small
there's going to be a
fragment.
gap right here.
No, just a little bit laterally. Because this is a small fragment, and after that start our area of fixations here.
Okay.
So you think we need to go more lateral for the fixation?
Yes, absolutely.
Nice. Can I get the stand retractor, please?
There's a muscle there. Is that zygomaticus major?
Could be masseter too.
Oh, yeah.
Oh yeah, let's get, can I have a knife, please? Thank you. So, maybe the hot stick's better. What's that shitty stuff?
This is start our maxilla.
So hard.
Let me see the implant. Just see how far we are.
We're not very far from
We're not.
the
Okay.
mucosa here.
Like this, right?
Yeah, with the little elevation going immediately. Ooh,
So we're just about there, right?
getting close. Oh yeah, that's nice. That nice little curve shows you where you're going, right?
Mhm.
Is that
What does this look like?
Not bad at all.
Yeah, we just gotta make a little more room for our to put our screws in. But
So, Ray, where are the screws going for the maxillary implant?
so down over here
1, 2.
and over here.
I don't see one though. Is
Yeah,
there another one?
they're more.
Oh yeah.
There.
Okay. I thought it might have been one of those where it actually hooks onto the other implant.
No.
Yeah, that looks nice. Does that ever look nice?
I think maybe we need to free up a little bit more.
Medially or
Yeah. Maybe.
inferiorly?
Medially.
Medially, like here?
Well, actually, so let me see the drill guide again. This one.
We're looking for the drill guide. Or
For this question?
which one?
I just want to confirm my orbital part, and then if that's in good position, then we can compare the maxillary part. Does that look right for the orbital drill guide here?
The drill guide on the orbital floor? For the drill guide specifically?
As long as you can go any higher up, it's in a perfect position. Because it's designed to stop exactly in the corner.
Okay,
Okay.
that's helpful.
So this goes here. Take this out. Can you grab that?
The
We got to pick up.
drill guide?
Yeah.
or- Yeah, I got it.
Okay. So it goes
Here.
here. And then this. Slide that little punch in it. A little bit more. So I think we just need just a little bit more dissection that way. Maybe.
Like on the bottom of this? here?
Yeah.
Yeah, definitely. Let's see, this is super thick, so yeah, you know what? I'll probably release some of this anyway.
We don't need that much more. We do need to get the screw in there. So.
I want to call it number 9 elevator.
Number 9, yep.
Number 9, thank you. Hey. Hey, Ray, you're going to be so happy. Check this out.
Mm-hmm. There we go. There's only one screw there immediately?
I believe.
2.
2, okay.
Oh, there's 2.
Yes.
Okay, so if you're relatively happy there's no overlap here, right? Between prostheses?
No,
They're
right,
different.
correct.
So,
So that should go right at the edge of this
got it,
one.
like. So this can come up just
Maybe
a bit.
rotate it just a little, just
Yeah.
2 degrees that way.
Take another forceps, please. Sorry.
What do you think, Tatiana?
I think that we should start with the fixing of
I
orbit,
think
and
that's a good
after
idea.
that to do the
You know what we would say in
position.
Canada? We would say it's good
Four
enough for
screw.
government work. Hear that right?
Yep.
It's good enough for government work?
Mm-hmm. Well, everything is government work in Canada, right?
Yes, that's the point. Okay, you want the 4mm screw?
Yep.
Great.
Because this is the important part, and this is less important part.
Yes,
If we lose this one,
this
we
is the
don't lose
important part,
anything. But this is a very, very important thing.
Is this your set, right?
What?
This
The screws? No.
And what kind of screw we put now? Is it a striker?
Self-drilling.
Self tapping. Yeah.
Does it look self-drilling, Dave?
What is the firm of this screw? You don't know.
I don't think this is self-drilling.
Uh-huh. Jeez.
No.
Yeah, maybe another color. Maybe the green one is self drilling. No,
You may have
because
to read on it.
the usually yellow is drilling, and another color is a
Like up
self
here.
drilling.
Those are
Silver.
rescue screws though, aren't they?
Are they?
I don't know.
Aren't the Yasker usually purple?
Mesh plates, it says, yeah, we could try a 4mm one of those.
Yeah, let's see what it looks like. I've never seen drilling and non-drilling in the same set.
No.
Have you?
We form this set by ourselves. That's why we put all screw that we have in one
Right.
picture too.
Can I hold something down? This one?
Could be.
What do you think?
It could be self drilling.
Doesn't look sharp enough.
I agree. I think it's the first one.
You can try. Why
It
not?
doesn't look self-drilling. Give it a try.
Emma?
No.
No.
I think it's the first one, but I think
I don't think either of them are self-drilling.
you just may have to really refund it.
Really?
And come back a little bit. I mean, I don't know if this is something that you use a lot. I don't.
And what about the drilling? Maybe we have a drilling machine here. У нас немає чим засверлити,
We
якщо
need
що?
a drill.
Ні,
We need a
сверлити.
drill. Yeah.
Наконечник. Ваші лоровські теж підходять.
Drill it with your hands.
This is done as self-drilling.
Okay. Okay.
They try to... you have a drill. So it's not necessary to find drilling for you.
No, we can get this to work.
Передайте, будь ласка, що знайшли дрель, що не треба.
This
Хай не
be the first
шукають.
time trying this drill though. So.
bring it across this way.
Супер.
Forward. Here, so the black thing goes with that. So the black thing. Put this down. Oh, hold on. Take your working piece.
I really want to,
Here's the other way.
I think there's a little protuberance there.
Угу.
There's some way to kind of file that down.
And go, you know, slide on it like a handle on them.
See how this is just a little
Mm.
bit up?
Yes. It's not too good. Maybe.
I mean, it's okay. It's not perfect.
Yes, it'll go in.
No, it's not good because
There you go. Nice. And then you go,
I'd like to file that down.
mm-hmm. We should remove with some.
Yeah. Do we have an osteotome? I think I saw an osteotome in your set.
Can you ask Lucy for the osteotome? Okay. Do you have it? I don't think you have it. Okay. So. Now the black. Now, move the black card in it.
Oh, you know what? Maybe this is this too low? Should this be up here?
this is the little piece, you have to pull back on the piece.
Could you show us the plan one more time?
Take it out, you have to pull back on the piece, there you go. Okay, that's good.
In the upper part of.
I need to see the medial part of the orbital implant. See where it's supposed to be resting. Can you blow up the 3D? Can you take away the implant for a second? Yeah. Okay, put it back. Let me see a prayer, please.
Yes, this is the upper part of our bone. No, it's correct.
So this should be right.
Mhm.
Okay, yeah, we were right.
Mm-hmm.
What's this little guy here?
Mm-hmm. This is the small fragment that we.
So should this go here or should it go
Well,
here?
I don't think you can put the.
We can check here.
Check the door.
Mhm.
I need a handle, something to go in. For the drill.
I don't think the bit doesn't go right in there, I don't think.
No, there's no way.
There's another,
Okay, hold on. Something
Yeah.
just open this? No, they're drill bits. Yeah. So this one, you want this one out?
Yeah. That one's fine. Yeah. Are you sure there's not a osteotome in your set, Johnny?
osteotome?
Yeah. Do you have an osteotome?
Yeah,
you have
we just saw some.
you have a mallet. Okay. You don't have one in here?
Uh,
I just don't want to use Natalia's instruments if we don't need to.
oh, right. That is an osteotome, those are osteotomes.
That's what I thought.
Yeah.
Okay, here, let's not mix. We don't need that. Don't mix it with Johnny's stuff. Where's that drill guide? The dark blue ones? Thank you.
Okay, it works.
Oh, perfect.
Got it?
Well, it works, but we still need the little housing for the, the adapter for the drill
Plan
bit.
B,
Okay?
well, I look for that, so it's the other type of, it should be the. So this
Hang on
is-
just before you do that.
I know, I'm saying if I can't find that piece, because it should have all been together. There's another set of item with them. Okay, this will be our plan B, just in case.
Yeah. Is that as far lateral and superior as it'll go?
I think that's supposed to be where it's,
Okay.
where it goes. Okay. These PSIs, they have to be positioned perfectly.
Right.
Yes. So this is the right place. Super.
Okay. So we just need to
Yeah.
remove,
put
just shave that
down.
bone down
Yes,
just a little
yes.
bit, right?
Which bone?
This,
Oh,
see how
look,
this one's
look.
sitting up a little bit?
Yep.
Just so this bone
okay.
underneath it, just
Well, we
oscillates.
should lift just a little bit
Okay.
So we don't have a drill yet, working drill.
like this.
Okay.
It's modeling with a small gap between two fragments. Or we can use also guides for the Roma if you want.
So it's not in the other package.
Okay, do you want me to give it a shot? With this self-tapping thing? Problem is,
Try.
We've probably got one chance, and if I blow it,
This
then.
big handle one, I know it's not ideal, but that other piece wasn't in the other set either.
Okay, let's give it a
It's
whirl.
good. It's just slowly will be.
Yeah, you said it was a ortho, right? Ocular ortho?
There you go.
Orofacial.
Yeah, I thought I should try to preserve that. It
Yeah.
might be his only sensation in his cheek.
Cord goes on the bottom.
I just, it's so nice.
I don't know if it's supposed to be like that or like that.
Like at first, because
Sorry,
because
like what?
when you put it down, we have a gap here. I think, like a step.
Yes.
I
That's
think it should be
why.
higher like that.
Mm. Нормально, орбітку ставимо. Тепер ще треба цей другий зафіксувати, а потім почнуть клапоть, я думаю, виділяти. Трошки проблема з тим, що нема чим засверлити. Самозасверлюючі гвинти нема. Ні, а треба крутити. І зараз придумаю, чим крутити. Ну от є, але щось до дрелі немає, до тієї дрелі щось немає. Може, якщо у вас є наконечник отакий прямий, яким носики, якщо ви пиляєте? Не п'єзопила, а наконечник просто. Maybe we can find just something to leave it here.
Because this is nice.
Mhm.
Yeah, no, there's no place.
They're
They're not, no.
No, that doesn't go like that.
That's pneumatic, isn't it? Is that electric?
Ні, нам треба наконечник. У вас є установка, і є такий наконечник, на який ви одіваєте. Да. А ну гляньте.
Also, you got that from the drill bit set? That's in there. Okay, so what size is that? You open the drill
Well, it
bit?
comes with those screws.
Correct, but what size is it? So if we could get a longer drill bit from the other drill bit set, sorry, then we could feed it down.
Ще раз доброго дня, колеги. Наступний пацієнт в першій операційній 26 червня отримав мінно-вибухову травму і осколкове проникаюче черепно-мозкове поранення, вдавлений перелом лобної ділянки справа. Була також травма м'яких тканин обличчя. Тоді в червні була проведена первинна хірургічна обробка ран. Було проведено видалення кісткових відламків в ділянці вдаленого перелому лобної кістки справа. Фотографії ви бачите пацієнта на даний час. І зараз я вас познайомлю з планом. План операції – це закриття, реконструкція дефекту лобної кістки з пацієнт-специфічним імплантом, який підготувала фірма Materialize. І буде ревізія рубця правої щоки з жировим трансплантантом. Зверніть увагу, буде робота з цим рубцем і робота з ділянкою дефекту лобної кістки. Крім того, пацієнту буде проведена септопластика. Це не пов'язано з травмою викривлення перегородки носа, але для покращення носового дихання і якості життя пацієнта буде проведено цей момент в загальній цій хірургії. Хірургічна бригада. Меттью Брейс, пластичний реконструктивний хірург з Канади, і Ягельський Євген Валентинович, отоляринголог з Києва, клініка «Нове тіло». Коментувати, напевно, цю операцію буде теж Ягельський Євген Валентинович. Дякую за увагу. Можна переключати на операційну.
Ні, нема.
Oh my goodness.
Let's check the maxillary implant before we.
Okay.
So do you still think we need to do a little shaving of bone?
Maybe with some kind of cutting for plates, it also will be good for
Okay.
for
Like plate
for
cutting?
smoothing. Yes, for smoothing this bone.
No.
No, maybe some instruments which we can cut the bone.
Rongeur?
It could be.
Oh,
It-
oh, you were
it
thinking about
could-
the osteotome, right?
Yes, yes.
We could shave it
Maybe
down a little bit.
osteotome, maybe some kind
Yeah,
of
yeah,
forceps or.
osteotome.
With osteotome, it will be difficult. Oh, maybe.
Yeah, we can use the
Easy.
We just need to take that little
Okay.
bump off.
What needs to be taken down?
This
That?
little tiny bump right
Okay. Now you, mallet?
Mhm.
Okay. Yes?
Mhm. And maybe this area.
Like that better?
Yeah, I think it's good.
Дякую. І представлю вам колеги КТ пацієнта. Це примірна реконструкція черепа. Ви бачите дефект лобної кістки. І як буде виглядати імплант. Пацієнт-специфічний імплант. Так буде виглядати імплант, який закриє дефект. І гвинти, якими буде цей імплант зафіксований. Все. Дякую за увагу.
Body of. Yeah, this is the smallest. How it should
I'll
be
take another Sam, please.
on the tip of the goma. Okay, but we have a small fragment inside this area. This small fragment is.
Ah.
Does that have to go? You have to remove that?
No, it's
okay.
not a problem.
Okay.
We should just check the position. That's why I think it will be okay for us if you know.
That looks pretty good.
No, it's not. Yes, maybe. But
want
we
me to
should
make
make
the bogey
some
hole?
marks like you.
Yeah.
I just try do it like
Yeah.
you. No, it's impossible. Але нам треба ще будуть. Ну, якщо є можливість, то да, якщо ні, то ми викрутимося.
А це дріль не
М-м.
Тобто нам треба дріль, можливо, страйкер.
Да, любе.
Це ручка для страйкера.
Да.
Just eyeball it?
Зрозумів.
Там люба ручка підходить.
Треба п'єзо. П'єзо вам не треба.
П'єзо ні. Там наконечник з п'єзо може підійти просто.
Я зрозумів. Головне, не терміну.
А, поняла. It could be like
Feels
this.
good. That looks good. Yeah, I like it. What do you think?
We have.
Maybe shave this down a little bit more?
Yeah, we have the problems here. I think that we not put on the bone in this area.
Yeah, it's on the bone.
On the bone?
So maybe shave this down a little bit more.
No. We have a problem. Not here. I think the problem is here.
Is it too? It's just a hair's breadth too lateral, is it? Or too medium? Oh, okay.
Too lateral or
I
too
think it goes
medial.
more medial, it falls off the ledge. just like
Right.
that.
Maybe the position is not right here.
Can't be too much more medial though,
Yeah,
because we won't have any
because
more
you're off the
on in my bone.
I,
You know, maybe it's rotated. Maybe it's rotated.
yes,
clockwise or
just a little bit rotated.
Yeah.
Now we,
Like that.
yeah, we
But we're off.
compensate.
There's no bone here though. Yeah, it has to be at least that far lateral.
But we should find the place here.
So
And-
maybe this orbital implant is a little
No,
too medial.
orbital it's important, most important this part, so we can ignore it. Or maybe we should replace the this part here.
That looks.
It's
really nice.
not good. Maybe
The second
here.
screw hole though is off the bone there.
It's not
I
good.
do think it has to go just a little bit more lateral.
I think we have some problem here because it's not we don't have a good smoothing when we modeling here, so this gap will be in any position.
Yes.
Mm-hmm.
Now we did take bone off there specifically.
So we should leave
I
it
think we
like
should
this.
probably.
I think that's fine. Yeah.
All right. Self-tapping screw ready? Or do you want to use the guide
We
again?
should
or-
check
we have
we should check
Well, no, I mean you.
Oh.
You drilling it.
You can do it this way. Do you think this needs to be repositioned?
No, I think we should leave it like this.
You like it?
Because I think that we should check the orbital floor and the lateral wall where we have some orientations, and in the case that it's good, we should leave it.
Ray,
I
is this
think
where
so.
you would normally do your force duction test?
Yeah. Doesn't really apply that.
No.
All right, let's fixate this.
Mm-hmm.
Okay, do you have the drill bit loaded on the driver? Yeah, you got that. Okay, great. Perfect.
I'll do this one first.
Yeah, absolutely. Amazing.
We have no bone, yes?
Yeah,
Okay.
it's kind of.
No bone.
It's yucky
This
bone.
is the wrong position. Maybe we put the guide, make the pre-drilling, and after that put our screws.
Okay.
Oh no.
That's kind
Or
of
we
what they're
should-
designed for, isn't it?
Or we checked one more time this area, maybe.
That will have to go more lateral now, won't it? Just a little bit.
Yes.
Unless-
I think in this position it will better. Maybe you try to find the
See
bone.
the drill guide?
It's in that shiny cup there, Rap.
Oh, whoa.
Thank you very much. Could you?
Emma. Busy girl. That looks more like it.
Mhm.
Yes.
That looks like something that'll accept.
Oh, we can use the guides for the nose. Will be easier for us.
Was there another guide?
Yeah, for nose for these two screws, and it also will be good for it. Yes, but we should make some mobilizations on the apertura piriformis because it's like should be like a hook here.
Those other, like this one here?
Mm-hmm.
Is this supposed to fit around the orbital implant?
Mm-hmm.
Hmm. Does this go over the rim?
No. It's called to the apertura piriformis, like a hook. Could you show us, please?
The medial drill guide. The maxillary milk.
Mm-hmm.
Oh,
That's
okay.
very helpful.
So it goes like this,
Mm-hmm.
like that.
Mm-hmm. Yes.
Thank you.
Mm-hmm.
That's great.
Mm-hmm. Yeah, super.
Okay.
That's ingenious.
Mm-hmm. It's stable. And we can do our drilling.
Okay, we have a drill?
We might.
A little more TXA?
No, I think we're okay.
А покажіть, будь ласка, отвори, в які треба сверлити. Де отвори, які?
So, do you want the drill, right?
Yeah, if you have it. Or do we have self-tapping screws?
No, it should be okay. Maybe not a good. Mm-hmm. I'll help you. Something here. Here. It's too small. Mm-hmm. Do you have the longer one? No, you don't have.
Okay, let's do this. So
Maybe another ties.
yeah,
The Ray Cho drill?
the Ray Cho drill. There we go.
It's not long enough. It's not long enough.
Now hang on, Ray.
Mm-mm.
It was better.
Huh?
Oh, I can help
No,
you.
now I do. Sorry, I didn't see it. Can we take this out?
This is not going to be long enough.
Oh, you know what? I think we just need to mark it with the hot stick, right? And then drill it on the face of the bone.
There's no other.
No, it's good.
Yeah, it's not quite right there.
That one was.
That's better.
No, it's not working in this area. We can see anything in these cases. And it's not a good position of our guide. We
You don't
still
like it?
have a big gap
Right
between
here,
the bone
yeah.
fragments. Mm-hmm. Yeah, now it's better.
Yeah, make those so you can see them a bit better.
Maybe just one. It also would be helpful.
Good. The other
Where,
one was, I don't see it
where,
now. It was way down by me here.
That's good enough.
where is our implant?
See the implant? We have the maxillary implant.
Here is it.
Okay.
Mm-hmm.
We'll go out there for a minute.
Yeah.
Mm-hmm. This one. Here.
That's not right.
So we can leave it just a little bit down and leave it like this, and it will be okay.
I think this looks good.
Yes, yes,
agree.
absolutely.
I agree.
So give us please the drilling, self-drilling guides.
Yeah, we'll take the
Screw.
driver. No, it's just, it's all right.
The
Yeah,
drill.
take the drill. And now we'll take a number 4 screw. Unless you want something different.
No, no, sounds good to me.
Give us please
Screw,
the
please.
screw.
I want to reposition this.
But the,
Okay.
Well, yeah.
Mm-hmm.
do you want us to place the screw then?
Go ahead.
Yeah.
We'll place one screw
Okay.
and then we'll
Sure.
reposition it.
It, no.
It's impossible.
Do you want longer screw or rescue screw?
I don't know because I think we have not. Maybe I try to do it here. It's failed. We should do the drilling. Maybe I try to do it.
Can you, yeah.
Maybe longer one, but no, it's impossible because we have the second cortical part.
6 millimeter screw, please.
Maybe drill a little deeper.
Yeah, yes.
We have a longer drill here, I think.
Well, I think you should. I think it almost.
No, the
fits.
problem that we don't drill the second cortical.
Yeah, yeah. But we have a longer drill. You want to use that?
Yes, yes.
Could you put the longer drill on that, please?
Дрелі нема у нас просто.
І ви не важко вкручуєте.
Да. It's impossible. I will broke your instruments if I continue to do it.
That looks good.
Yeah, you can try, but I'm not
You
sure.
want a 5 screw?
Mm-hmm.
You have a 5 screw?
No, I have 6.
Oh, okay, 6. Then.
There is no screws. It's okay. Thank you very much. Yeah, it could be.
Another 6?
Maybe,
Oh, yeah, we'll just-
maybe here we try to put
Let me
one more
reposition this one
screws.
first. Can I
But
have an empty
it's not
screwdriver?
stable, Doctor. It's not stable. It's not be comfortable for you to reposition this. Maybe we put
want
one
the
more
ones-
screws.
Okay.
Okay, we'll take the.
It's
drill
drilling.
bit.
Drilling.
Yeah, drill bit. Yeah.
The longer one. you have a hand towel?
No, we need the drilling.
The long drill bit. Yeah, just yeah. Can you, can somebody tighten my head strap just a little bit? Just a scooch. Uh-huh. Okay, that's good. Thank you.
6 millimeters screw, please. And this is here. Mm-hmm. Thank you very much.
Good.
No, it's a bad position here. Or maybe if we change this plate.
Це робити це без великого натяжіння. Така
Any
навіть все ж таки це обличчя, міміки багато, тому невелике натяжіння і дуже якісна фіксація.
So these will last about 6 weeks to 3 months under the skin, and they usually dissolve, but sometimes they don't, and the skin actually spits them out. So the patient gets a little like pimple, and then the thread pops out, and that's not unusual. And so I'm sure he won't mind, but often people worry about it, that there's something wrong or that their incision is going to open up. But it takes weeks for it to happen, and the incision is strong by then.
Від 6 до 8 місяців іде загоєння цієї ділянки і нитку тримає весь цей час.
And you don't get upset.
Вирішуємо. І дуже швидка, дуже впевнена робота від нашого канадського колеги.
Not staying on. If it does it again, let's try the 20 and I'll just.
What's happening there, Chris?
What?
What's happening there?
It's just, it's not staying on the lure lock and it's like
Oh.
moving within seconds.
Паралельно
then the second
цього
time.
пацієнта проводиться забор жиром, який буде використований в якості трансплантату для заповнення ділянок на обличчі, де у нас є втяжіння.
The first one was fine.
Okay. Can I have the 6-0 proline, please, on a fine driver? And do we have finer? Do we have? Yeah. Yeah. Needle is up. Thank you. On your hands, when you have big hands, you need small instruments to be delicate.
Oh, you got three same drivers.
Okay. I like 6-0 on the face. So very fine suture. So you need a very strong closure with the 4-0 monocryl. You can use 5-0 monocryl too, but this fine suture will make the scar
Зараз буде
Very,
використовуватися.
barely visible.
Ниточка номер 6.
Cotton to draw. Again, I like to put the knot onto the skin side, not over top. So that's going to help push the skin together in the version, which is key. And so we've been able to remove the contracted scar tissue, but now we're going to add volume with the fat.
There's two big boxes that are out there.
І доктор Мед
And we don't have a
каже,
lot of fat
що
there.
всі втягнуті ділянці будуть заповнені жировою тканиною, яку зараз вже взяли.
His skin is very weak, like it wants to tear, so I have to be very careful here. I'm assisting myself, so I'm using my left hand to retract the skin up. I do a lot of surgery by myself. Can I have a dab? I do a lot of surgery by myself, skin cancers, and so you can use your stitch to be your retractor. You want to go in the skin at 90 degrees, and when you do that, you ensure that you get good eversion. And so you can do a lot of this kind of dermatologic surgery by yourself. You don't need a nurse. It's helpful to have a nurse, but you don't need a nurse. You can be your own assistant.
Я сподіваюся, ви почули, що розповів доктор Мед. Коротко перескажу. Він каже, що він зараз сам собі асистує. Він підтягує шкіру за нитку, сам же наклав. Каже, що він виконує досить таки багато пластичних і реконструктивних операцій на шкірі самостійно. Частіше то якісь онкологічні кейси.
It's Natalia.
I'm sorry.
I don't know if she wants to.
Can you tell her you added the section?
I didn't, and I just remembered that. I don't really want to do that until she's gone into the.
Sinus.
Until she's exposed the dura and closed it. I don't really think we should get nose bacteria in the field.
Yeah.
The other thing you can do, little tricks, is use your needle as a retractor. So sometimes if it's hard to get the skin edge up, you can grab it with your needle.
Як ви побачили, іноді не дуже зручно іглою відразу попасти в потрібний шар, і тому можна використовувати голку нитки саме як ретрактор, підтягнути шкіру, перехопити делікатним пінцетом, а потім вже вколоти саме в той шар, що вам потрібно.
I try to avoid using dissolvable sutures on the skin in the face because they tend to be very inflammatory. The scars are very red, and the patients don't like them. But the exception would be somebody who you don't think you'll see back in follow-up. So somebody that's unreliable to come to have them removed. And so we sometimes use them, like in homeless people or other people that might be transient and not going to be reliable to come back. Yeah.
Доктор Мед каже, що він не любить використовувати нитки, що розсмоктуються, коли йде робота на обличчі. Він каже, що ці нитки можуть давати досить таки стійке запалення, і вони роблять це в виключених випадках, частіше до тих пацієнтів, які навряд чи прийдуть до вас повторно. Наприклад, хто знаходиться в вашому місті приїздом, або, як він сказав, homeless, люди без даху над головою. Він намагається завжди заховати голочку, коли намагається віддати медсестрі.
I didn't have that fast. I'm using a microblade.
That's fine. That's fine. So I can I can do the fat whenever the fat is ready. But if the fat's not ready, it's separating. Hindi sauce nga to cut. So, if Natalia, I don't know if she wants me to start this or if she wants to do it. So,
Зараз до нас буде приєднуватись Наталя Військо, хірург з Сполучених Штатів Америки. І вона займається її особливо вузька специфіка. Вона гарно працює з переломами кісток.
so if you want to mark the lines so that the lines aren't mismatched after. So that's what those markings are.
Враховуючи, що у нас є великий дефект, от нам потрібно буде зробити гарну ревізію всіх ділянок. І вона зараз приєднається до нас.
That looks good. There's no tension. It's not going to pull the eyelid down because it's vertical. But I think if we add volume into this area that I marked and underneath the scar, it will help. Fat, I was saying before, fat is predictably unpredictable and reliably unreliable, meaning you can't be sure that it will all survive. So you often have to put more than you think. If I think I might need 3 or 4 cc's here, I should probably put 10 to 15 cc's because it will absorb.
Звичайно, жир, який вводиться в якості трансплантату, дуже сильно може розсмоктуватися самостійно, і тому потрібно зробити з гарним запасом. Якщо на цій ділянці 3 or 5 we need, нам потрібно 3 чи 5 мл, то доктор Мед буде вводити 5, щоб залишилось. Доктор Мед буде вводити 7 або 10 зараз.
There's a technique called FAMI, F-A-M-I, fat adjacent to muscle injection. And what that describes is that if you put fat grafting in near muscle, it has the highest chance of taking because of the blood supply in the muscle. So in the face, we want to go deep and probably even almost on super periosteal under the muscle, and then we want to go on top of the muscle and layer it so it's not just one big blob, but we want to put it in multiple layers. So I'm going to try to go super periosteal above the muscle and then in the deep dermis.
І намагатися вводити краще в різні слої, щоб зменшити резорбцію. Майже над кістям, під м'язом і потім вже під деревом. Щоб зробити не один запах жиру, а декілька шарів, декілька зон.
Chris, the only thing I forgot to put up was a needle to introduce the cannula. So like a 20 gauge.
I've got 22s up.
Do you have 22s up?
Yeah, I made
Okay,
lots. They
awesome.
come with the 10 cc, so I just.
Perfect. Perfect. So they're just washing the fat now. So when you aspirate the fat, you have your tumescent, which was lidocaine and saline, and epinephrine. So that will be in the what's suctioned out, and then you have all the disrupted fat cells, so the oil, and then you have the intact fat cells. Chris, can you pass me the cannula?
So this is a micronizer
So
for fat. So
that's
basically
infiltrated.
we'll take the fat.
Okay, so this is the infiltrator. Show it on.
And help.
This is the infiltrator. So these edges are not sharp; they're just round. And this is what you put the lidocaine on. So you put it into the abdomen in the subcutaneous plane, and you inject, and it infiltrates the lidocaine. And then this one, the different one, is a Sorensen micro fat harvester. So you can see the edges are beveled, they're sharp. So when this passes through the subdermis and you're suctioning, it's actually cutting the fat, like sucking tiny pieces of fat into the syringe. So what we want is micro fat, not big blobs, because the big blobs won't survive, and if they do survive, they'll look like nodules. So you have very, very fine fat. You can then process micro fat through filter and make nano fat, but that's mostly disrupted fat cells and just growth factors. So a lot of people use nano fat for the growth factors in the skin, but this is just a micro fat harvester. You can see the beveled edge.
Гострі краї, які зрізають
Different than the infiltrator, which is just round.
один для інфільтрації, І другий з більшою кількістю дирочок саме для
Nothing creepy about this.
забору жиру.
Nice. Yeah. We don't have everything we would normally have at home.
No. So you can spin the fat in a centrifuge and separate the oils and the liquid and the stem cells from the actual fat cells. The more you spin the fat and the faster you spin it, the more you kill. So you'll get a pure sample but less viable fat. If you decant it and let it sit in the room and separate with gravity, it takes a long time, like an hour and a half. You get more cells, but it's less clean. So you get more oil, which can be inflammatory. So it's a balance. So I actually published a research paper on what's the best. Gives you the most cells, but the cleanest.
Some nice
And it's spinning it for 2 minutes at 3,000 gravity. So not more than 2 minutes and not more than 3,000 G.
Доктор Мет розповів, що він проводив роботу дослідницьку щодо жирового трансплантації. І що їх проводити в центрифузі. Звичайно, це відомий факт, але він знов-таки нагадує, що чим сильніше ми будемо працювати, чим інтенсивніше ми будемо крутити в центрифузі, то менше у нас будуть живих клітин.
Then we're going to use the small fat transfer cannula. It's an 18. I'll take that. This one, it's called a tulip set. Tulip, like the flower.
Just the company name.
Yeah.
They
Which you
make.
can buy online. Another.
So now we have the fat and the 1 cc syringe and a cannula. The port is on the side. So the worry with filler and with fat is if you were to stick this in and get into the artery and then push fat into the artery, you would block it and could cause blindness and cause necrosis. So that's why the hole is not at the tip, but it's at the side. So if you pushed into an artery,
How pretty that
it's
is.
injecting behind the end of it, so it makes it safer. So I'm
Знов таки пам'ятаємо про углову артерію, що там проходить. Саме тому на цій канюлі збоку отвір, щоб, а не на кінці, щоб не пошкоджити артерію.
The oils from the fat.
Досить таки глибоко.
So we're going to do fat adjacent to
Yes.
So when I
feel for the
introduce
maxilla
the
here,
filter into
go
these,
down
I'm
onto
going
the
to
bone.
stop because you don't
Йдемо
want
по
that
кістці.
I go very deep here. Infraorbital nerve is here. We're going to be away from the infraorbital nerve.
І подалі від нерву.
And I'm on the bones
You
and feel
don't
that.
want that.
Feel? You can feel if you want on feel. Push and you feel bone.
Yes, yes, yes.
Oh, where's Natalia? Perfect timing. So I'm going deep, and you want to do small
So,
amounts,
Natalia,
very small amounts.
just to prep you, Matt's on a septoplasty for this case.
You can do it, Natalia. His septum's off to the left, and he is having his obstruction. Unless you don't want to do it. I didn't want to do anything in his nose until you finished exposing to us. So, yeah. If you wanted to finish, that was the plan. Yeah, I think just separate the osteocartilaginous junction and remove maybe a little bit, but I don't think you're gonna have to do much. No, it's just a deviated septum. So, like I said, it's not predictable and or reliable, so you need much more fat than you think. So I'm still deep. I'm supra-periosteal. And I'm going to add just 2 syringes, which is 2 cc's of fat, deep, and then we're going to come a little bit more superficial. And I'm just pushing with my finger. I don't know if you can see, but I'm pushing my finger on the plunger very lightly. You don't want to put a whole bunch of fat in very quickly.
Дуже обережно, дуже повільно вводимо жир в ці ділянки.
The analogy that I like best is imagine that you had your front yard, your garden, and you want to plant grass, you don't dump the grass in piles, but you spread it very, very thin everywhere to allow it to grow, and that's the same with that.
Аналогія з підсадкою жирової тканини – це як робота з газоном на вашому задньому дворі. Якщо ви хочете, щоб мати гарний газон, ви повинні дуже рівномірно насипати смолу. Приблизно так, рівномірно заводимо жир.
So we're aiming for 9 cc.
Somewhere around there, 8 or 9, yeah. These are just swell up here. That's not fat, that's just swelling. We're using 1 cc lure lock because it has to screw in. If you have a slip tip, it will just pop off. So.
Використовуємо інсуліновий шприц, 1 кубічний
I'm going to use a different vector from that second hole just
сантиметр, and
so that I can kind of cross hatch.
дуже обережно і ніжно намагаємось працювати.
And these are all blunt, so you don't have to worry about hurting the nerves. It's like being sharp.
Ножиці.
Okay. Give me, Lucy, sorry, can I have 4 1 cc syringes, please? Hey, Nana. Yeah, the light. I've got 3 in here.
Is that 4 enough?
That was 3.
That was 3. This is 4.
4. Say cheese.
You can't tell I'm smiling, but I am.
3 мл жиру введено. Продовжуємо.
For cosmetic reasons, you can do this for somebody with an aging face. They're losing volume, tear troughs, hollowing around the eye. So I do this mostly at home in Canada for men and women who feel like their eyelids look too old, too tired. You can add volume back. You can correct dark circles under the eyes.
Дуже часто доктор Мет використовує іпофілінг саме для корекції втомлених глаз, мішків під очима.
So that's
It might be good with one more, Chris.
so you're on 5.
Maybe 6.
That's 6 in his hand.
This is 6 in my hand, so
No, 6 in this
Okay.
gentleman's hand. And then I've got 0.4. So is that enough?
yeah.
Okay. Jackie, we're good. Good. Don't get rid of it.
Natalia, do you want to scrub it?
Are you ready?
I'm ready.
Okay.
Yeah. You have to be careful you don't come through your incision. So I'm putting my finger here so I can feel how deep I am, and I'm not going to pop through the incision I just closed. So I'm getting very deep to it. The tip is in the layer below the scar.
Just a small, I need to bigger, yeah, what do you want? Like, it's so tiny.
That's very straight. That's fine. Yeah.
I have one that comes in the
You
back.
guys have any
We have
questions?
four in the door.
Can you cut me like just enough to cover this? Like I mean,
Does America?
It's just swelling, not fat, 'cause I never went up here.
Це не жир,
How swollen it's
бачите,
getting.
це набряк.
Ready for it?
that's it.
And I can get that back, Jackie. And those are done if you wanted to reprocess them. I don't know when the next bag got here.
So you are done with that grafting.
Which, sorry? Layer, yeah, multiple. So we have skin, fat, mass, muscle, periosteum, bone. We are on the periosteum, and then there's muscle on top of the periosteum. So we're under the muscle in between, and then we're on top of the muscle, and then we're in the mass and subcutaneous layer. So I did 3 different layers, fat and 3 layers to build it. You want to put the fat adjacent to muscle. That's where it works best. If you just put fat freely, it will mostly resorb and go away. But muscle has such a good blood supply that you'll retain as much as possible. In the literature, it says you'll retain 10 to 90%. It's very unpredictable. But I usually count on half going away, 50% going away. So you have to overfill, expect you'll lose half, and then you'll get the result. So that's giving him some nice volume in his cheek. Go down to half of that, and you should have the scar is much thinner, and it should be lifted up and volumized. But to know what
Доктор Мат
layer you're on,
розповідає, що
I pushed the
він
cannula.
зазвичай вводить
The cannula
десь на
is not sharp,
50%
so it can't go
більше.
through the periosteum, it should go on it. And when you're on periosteum, we were underneath the muscle.
На
Then I
50%
come out a little bit and
ніж
lift up
хочеш,
and
щоб
go
він
again. So I
настільки
can
його
feel the bone underneath me, but it doesn't feel like I'm scraping, but I know I'm on top of the muscles. And then I come deep under the skin, not so you can see the cannula right under the skin, but a little bit deeper where you can't see it but can feel it. And that's in the SMAS. Do you know the SMAS?
We say dummies never.
Superficial musculoaponeurotic system. And so that's what connects the muscles to the skin. And so that's what we use in facelifts. So if you made an incision and pulled the skin, it's a very tough layer that if you pull, it's like a appendix mass. If you cut through that, there's no blood vessels. It's avascular. It's a beautiful plane that you can lift up and pull to raise the face up for a facelift. You sew that down and then take the skin away. In a facelift, you never want to just pull the skin because it will make the person look funny. But if you pull the SMAS, it will lift the muscles. It will lift the platysma. The SMAS is the platysma. Platysma in the neck comes up and becomes the SMAS. It has some muscle fibers, some ligaments, some tendons. And it's very tough, like muscle. And it's a great plane for injecting into, and a great plane for lifting the face in. So that's what we did there. Dr. Biscup, no problem. Dr. Biscup's going to do this incision, reflect this down, and put the plate in here.
This one reminds me of the amateur where when you go like. Yeah, that's what we do. It's a nice
Any other questions?
Well, everything was brilliant.
I have some good pictures I can show you of this SMAS. Yeah. I have them on my phone. I'll show you one. Natalia? And then, so here you can see the donor site, very tiny little site to get it from. Every time I do this for a woman, they always say, take more than you need. But we usually take 40 or 60 cc's of that. This will be very bruised. This will be very sore tomorrow. So he'll feel probably more pain here than in his face. This This is much more painful. Yeah, even though it's very small incision, it's very, very tender after.
Дуже болюче, дуже сильно головне. І ще хороші жінки, коли приходять, вони просять забрати більше, ніж треба.
Often we'll put an ace bandage, an elastic bandage, on the belly to kind of keep it tight, and that helps prevent bruising. And it usually feels better. Patients like it when it's nice and snug. It feels like a hug, and it holds it, and it supports their belly so when they move, it's not tightening. But you don't have to do that. Where's the oh, there she is. You have lots of help here, so I think I could probably go somewhere else unless you want me. I marked his forehead. Because he's got a little bit of like surgery, so yeah. And then I didn't know.
Try to stay here and here.
Yeah. Did you see the CT?
Yes.
Yeah. Okay. Yeah, it's kind of weird, kind of off center, but I marked the edges.
Perfect.
Bryce,
Yeah.
can you say how long time is this bandage for patient?
Sorry, how long
I'm sorry to interrupt. Have you timed out for this procedure?
have we timed out?
Yeah.
Yeah.
Okay.
Sorry, what was the question?
Take a knife,
How
please.
long time?
You have that Colorado
First
tip.
time,
That's the collar tip is in there. You want that or do you want the knife?
for
I
patient.
need a knife first, but then
2-3
you have the
days.
Colorado tip
But a lot of people will wear it longer
What
because
setting
it feels
for
good, but they don't
pottery?
have to.
Pardon? What settings on the pottery?
The settings on the cutter machine.
Napkin, please.
Sorry?
Napkin. Sponge. Okay, thanks. Thanks.
Is that a brown specific? Okay, then.
Добрий день. Рада вас бачити, пані.
Yeah, I'm going to show you the picture of his mouth.
Як вам цікаво?
Так. Добре, цікаво. Сиділи б в іншому місці.
Так, тут в нього розширений шрам, то ми, так як ми мусимо тут і так робити incision,
Розріз.
розріз, то ми зразу вирізаємо шрам.
I can send it. Yes.
В таких ситуаціях дуже важливо думати про blood supply
Контроль
цієї
кровотечі.
шкіри. Наприклад, він має дуже багато всяких різних ранок у цілому лиці, але вони досить вже розвинуті, і як шрам вже трохи старший, можна різати і не переживати, що ця частина шкіри помре. This back, I'll take a double hook.
But you can remember. Double skin, the place that you brought in?
Do you have a baby?
Yes.
I'll take the baby in the. Do we have one in the room? I'll take a pickup with teeth. Я їм казала раніше, я як торкати шкіру, я люблю використовувати skin hooks, тому що я думаю, що це найменш травматично. Так що я навіть стараюся дуже сильно не тиснути шкіру.
Не травмувати краї.
Так, не хочу травмувати краї. We'll probably need another one like this.
You have another one like that? I don't think so.
Right, but specimen. Not specimen, but
That's garbage.
yeah. Foreign body.
Він якраз про нього і казав, що він не проти.
Коли приходиться ближче до волосся, я стараюся тільки різати ножем, тому що якщо дуже сильно різати клатери, волосся вмирає тоді, і тоді ширший шрам і гірший скарб. Волосся тоді не росте.
Пані Наталі,
Так
ви не
що
будете
воно-
проти одягнути мікрофон? Щоб, якщо ви не будете проти. Або я можу ретранслювати все, намагатись.
Але може ретранслюйте, тому що я не знаю, як я не саджу його, тому що я вже
А
не
там
хочу
он...
затримувати операцію.
Like a couple times
Yes.
a month?
And that has the PSI
usually
for
for
you.
cosmetics,
Okay.
He's working
for
on the
dark,
screws and the system of
really high.
anesthesia to have everything to that.
Okay,
So just
great,
keeping
thank
you
you.
abreast.
Так як ми вже трошки глибше, далі від коріння волосся, from the follicle, тепер я можу використовувати cautery.
Find another Turel.
And what's our cautery set out again? I'm sorry.
Монополяр.
Platysma in the neck, and then in the face,
Go up to 30, please.
and then becomes temporal
30.
parietal fascia. In the face, so it's on top of the muscles, but
На 30.
under the
Так
skin.
як я
Виставляємо
буду
So
монополяр.
it's an important picture that the different layers of the face: skin, fat, mass, muscles.
я раніше чи пізніше мушу робити dissection прямо на кістці. Але поки що, поки я стараюся трохи лишати like vascularized tissue, in case there's a separation or a healing problem, that I won't have bone and skull exposed.
Для кращого загоєння ми будемо намагатись пізніше
In the face, the fat crashed, we were here.
забирати, відкривати кістку,
Onto
щоб
bone,
вона
under the
досить
muscle,
вкрита
and then on top of the muscle.
So now that
тканиною.
we're under the scar, then we can actually make an incision in the periosteum.
І от зараз вже можна робити.
Do we have another double hook?
There's a big,
I'll take a big one, yeah.
It's in a basic plastic set,
Sure.
it's the only one. And I have
Are
a
we
skin
gonna-
hook, will this sharp
Yeah,
skin
that'll
hook,
work.
that'll work?
Цих два можете ставити. Два на
I have
цей.
I
Я
have
можу
second skin hook
отак
as well.
спробувати тримати.
There's a race.
Камера. Буде камеру заважати.
Камеру ми не заважаємо, камера у нас отут.
Хтось сидить?
Я переходжу.
There's a finger rake.
Doзвольте.
You want a finger rake?
Дозвольте.
No, I have a race. I'm good.
You good? Okay.
Yep.
Picture. So then we talked about the last game, layers of the scalp, skin, subcutaneous tissues, and galea, which is the same.
Євгенець, шторці, покличте, будь ласка, налаштувати камеру.
Так, так,
And
так.
you cut through scalp, and you cut down through skin and fat.
So there's layers to the
Galea,
scalp.
then there's no blood supply.
The first layer is skin. After that, we have subcutaneous tissue. And then we have galea, which is the straight layer. Then there's a loose aponeurotic tissue, and then there's periosteum. And so the space between the galea and the periosteum is very avascular and a very nice quick plane because it dissects really easily. Very nice plane to dissect in. Unfortunately, for bony defects, we have to be right on the bone.
Якщо можна екзоскоп задвинути трішечки, да, от так от його поставити, щоб він якось
Jack, you
тут
got
вже
a
був.
reader now?
Yes.
Є.
Old books? I can bring my
Так,
computer
треба трошки
tomorrow.
обережно, як ми тягнемо, тому що в нього шкіра. І,
дефект.
ну, the scalp, and then right on top, right on the bottom is dura. So we have to be careful. Not violate.
Тому що зараз, коли вони відсепарують, вже буде все це.
A lot of these pictures are
Все, оце от зараз.
So a lot of scar tissue here. And I'm going to actually kind of dissect between those two. Get the knife again. Я трошки далі потягну свою.
А, ви маєте на увазі там, де вони зараз ріжуть, туди походу.
You can go and look. I can show you later.
Зараз краще.
То потім від вас кликає. Воно, в принципі, по
Cautery
всьому
again?
полю.
So the cadaver, the galea, is here, your scalp. So you can see what Natalia did. She's going to go through all those layers to get down into that layer to so they lift it.
Ця частина тут, напевно, найважча частина операції розділити шкіру від дюра. Тому що, ну я вже до тебе говорила за це, є риск, що можна поранити дюра. Sharon, сиди. Can we drop the cautery now to 15-15? Let's take cautery.
Ставимо монополяр на 15.
Я люблю, як мені тримають, я люблю так от вверх тримати.
Окей.
І це дозволяє мені, it protects the skin, so I don't go through the skin. And it helps me to know my plane and where I am.
And so, you know, if I have to err on the side of leaving a little bit of periosteum down, I'm going to err on the side of doing that because the last thing I want to do is violate the dura.
She's trying to lower for you. You just gotta.
Як буде dura по-українськи?
You're good.
Дуже довге слово.
Я не запам'ятаю. Так що ми тут помаленьку. Так як це критичніша частина операції. Розділяємося. Я стараюся бути досить високо, щоб не поранити знову. Отак.
Отак, так.
І це знову, бачите, захищає шкіру. Я трохи навіть тягну ззаду, так от, щоб шкіра віддалювалася, бо я також шкіру не хочу поранити. Я знаю, що він тут далі має шрам, і там шраму можливо буде ще більше і ще тяжче розділити. Jackie, do we have the PSI in here?
I do have the PSI if you're gonna leave it up there. Do you wanna see it or?
No, I just want to make sure it's in the room.
Let's see what's underneath. Yeah, that should be, that's the other side. There's material.
Я переважно, ну, як роблю такі операції, де близько до джура, я все перевіряю, щоб неврохірург був available. Так що я поговорила з Наталією Хомашко. Вона сказала мені, що у вас дуже добрий неврохірург. Це правда?
Так.
Часто це досить рідкість. Знайти доброго неврохірурга. Я використовую його ту рубець, що він вже мав. Yes.
You know you want the level 1 for the KLS, 1.5, or the 2.0?
1.5.
Можна протерти маніпулятор. Мені перехватитись нижче.
Просто я могла бачити. Я сама рукою просто підвищую. Це мені допомагає знати точно, де я є. А чоботарьому це
Він буде, але він не буде.
напевно важко.
А ви перегородками зробили вже, Євгена?
Ні, ми будемо робити вже
Це саме останнє, тому
найостанніше.
що воно дуже брудне. То ми хочемо цю дуже важливу стерильну. Sterile. What's sterile?
Перегородка рахується стериля, перегородка брудна
Чисто.
рахується, напевно?
Так.
Вона ж в носі.
Носі, так що.
А ви просто по рубцю тут пішли, так?
Так.
Розріз.
Як є нагода і є шрам, треба його використовувати.
Угу.
Я також мацаю пальцем, щоб знати, де знову починається кістка. І ну, причина, чому ми вирішили покласти сюди titanium, це є досить, it's like a critical defect, so it's large enough to where if something hits him, it could actually, you know, damage the brain. And so this is mainly done for, even though he doesn't have a contour irregularity, it's mainly done for brain protection.
І враховуючи,
Що
що
Ага,
дефект
точно.
досить таки великий, а було вирішено встановити титанову пластинку пацієнту, щоб вдруг у житті він не вдарився, не пошкоджив ділянку.
Переважно, якщо дефект більший за 2 см, тоді його треба накрити.
Ага, таке правило, так?
Так.
Власне, дефект значно більше. Можемо протерти монополяр.
Що?
Протерти каутер. Ось.
Do we have like a Army Navy?
There's not one here, I can get us one, I know they are outside, but go ahead.
Ну, тут от теж якісь. Але я не хочу витягувати, тому що я не хочу йому дірку робити в небажаному місці. Що можете тут тримати, будь ласка? Далі ми можемо просто перерізати, бо тут кістка. Я можу прямо на кісі робити.
А мазур поступила вже.
І нам треба достатньо місця, щоб ми могли покласти нашу імпланту і також screws, шурупки. All right, Jackie, I'm ready for the implant. Yep.
Наталя, а завжди в лупах оперуєш?
Що?
В лупах завжди оперуєш?
Так, переважно. Мені так, як пластичний хірург, в лупах тяжко деколи, тому що ми мусимо бачити деталі, але також ми мусимо бачити, як все виглядає повністю. Так що я часто дивлюся через лупи, тоді дивлюся просто так. Як добре світло, то вам не легше туди назад йти, але...
Чого?
Alright, we ready? Ready. Так що імплант, він має сам свій контур. Я повертаю, поки контур
не ляже.
Правильно не ляже. Бачите, як воно гарно
А може
лягає?
Настю покликати сюди з матеріалайза, чи не треба?
Ідеально,
Ідеально,
так,
так.
воно
У нас
просто
точно
не
такий
лягає.
білець. У нас точно такий
Так що
білець
я
був.
повертаю, поки воно гарно не вляже. І тоді ти знаєш точно,
О, треба фото. Можна
де
фото
воно має.
зробити?
Хочете помацати, як воно полягло?
Так, покличте Настю. Можете покликати?
Take a script.
Настю з
You want the
матеріалайза.
1.5?
Yes.
Анастасія матеріалайз. Ідіть покличте. Я зараз іду
Дальше,
сторони.
трошки дальше.
Ану без світла,
Найгірше,
Наталя, ану
якщо
без світла. Не світіть. Вау.
Імплант виготовлений особисто під цього пацієнта, тобто тут вираховані будь-які кути, щоб імплант ліг максимально на своє місце співпав.
Я би сказала, що імпланти на skull, like custom implants, are not as necessary because it's a pretty simple contour. It's just straight. And so I think that's how we have it. Right? That looks like how? Yes. So, perfect. Yeah.
One more
It fits
sponge,
amazing.
please. One more sponge.
So as I was saying, it's a pretty straight contour, and so it's pretty easy to just take a titanium mesh and bend it and contour it to the skull. It takes a little bit more time because you have to bend and you have to make sure nothing is sticking up, because in this area of the forehead, even screws and small plates can become very visible. But if PSIs aren't available with titanium mesh, it's okay. So there's different types of implants that could be used for cranioplasty. Titanium is one of them. Another common one is called P. It's a porous polyethylene type of product. And it can also be custom fabricated to the particular size of the defect. I personally really like titanium products because titanium is very, not very porous. There's hardly any pores. And so it doesn't seed with bacteria as much. And so in patients that, let's say, have an infected cranial implant from a peak or something like that, which has a higher infection rate, sometimes to protect the brain. What's that?
It's just getting me at the end, there's no...
Можете розслабитися, щоб шкіра трохи
You know what size screw?
Відпочила.
Тобто інфікування ризик дуже
А
великий.
який розмір широких?
На титані менше.
Який розмір широкий?
Всі п'ясаті, нижній з правого боку 4, так? Довжина, так. Це 1.5, так?
1.5.
Так, так що в ситуації при інфекції
Фотографуйте ще нас. Тарас Григорович,
власне
фотографуйте нас.
титаніум.
Make a photo, please.
Дайте фото. Або йдіть до нас, попросіть колегу сфотографувати. Йдіть до нас.
So I don't know if I should start any.
І ще раз.
Нема.
Але йдіть до нас. Дайте колезі телефон і йдіть до нас.
That seems like a very large drill bit. You need a smaller one. You need a 1.5.
Перепрошую, Наталі, дивіться.
Are you drilling? Just screwing this and self-tapping screws, no power.
This is a full
Because like I don't really need the drill, otherwise, I will see if I get the power for it.
1, 2, 3 should be 5 millimeter length, and this one should be 4 millimeter length.
Oh, that's, is that a PSI?
Jackie, if we could, let me just try with one of the ones.
I don't need that handle for it, it's not fitting on here. She's still trying to find me a handle, sorry.
Давайте.
Так, ми вирівняємося.
Так, давайте, щоб всіх було видно. Так, дивіться сюди.
I'm just talking
На
what we should do.
телефон.
Last cases there we know. Yeah. Okay.
Дякую.
The second case is there.
Так, так що і дуже дивиться, де шрами на старайся використовувати шрам. Але я би не хотіла тут прямо робити шрам, тому що тоді тут зразу над мозком. І я хотіла трошки місця, щоб знайти правильний плейн, в якому я хочу розділити шри. Те, що тут шрам трошки мене тривожить, але я бачу, що як я подивлюся на шкіру, то в неї тут добре кров тече. То я знаю, що це напевно добре зараз. І так як я тут закрию, навіть якщо б тут відкрилося, я не думаю, що це станеться, але замість того, що голої кістки, тут є гарний васкулірований тисю.
Впевнений.
Start this thing on one.
How are we doing, Jack?
They had to open 2 in one of the other rooms or something, they were having a bunch of issues with power.
So no power.
Well, they're working on it. I don't know where they're
If
at
I
yet,
can just
nobody's
get
been
a
back.
screwdriver and a blade that fits, we could try just tapping it in. Шурупки можуть бути такі, що вони самі роблять гурток, і також можуть бути такі, що треба дрил. Я люблю дрил, більше в твердих кістках, так як
Щоб було менше
щоб
потріскування.
менше треба було тиснути, і набагато легше ставиться, і мені легше. Не треба так сильно мучитись. І набагато скорше йде.
Є і саморізи.
Так, так, ми говорили, so self-drilling and self-tapping screws will be able to make their own hole.
То краще.
Мені більше
Спокійніше і надійніше це зробити невеличкий отвір, а потім закрутитись. Ніж відразу саморіз заходить і
дрил
може
зробити
тріснути.
дзюрку,
Да.
тоді в дрил покласти широко.
Це безпечніше, так?
Так, легше, скорше, легкіше. Я думаю, менш травматичний кіс. Але так, так як тут тільки 4 зробити, то набагато легше буває і інші ситуації, де нам треба багато цього робити. Дрил набагато скорше збирати.
Передачі вам. Ні, бо там дійсно мало, там помінялося вже підкреслення вже багато.
Зараз щось йде в інше операційне.
Так, там завершено.
Продовжує. Продовжується.
Так, так.
Поки у нас технічна пауза, може є сенс переключитись туди.
Добре, я це останнє назад, ми чекаємо, може вас щось не вчути. Наприклад, якщо б ми робили це передати, frontal sinus
Can you?
granulation навколо flap апендицити. Тоді я світло показую sinus, щоб я могла бачити точно, де sinus. Я
Drill.
ні, не скрую, просто ручкою I mark where the sinus is at. And then at that point, I'll take a reciprocating saw and I'll remove the anterior table. So I'll make a cut going across here, here, and across the top. When you're making that cut on the anterior table, it's really important that your reciprocating saw is oblique and not angled like this, because we all know what's back there. So you want to just kind of skive and cut that whole edge at an oblique angle. Then you remove that anterior table. On the inside, there's obviously a lot of sinus mucosa, so I'll usually take like a Frigidaire or a Tourette. They take the sinus mucosa out completely from both the front and the back of the sinus. There will oftentimes be an anterior septation right in the middle of the frontal sinus. I'll also remove that. I'll save that
And the
piece of
one
bone.
sinus, if you
I'll make one sinus.
one sinus, yes.
The less bone that's inside the sinus, the less sinus mucosa, and the less risk of infection and mucosal formation. And so I'll remove that central piece, but I'll save the bone. Then we'll take a burr and we'll burr the anterior and posterior table just to remove the inner 1 millimeter of that bone, so that if there's any tiny little mucosa pieces that are impregnated in the bone, it removes them, again, to prevent mucosal formation. And then those little pieces of bone that I took from the septa, I'll find the frontonasal outflow tract and I'll put the bone in the frontonasal outflow tract.
So,
Like I'll make a
close,
piece
so close,
to close it.
by bone, you close by
On
bone.
bone.
By bone. And
With
remove
bone.
mucosa, remove bone, and close this.
And then I'll typically take that, I will harvest a pericranial flap at the same time. And then I'll tuck that into the sinus.
Pericranial flap.
Right. The
From
reason
the-
I like
from
Brakes have been pumped.
through the coronal incision.
the-
And it's usually a flap that's very big because you want it to fit and stuff the frontal sinus with tissue. I like pericranium because it's well vascularized, it has a good blood supply. I don't like to use any foreign bodies because your risk of infection, the nose being dirty, is very high. And I honestly don't like to use fat because I think it all goes away. There's no blood supply to it, so it'll be there for a little
Goes
bit,
away.
but then it'll all go away and die, and there'll be nothing in the sinus. And so I really, I don't think there's, in my mind, and there's differing opinions, any other option but to put pericranium in there. And even more important when you have a frontal sinus fracture that involves the posterior table. In that case, you're really trying to protect the brain.
Switch
So
off.
laying
Let's switch
device tissue to cover the dura, right on top, right under the dura, is really important to block the contamination from inside the sinus.
And if you have, якщо є задня стінка, if you have a fracture of the posterior wall, you also have the same strategy?
It's a little bit different. So those cases I'll do with neurosurgery, and they'll do like a small frontal craniotomy to be able to remove the entire frontal sinus, both the anterior and posterior tables. That way they don't have to worry about injuring the brain by just removing that posterior table. Otherwise, if they're taking it out with a rupture, they can very easily hit the brain. When they do the craniotomy, they're able to protect it very well. And so we'll remove the whole thing, and then on the back table, I'll take off the posterior table and just remove the mucosa off the anterior table, drill, same thing as the obliteration. How are we doing?
We're trying to find it could be all of our symptoms, we've got screws, not.
We got Synthes screws too. Why don't we get the Synthes screws and the Synthes blades? And that's the 2.7 millimeter set.
This is 1.5, this is 2.5.
Oh, okay. Gotcha. I say we just open up the Synthes if we have the Synthes blade.
Can we put a sponge with saline to cover it
Yeah.
while we're waiting?
And then
Can we ask a little saline on the sponge? Saline on the sponge, yes. And to cover.
I know, in hard bone, like the skull.
Oh,
just
sterile.
like, pardon?
Okay,
This
I
is
can.
sterile.
Oh,
Oh yeah, that's all sterile.
okay, thanks.
So I'm gonna try to just do it myself, with my method. But, yeah.
I see.
But right now, we can't find the screws, we can't find the screwdriver, can't find it.
Як вони перейдення була? Ви можете, Наталя, можете нам показати на завтра будете операцію?
На завтра, так?
На завтра Рижко, ото ми чекаємо.
Можна ще питання стосовно розрізу? Тут пішли по
Рубцю, перед тим.
А як розріз правильно?
тому що є деякі хірурги, які подобаються такі
Такі зад.
Так що, як я роблю операцію, скажімо, дитині, як вона має cranial synostosis, я роблю дуже такий легенький зигзаг, так як хвиля. І це допомагає заховати шрам, тому що волосся росте так от, і воно накриває тоді шрам, по боках волосся падає, так що якщо шрам йде в таку сторону, волосся падає на нього. Якщо шрам пішов так от, волосся падає, і тоді шрам видно більше. Шрам закривається, якщо так робити. Декотрі люди роблять по боках curves і зверху просто прямо. Бо волосся і так росте, а по боках це важливо робити. Але я не люблю зигзаг, тому що the blood supply to the very tip of the triangle is a lot less than if you make a smooth curvature. And it's really, not necessary to do a lot of zigzags because it takes a lot of time to close. So I just usually do soft zigzags. So if I were to make one here, it would be like that, like big zigzags. Or
Big waves.
Big waves.
Завтра, Наталя, ти йдеш на цю coronal incision? Важка операція, там і фронтуса, і ендоскопія. Там
Все на світі.
Все на світі.
І ринопластика, і
треба підготувати нам побути.
Вибачте, якраз це відростає. Там тільки спина.
також клас накрити, щоб вона просто не лизала так.
Good, good. You took that little piece of rib, and there was a very small hole in the lining over top of the lung, and so I repaired it. So it might feel like it's hard to breathe, but if you're feeling good,
Far away.
yeah. We took that rib, gave you a nice little
Саме глибину розміру, то максимально зразу треба йти, щоб під ріст волосся.
Так що я тут ножем ріжу. Я ріжу ножем, поки я набагато нижче.
Цибулини.
I need a 5mm screw. Okay. I need the implant too. It's laying underneath the ring.
Here's it. We put it here.
Okay.
Yeah. Sorry.
Ми говорили, що цей імплант він має в собі натуральні зроблені контури, що допомагає змістити правильно сам імплант.
Put them in. Okay, so you're gonna have bruises, pains, cast on for 1 week. Okay,
Take another
looks really good.
Plan.
another 5 years.
Really good. Has proper projection and proper.
We have some irrigation after this, after we put the screws in.
Вам краще на кістку, на період.
На кістку.
Тобто період краще зняти.
Так. Але там, де ми йшли
My pleasure.
on top of the dura, I left a little bit of the periosteum on top of the dura because I don't want to
I
injure.
don't know what the rules are.
Injure the dura.
I am okay with you eating as long as your nurse is there. We don't want you
I'll
to-
take another.
And so start with some water. You feel good? I would start with a little bit of water and see how your stomach feels, and if
Я
that's
також
okay.
сказала, що, наприклад, на
You did? Oh, perfect.
скол
Okay.
не так
I will
важливо
let the nurses
мати
know.
PSI,
All right.
тому що
Rest.
Досить.
воно не так лежить.
Нема таких.
I'm going to give this screw back to you. And I'm going to give you set that one back, I think. Воно тут відстає від кісті. Хочу, щоб воно відставало. Правда, трошки нижче, не так важливо, чи воно відстає, чи ні, тому що тут грубша, ну просто грубша шкіра, більше жиру. Так що я трошки просунула тут. Jackie, I'm gonna forget this screw because I think I damaged the. We're gonna throw that one away. You can give me another one. Так що вони тепер трошки краще, бачите. Ці рукавиці. Мені не можуть палитися.
Багато що не бачив. Буде запис. Ми зробили не там, до речі, запис краще, ніж з камери.
І як я кладу шурупку, я вперед трошки і тоді назад. Деколи кістка попадає, it falls into the screw threads and it's hard to screw in. Ще один. Another one.
Один там найдовший.
Я вже по-англійськи, по-українськи, like it's just a mixture.
Один найдовший оцей, так?
So confused.
Найдовше те, що буде справа.
Це не цей найдовший?
Це щось дуже тут м'яко. Я тут вони буду навіть класти. Can I get a 4? Ага. Тут трохи м'якше, так що не повністю...
Трішки нібито кістю вийшло. Ми можемо зараз його просунути. Розпати. Fear, please. Fear.
Я це зараз вправлю. Я
О,
просто
все.
покладу і тоді з того витягну Curiosity. І ширубки. Головне мати 2 ширубки.
How are things going?
Класти 4 навіть трошки забагато.
We're making it work.
Curiosity.
Останнє не продаєте?
Не треба. Тут м'яко, я боюся, що
Ага.
впадає в...
Ясно. Тобто ви впевнені, що воно стоїть і все, і
Так,
достатньо?
так. Тут фактично тільки 2 потрібно. 3 то вже досить максимально добре тримається. І все. Irrigation. Я люблю трохи промити, тому що там які-небудь бактерії, щоб вони впали з повітря. Я рейте Аскар.
Аскар ви
One more.
Зробили.
Thanks.
І ще туди.
Якщо є нагода з антибіотиками, irrigation також можна використовувати.
I had to.
Але скалп, вона має дуже добре.
One more, please. Yeah? One more?
Ні, це достатньо. 3 Vicro, please. Так що, коли я відкриваю, я використовую 3 Vicro в гелі. Ну, впало. Тому що 4 не потрібно, і один з них падає дуже близько до дефекту. Але він
Там така дуже м'яка ділянка, і
Там
тому от вирішили не ризикувати.
Інші тримають вас, так?
Дуже
Дуже
стабільно.
стильно.
Nope. So then I'll do a 5-0 proline after that.
5-0 proline?
Uh-huh. So 3-0 Vicryl, 5-0 proline.
Yes, 2 available?
Perfect.
We'll have a 6-0 proline, so 5-0 proline can't. That's okay. 5-0 proline?
Dahlia – це дуже така сильна layer of the scalp. І на неї можна належати, щоб тримала
Scissors for lean.
Я так говорю.
Thanks.
Я ще повністю по-англійськи говорю.
Що якраз за це досконало.
Put them.
No. So one very good thing is the cinch knot. So you see how I loop these knots? I hold this one straight and I just pull on this one and it tightens by itself. So you don't need somebody to squeeze it together. It's very nice technique.
Is a maxillary PSI for, again, for volume and proper contour to the mid-face. And these have been placed with rigid fixation. We do have a lot of soft tissue loss in the mid-face, which was tethering by scar tissue to a great degree. And
We need some rising solution course.
We're going to reline it with vascularized soft tissue
Mm-hmm.
from the neck and shoulder.
Take some more saline in the container, please.
Sorry, were we going to drill that hole?
Yes, we are waiting for the irrigation.
Right.
So you're no longer taking the shoulder, you're doing it.
No, I think,
No, we are.
I think
We're
we're
gonna-
going to, yeah.
So this is for the dermis fat graft. What she's closing, that's the donor site for the dermis fat graft, which we're using to augment the orbital volume that was lost when his eyes were removed. You ready? Or is the drill not working yet?
The drill's totally working, it's just.
Oh, we need irrigation.
Where did you get this?
Hmm?
Where did you get this?
Stomatologist, dentist.
Nice. Very nice.
Can we keep it?
They remove teeth with this.
There's
Nice.
drill bit, drill that they gave us. Could I take that? And I'm using that.
Thank you very much.
No, they haven't done the plates yet. That wasn't necessary.
Drill, baby, drill.
Except for today,
But we should, yes, we should change the,
Are we good there?
because.
You got a better angle?
Mm-hmm. Yes, as
Yeah.
much as you.
Okay,
Mm-hmm.
that's nice.
Yes,
there's a lap bed if you want.
how it works. I
can-
just
yeah,
need
you
to
just do
push.
that.
Uh-huh.
I can
Okay.
irrigate for you if you like.
Yes, thank you very much.
Let's make sure implant's good. Okay. That's good.
Are we good? Okay.
Yep.
Okay, you get that? Okay. Okay, do you want, we'll take a, what do you want? Six through, please?
6 screw, coming right up.
All that effort for that.
Yeah? Wow, it's just one screw down there. No, this is another one.
Oh, yeah, I mean, it's
6
yeah.
screw.
like for 4 seconds of actual action.
Correct.
Right, are there any things that from your specific instruments that you don't need anymore that we could process?
Wow, right? This looks so much better.
Okay.
What was I thinking?
His eye looks so much better. It really
Yeah,
does.
the eye is very, very nice.
Has anybody gone to anything to it twice? Like say everything's going to, I did it once.
Not yet, no.
Nice. Okay,
No.
that's still running.
Mm-hmm. Thank you very much.
Oh, okay.
I think it's impossible, but we try to do.
We can go
Mhm.
this way too.
No, because we have. Oh, maybe. No, we try with 6. Super. Thank you very much.
What are we doing now?
So we're fixating the patient-specific implants with titanium screws. Is that biting?
No?
It's okay. It could be.
Okay. One more
There's
here.
one more down here. This on, there we go. Good.
6?
6.
Mm-hmm. Oh, sorry.
I wish I could stay for your
Yes, beautiful.
supraclavicular flap.
It could be the.
Oh, did it break?
Broken. Mm-hmm.
Broke.
The screw broke?
The screw broke? Look.
Yes. We should leave it like this
I think we're good.
because we will
have
have
3
the
screws.
problem when we start to remove. We should leave it.
Yeah,
Sorry.
no, you're right.
All right.
Come see it. Looks good. Check this out.
Should get a picture of it.
Huh?
Can someone grab my camera or my phone right there and take a picture? Let's get Sen. Have a Sen.
Wow, that's a big, 2 implants, man, obviously.
Yeah.
But, yeah.
Well,
And quite a big release of that scar.
Yeah, and then he's got the dermal fat graft in here, Matt. Check it out.
Oh, cool.
Yeah.
I never seen one.
So totally different position of his eye socket.
Is that his mid-face musculature?
Yeah, we just kind of flapped it laterally
Okay.
and give him some volume there. I mean, and I was thinking that would be
Do you
so
have the
much
other
quicker,
half
but
of that fat graft?
to do this for a whole bunch of reasons.
Yes, I can.
Like, oh, you know what? I haven't dissected yet.
Well, we stayed out of his mouth, which was a goal, and
Let me see. Yeah.
and
Pick
we-
up some
I mean,
scissors.
at rest, his nose is
Yeah. Tenotomies are fine.
too hot.
The
honestly,
blockouts.
But
The
we
blockouts.
released it so that he's got, you know, if I could get in that position, that'd be great, but I don't think it's gonna stay there even with the super cloud flap. I really released it here, and it's happier, but it's,
Can I get a Demar, please?
don't think it's gonna stay there, Matt, without,
And we use a PDS and tack the nostril over to the piriform liquid. And then maybe. Release that before we get the bottom.
no chance it is.
We might be able to convince it. Yeah, cool. That's such a short job to connect those two. And rotate.
What are you looking for?
Just the big end of the smaller one.
Immediately,
This is fine.
that's what has to happen. To the piriform ligament, you might be able to hold it.
Me.
Gotcha.
Do you think we should make that decision, John?
Well, it's very tempting. And then you could even, if you didn't quite make it all the way over here, you could have a little mini romp, labeller flap, right?
Yeah.
I like that idea.
Does that link reach midway?
Can I get a Adson, please?
That's why,
Yeah.
yeah, it's gonna, like, his arm stops there,
Yeah.
for one thing. And that is a very, very long reach. He's got a long neck. It's not a periauricular, of course, it's a mid-face, so it's,
Yeah, I'm just thinking, like we talked in, if we do make that application, we have to transfer defect lateral.
okay.
Yeah.
Yeah, I like that. Yeah.
So no change.
I do like that. I thought I was actually gonna do that. I might have taken this a little lower and back cut it, but yeah, I mean, there's way more lax than I thought. And literally, I've almost connected, right? We're just about there.
Yeah, such a short job. Complete that.
Right.
Trying to take that out, trying to over, and this will be so much less.
Yeah. Do you think we need this? If we do that? The only difference about him today is that he did shave. Remember there was an issue about his beard? But he looks great.
Yeah.
Yeah.
I just rounded on my first guy, and he's not having any trouble breathing, and his biggest concern is.
Can you lift his upper lip?
Does he look better?
Yeah. Yeah, it's really good.
Thank you.
I said, is it hard to breathe? He said, no, it only hurts. It hurts really bad.
Excuse me.
Is this access to tunnel?
Yeah.
It's good. Tunnel it.
We may make a cut here like this. Bring that in.
And then the hole back here to see if we can pull it down. Here's what it's gonna go so far.
Yeah, I kind of like that idea. Matt, I'm very intrigued by that suture, that alar suture. Yeah.
Optic nerve, very tough.
So this is for dermis, fat, and then put the fat into the eye.
Oh, thank you. And then it gives like a space.
Gross.
Not so much.
Not to the person who does this every day.
Not by far the worst thing I've ever seen.
So what are we
This
looking
is
at there?
the right globe.
Okay, so that's the eye glow.
More the same.
Yeah, on the other side.
Use for this one, half we'll use for the area. So that's what, usually in simple.
You should send them separately because they come from different sides.
May I ask you about
This, what do you need to say? Okay. What do you need? Oh, no,
Thank you.
I have more specimen.
Since I'm on the other side, I can work on this while you're doing that.
Yeah, I can also, like, see what Donnie and I.
Okay.
Yeah.
And we're
Yep.
gonna slide in right here, just
Okay.
go back.
Okay.
From around the bottom there.
We can. Yes, I understand correctly.
Yeah, you can
would
go-
like
you
to
can-
switch.
So like me, thank you.
We got
May
this,
I?
Sean.
May I?
Oh, I have more.
More
Specimen on a different location.
Pretty much the same size as her.
Yes, I know. Six and a half or both sides, whenever I think that I put proline in.
Ah, okay.
So what are we calling this again?
So I think
Wow, Priya, it was like we were.
for the most part, I will be doing this part, the part that I just did, opening things up and removing any, kind of
Right eyeball.
right globe.
EYE.
Thank you. Right,
Yeah,
Obi, how's that? Just for you.
Can you help a brother out here?
Sure.
Can you put that? Oh, so much better.
So I just
Yeah,
gotta make
thank
sure there's enough space there. It feels good. I'll take the dermis vac wrap, please. And then another 5-0 Vicryl repeat, please.
Could I have
Usually
Dr.
use sticks of Vicryl, but
Cho's?
we don't have any sticks of Vicryl.
Could I please have Dr.
No,
Cho's
the
original?
dermis vac wrap, yeah.
Vivi, could I have the original bipolar, please?
The orange one?
Yeah. Thank you.
Is there something bleeding? Or is there foreign body? I'm sure there's a foreign body. See the scissors again? It's probably a little more length than I need. That's better.
Do you mind turning my whole thing this way? The whole.
Чуть-чуть правіше поправся.
Thank you. Yes. It's great. Thank you so much.
So hopefully most of our
Vivi?
patients will be a little not
You don't
as
have a marking
skinny as
pen, do
this
you, love?
guy. Be able to get more fat.
Take it.
Yeah. So
Petition this, right? Are
oriented,
you okay with that?
oriented this way. Yeah, that's good.
So,
Stuff it in there, and I kind of just start sewing and then kind of sew and trim and sew and trim until you feel like okay, it's all going to go in there.
Yeah.
So I'll take the 5-0 Vicryl, please. Let's go. Or monocle. Yeah, Vicryl.
Vicryl.
See that.
Micro repeat.
Is the bipolar on?
I can make it on.
Have it here.
Ready? Oh, sorry, I just
Go on.
And here.
ixnayed your bayonet.
That's fine.
Where
On.
it's there and just switch it from rolling to bipolar.
It is on. No worries about
It's
that.
on, okay. I have the 501
Go.
Pro, bipo.
Thank you.
Yeah, the button's pushed.
Okay, I think we're all set here.
501.
So you decide to make
I
additional.
think Matt's point is.
On a Castrovia.
Phoebe, are you good for
we
a
could
minute?
take potentially 10 centimeters off the flap.
Okay, I'm just gonna run to
If,
3 and then I'll be back.
if we use this and we don't like it, we can put it back. If we, I was just gonna tunnel it. but
So, when you're
his
harvesting
point
these,
is, we
try
could,
to
we
avoid
could
the
use this
monopolar,
for this.
Mm-hmm.
cause shrinkage over
We
And
will-
this one you use for this.
Yes,
That's what you
exactly.
get it.
Super.
It's a lot more
I
reliable.
was getting, forceps, sorry.
If I knew we were gonna do that, I might have designed it a little bit differently. I might have gone back here a little bit more.
Yeah, like advanced.
Yeah.
Ship to shore.
It's okay though.
No, but it's we have the enough
I mean, right.
enough space for
Yeah.
this. But
So
we
I don't sew
we
directly
see
to
the
the edge.
problem on
Exactly.
this area.
Exactly. So
I
we could
overlap
have
the
labeller
columns
or
just
something,
a couple millimeters.
you know, for that, but I like the, yeah. the volume there. Okay, and, yeah, there was some bleeding right up in here that I was, thank you. This is good.
We come up under the upper lid. Yeah, let's go up.
Right up here. Really like your bipolars, right?
Ace Medical donated them.
Love them, actually. So nice.
Thank you very much.
What's the status of the lacrimal system here?
I don't know.
Does it matter?
I don't really have any reason to believe that it's compromised on this side. On the other side, I'm sure it's gone.
Okay, knife, please.
Maxilla is almost pretty much gone.
Always moving on me.
Take their scissors?
Because it's not fixed in a good way on your head. Да, воно з'їхало знову.
Thank you. And both are
Just one. I'll run this.
run it.
I usually interrupt it, but here I'm gonna run it.
Superficial temporal vein won't be very far away.
What's the next case in here?
Big surgeries.
another
Yes,
PSI, right?
yes, yes.
Oh, wait, wait. Next case. Wasn't that the one with the late breaking addition of the shrapnel on his
Neck.
neck?
Yeah.
That was that.
Yeah, I was suggesting whether they start that in one. One is done.
Right.
Excuse me.
We have a couple of, maybe a couple more sponges and a
Have they
couple
already
of
started a
double
case?
skin hooks, please.
Yeah, they're on their second case.
There's only 2 cases, right?
And there's only 2 cases, so they take the second one here.
You.
We're gonna take a Raytac as well, please.
Can I get a set of right next? Do me a favor, we can open up sterile supply here.
Yeah. Okay, DG, what do you need? Raytac? Anything else?
No, for now, it's good.
That's perfect. The other side.
Oh,
Thank you.
like, I didn't think it was
Yeah.
bleeding that
No,
much.
it's not you.
No, it's you guys.
Right there.
It's definitely you guys. All right, not bad, thank you. And can you get one in there? Double skin hook, please, to put me on. Yeah, great. Yeah, that's a much
Too
bigger
close.
skin hook.
This is too big.
You have the small one.
I have the small one.
Okay.
Oh, this skin hook? Yeah, that's the only one.
Only one. Okay.
One in the set.
Okay, it's okay.
Can I get the Damar, a small Damar?
Small them are.
And then you can have this back.
Small them are.
You want this skin, you can take it. There you go.
We didn't like it anyway.
Yeah.
Thank you very much.
Hey, baby, you don't have any little lips, do you?
You might do something different.
Excuse me for
you have any yellow clips? Yellow hema clips? No?
What do you want?
Okay, no problem.
Yes, for it.
Що? Ну да. П'єза не треба мені. Москіт, кохер, нож, ну, лезві.
Can I see those other
Що?
smaller
Ножницями, а і коагулятором. Коагулятор основне, щоб був.
Okay, so sometimes we can find that superficial temporal. Do you mind if I go up there?
Yes, of course.
And thanks. We'll get the double skin hooks, please. Is that right? Yeah. Well, we're doing the,
Yeah, the scissors.
just the cervical facial part, just to see what it gives us.
Got it.
Yep.
Thank you.
You always operate with loose? Okay.
Not
100%.
you're 100%. Probably. I like to operate with loose for rhino currency, but I don't know how to do. My flips, I generally do. The faceless I do. Right here, product, I guess. But like, if I'm doing like a lip lift or a chin implant or something like that, I'm potentially.
Thank you. Now, there's our superficial.
I thought LASIK done back in the day, like 15 years ago, 16 years ago, something like that. I love it. It changed my life. But, however, I think I'm now.
Presbyopic.
Yeah.
How old are you, Grant?
37.
Oh, it's a little bit early for presbyopia.
I haven't gone to go get them checked because I have a little bit of smile.
This is where we would have raised the temporal parietal flap if we used it, I guess.
You get a little on.
Usually use it.
No, it's a crappy little flap. It's no. But thank you.
Yeah, I've not been terribly impressed by the TPF flap.
It's a cool flap. It's got a, there's your blood vessel right there. But it's just doesn't have anything to it. There's nothing to it. Really at all. Thank you.
It's better than nothing at all.
Yeah.
But not much.
But like I think you said something about you've tried the skin graft on it a couple times and it never took and stuff like that.
Yeah. Of course, that was in like radiated patients.
Sure. Yeah.
But you
Can I
expect
please?
it to provide some vasculature.
Emma, can I have this question?
May I ask you about the second hook?
I'm waiting
No.
for the cup.
May I ask you second hook for the skin? Mm-hmm. Thank you very much. Maybe not so big. Okay.
I'll take the bad one. Even that is so scarred.
Yes. Sometimes the patient has some injury in this area,
Yeah.
and when we open the neck, it's also like a big scar. It's
Yes, I'm sure that's true. Okay, so can I get you to put the nice little double skin hook right there? Yeah. Oh, more shrapnel. Add some with teeth, please. Just a little. Thank you. Piece of metal. Knife, please. Oh, sorry, I got it.
So this one is. Ah, right.
I'm gonna need a couple Foro silks
For a substitute, please.
and two conformers, which I put somewhere.
Probably a little sensation nerve there.
You said 2 silk?
Foro silks. Yeah.
How long do you need the front?
A week.
Which conformer?
They're both larges, I think. Tons of-
Розпатер для,
Okay, there's the zygomatic arch.
для кістки кохір, що був.
Read about the frontal branch.
Рот оці жабки. Галині Богданівні скажи, що ми скоро будемо починати. О, все. Добрий день. Дякую. Нам не треба стоматологічні, нам треба загальнохірургічні. Все добре. Дякую. Да, супер. Дуже дякую вам.
Yep.
Ну ви ж з нами станете?
Так, я вам.
Все, дякую.
Can we open it, please? Thank you.
Sponge, please.
And I'll place the box over here. Yes. Do you want this some kind of, manufacturer back?
Yeah.
Коли день то
I
буде,
don't need
скажеш,
it
я
yet.
розмиюсь.
Okay.
I think I'm around your arm.
Угу. Давай.
I love all this bleeding because it means that there's a good blood
It's
supply.
such a-
to the
yeah.
graft, right?
I don't love it.
I know, it's pouring over here.
Oh.
I'm sure you feel terrible about it.
Knife, please. Do you need to grab a knife?
The record is that Ray did not complain about it. I was the one who's complaining about it.
Sorry, guys. Oh, you guys. Oh, this is probably gonna bleed. Thank you so much. Okay, so now we're seeing some. Oh, I would love to keep those
Угу.
blood vessels. Look at those beautiful blood vessels. Honey. Thank you. I'll take a. You have a non-tooth forceps? Okay.
And we should have, these are brown.
So not rocket science, right?
Oh, it's kind of like.
There's a little
it's
nuance
kinda-
as
yeah,
far
it's
as
kind of like
sizing.
stuffing a
stuffing it.
All right.
All the stuff with people coming out.
We could do all this with the monopolar, but I'd rather not.
Yeah.
I like doing this. I can see a lot more deep. Now, there's the facial nerve. The mosquito, please. Just some buccal branches of the facial nerve right there.
Where? Here.
Down there. And it's really nice to see those.
Yeah.
Because it tells you how deep you are.
Mm.
So anything superficial to that is fine. Excellent. Mike, please. Number 15.
There's no problems with this getting buried or anything, it's obviously you de-eft it.
So
I mean, this is all dermis.
Yeah, any kind of thing.
Try to keep all the fat, you know, it likes to kind of pooch out a little bit. If there's a little fat globules coming out, then we just excise them.
everything wants to bleed now, I'm sure.
Yeah, it's really not much.
An oculoplastic surgeon worked with us in training. And all of us who went into plastics tried to spend time with him.
Well, it's a requirement now for plastic surgery residents to spend time on oculoplasty.
Christy, I'm just looking at that bag. It's like an entire
I
bag.
think it's a
of
requirement
comics
for them to spend time with ENT now too.
With all the bags, they didn't get.
No.
I don't think the reverse is true.
He's the only one who pulled like 2 out of the bag and it was still there in the tray.
Understood.
So I don't know where to put it.
You're getting, okay, let me come and help.
Yeah, right. No, it's okay. Lucy and I are talking. Natalia took what she wanted, like she sent it up, so we're good.
Can I get a cotton tip, please? Cotton tip. Cotton tip.
Cotton tip.
Very hard. There's a nice branch of the facial. There.
So we had some comics in there.
Not my favorite Castros. Holy cow, Johnny, what did you do?
You know what, man? We're gonna improve his lot. Now, what we might do, Ray, is we might trade some of this defect in for a defect back here that would
Okay.
be
All right.
a little nicer.
Some of it or all of it?
Don't know. Honestly. Great.
Yeah.
Try to stay nice and superficial here.
Mm-hmm.
Yeah, they seem to prefer eviscerations here with this combat injuries. No. Yeah.
These are very superficial structures, so they can't be the facial nerve. They might be other things. They might be sensory nerves or whatever.
Careful with that skin will bother your arm.
I didn't leave it in a good place. Baby, I'm gonna give you this too.
Concept.
Baby, we're gonna give you this in a cotton tip.
Yeah, okay. Thank you. And
Maybe not.
Mhm.
These skinny guys, it's.
I'm very apologize, but I should go to the
Yes, thank you
another,
so much.
or
Thank you,
I
Tatiana.
try to come back chat as soon as possible.
Thank you.
If you don't excuse me
No,
for
thank
this,
you.
but I come back to you.
Thank you very much.
Thank you too.
Ви сьогодні на лагоді лагода, що
Наступна операція маєте на увазі, так?
Так, ви будете на цій операції?
Да? Якщо ми встигнемо, у нас поїзд 9:30. До того моменту.
Tatiana, they have the patient, they were doing the nasal intubation for you.
Yes.
Igor was with our nurses, getting the room ready, okay?
Thank
And
you very
lunch
much.
is here.
No,
So whenever
it's
you
okay.
get a chance, I'm just letting you know.
Thank you very much. Thank you.
Хотіла вас запитати, чи є можливість попроситися на операцію?
Зараз та що зараз?
Ну, і лагода.
Та я не проти, я тільки лагода це той, що з закритим ротом, чи хто це?
Тому що щелку мають робити.
А, то там зараз давайте, звісно. Але там буде ще Ігор Богданівна. А все. Якщо можна, можна. Я не проти.
Never seems like it's all gonna fit until you're just about finished.
Right here. I see you now. What's that?
Keeping tabs of everybody, making sure they're working.
She's the taskmaster.
You need some more of those cotton stuff.
I'm almost done.
Almost done?
Yeah.
I have about 2 or 3.
Concept.
Good.
Thank you.
Okay.
Put them with her, so she's ready.
Good.
Are we done with the drill?
Yep, we're done with the drills, right? Yeah, right.
Should be. Yeah.
Yes.
Yep.
So I'm gonna take them off the field, okay?
Thank you.
So we need to figure out for definitively whether we have any self-drilling screws or not. Uh-huh.
Someone brought those, so let me take a peek and see what those are, okay?
Mm-hmm. Take that.
You. Well, it's gonna improve. Is it gonna work? I don't know. I've really raised it up, and we'll find out, I guess. I'd love a hand. I'd love a hand for like a number of reasons. Yeah, thank you. Okay. How's that gonna work? Yeah.
It's your needle, baby. Okay. I like it. Can I get those conformers, please?
I was really messing with your mojo, wasn't I?
Nothing I'm not used to.
Well, Priya, I'd love to confirm everything with a nice little facial nerve stimulation, but
We have a Bovie here.
yes. Thank you. Oh, that helps.
Use the KLS, they didn't use any color, to just said, okay, I guess so.
So the KLS are self-drilling. Okay. Or any case that I do. The next case is PSI, right? Yeah. Any, yeah. Mm-hmm.
See this artery?
Where? Where is
This
it?
is the facial artery right there.
Ah, yep. All right. We have those conformers. What kind of eye ointment do we have here? What kind of eye ointments? Do we have eye ointments? Yeah. Do we have? We have erythromycin. Uh-huh. Do you have erythromycin? Erythromycin? No? Okay. How about some Maxitrol ointment? Yeah. Thank you. You guys?
4x4s.
I like it. Looks good.
I really like that prosthesis. Really like it.
Phoebe, darling, Matt is going to scrub in, okay?
Yeah.
Okay, just letting you know.
Does he have stuff over there?
Yeah, Matt said something about some suture techniques that would help this collapsed ala, and I think he wanted to move it from the base of the ala north, like this. But I think instead of there, put it up here, something like that. But, you know, he doesn't have great hip support, and we're not doing his nose today, of
But if
course.
you have something near the pure form,
Yeah, I
then
think,
you'll be able to anchor.
yeah, I think that's the idea.
Fibrous stuff right there. Gives it something to hold on to.
So I guess we have to just decide if this is gonna cut it. I don't think it will. I think he's gonna have too much of a secondary defect here, but,
We need something up here.
yeah. And if it isn't, that you know, we do have not that this is great, but we, like that, that could almost work, right?
I'm just afraid it's going to exert
So if
downward
not, we could
traction.
do a little glabellar flap from up top. I don't want it to do that. I don't think I can raise this too much more. I could a little bit.
Raise this a little more, make it back cut this way.
Yeah, we sure could.
I mean, so if you could bridge this gap here
Yeah.
with this flap, if you could bring it at least that high
Yep.
and then close the rest,
Yeah.
I think that would work as far as the eyelid goes.
Yeah, I agree. And then we could, I think, it's too much to ask for all this to get closed, so that would be a much more reasonable situation for doing a supraclavicular flap. We could do it there. I do it all the time to the medial cheek. But in him, he's just got such a long neck and it's a long reach.
Thank you. You have the other conformer?
Yes. Coming up.
Thank you.
You don't do this by yourself? How much of this do you know?
Just enough for you to get to we didn't want to go.
Thank you.
So just enough to get to the bottom of where we needed to put our implant. So I was gonna resect this and Ray said, hey, why don't you just flap it?
You
And I
get
thought
some
that's-
nice bulk.
Yeah, exactly. Because he would be so sunken in there without it.
The conformer comes out and the cross stitch comes out.
The conformer stays until they get a prosthesis.
May I see your handiwork? Oh, nice. Nice. Nice.
You are easily impressed, Johnny.
So, yeah. Well, thanks. I'm not sure if it's gonna sort of do everything we want it to. But,
I'll take the 4-0 soap, please.
That's like no tension at all.
right.
I mean, we could anchor with PDS to the
Periorbitum?
Yeah.
Periorbitum, yeah, or periosteum. Ray was wondering about a primary closure
And
a
then
little
this.
bit. Yeah.
Yeah. Bring that up to at least
That can
at
go
least
right-
up above the medial
He's also
canthal
worried about
tendon.
lower lid tethering, of course, but,
Yeah.
Beautiful.
thanks. And we can do more, but
And,
I don't really
take
want to do any more.
No, I think that's funny.
And then the question is, like, what about this?
You have a scissor, yeah, thank you.
Nice section.
Well, thanks. I mean, that's only the great irregular, but usually it's connected to the march somehow.
Yeah.
And I can just cut it if we need it, but I just didn't think we needed it.
App?
So,
Emma?
you know, monitoring, right? So
Yeah.
just the best I could. And there's no EJ essentially,
Yeah.
which is kind of interesting, hey? I mean, maybe I didn't find one anyway.
Yeah.
No EJ.
If they're done with.
So no wonder I couldn't hardly find this, right?
Yeah.
How many 4-0 silks do we have?
Right, Doc?
What?
The screws?
So I don't know what to say. Of course
yes,
I'd
we're
like
done
to
with the
flap,
screws.
But only if it needs it.
Do we have another 4-0 silk? Or is this it?
Yes, I do.
Okay.
I haven't even undermined this. I haven't even undermined this. We could totally undermine this. I think it might be.
I mean, it's so close.
It's almost a shame to do this.
It is.
Yeah.
Long time. Thanks.
Oh,
I'll
is
just
this
use
the-
yours.
This isn't your frost stitch, is
What's
it?
up? Yeah, is that gonna bother you?
No.
It's tarsorrhaphy. Not a frost stitch, just tarsorrhaphy. We could do a frost stitch though. Actually, that makes more sense. You wanted?
I thought
Yeah,
I thought Priya said something about a frost stitch, so.
Well, I wasn't thinking frost stitch, but now that you say it, it makes sense. So
I'll take all of the credit.
Yeah.
I think Priya just mentioned it.
Let's start. What set do we have here? Is it the Rhino set or facelift
It's
set?
really the rigid fixation set.
These
I
are
think it might be yours.
These are my.
do we have
Yeah.
do we have
Yeah.
half-inch steri
Well, some of them
strips?
are. Orange tape is mine. Can I have that double prong skin hook? The bigger one?
you want to do it, Matt? Because I'm
Do you want to get lunch done?
I'm fine. Ray's got a.
Wait, what time is it?
It's 2:00.
What?
Really?
Yeah.
Really, Ray? Oh, he does have an EJ, son of a gun. Okay, thank you. Is there another one of these double skin hooks, please? Thanks. I was just gonna say, I usually do this with my left hand, right? It's crazy. He doesn't, I don't think he needs much.
Can I get that other 60 or 40 soap? You can cut that out. Do we,
Mosquito for a second, please?
Emma, do we have half-inch steri strips and mastisol or tincture of benzoin?
Just got into his. Okay. Gosh, okay. I don't think I'm necessarily right into it, just this tiny little thing.
Yeah, it's a EJ.
Well, don't know what else, yeah. Knife, please?
Sorry?
Knife? Yeah.
Where?
Okay, I didn't really get into it, kind of, maybe a little bit, okay. And then we could do some up here, man. Lots to do back here. Thanks, I think that might be the end of his platysma there. Now, this is fun. I haven't operated with you for years. It's been too long. And I've never operated with these guys. It wasn't an entirely unpleasant experience, right?
Not for you.
No. Sorry, man. Okay.
I was wondering if we should try to squeeze another taste in here and take it off for tomorrow, like the facelift.
Ooh.
Oh, leave it alone. Yeah.
You probably don't fasted, isn't it?
Oh, you mean, oh, that facial prop?
Yeah, because I mean, we've got the time. If we can get ahead.
Well, do we not have another case in here?
Can I get a wet, please?
There's 2 in the other room which are done, and there was supposed to be 2 in here, and we're just moving it over.
That doesn't sound right.
Are we plugged in?
We switch to the bifold? Yeah.
And a dry, and then the mastisol.
Bipolar, you're looking for the master.
Thank you.
Okay.
Yeah.
Mastisol,
Or
I haven't heard that word in a long time.
What do you use? Tincture benzoin?
Just show me what it is.
Dermal bond and anyone
Huh?
interested.
What's the mastisol?
It's like
It's-
Teresa.
Reset,
Yeah.
yes.
Glue for the stereos.
Right.
What do you use for
Right,
steri strips?
Tincture of benzoin.
Yeah.
Actually, we don't really use,
You don't use steri strips?
we, okay. We usually use hemp.
Oh.
Hmm?
Hemp,
Hemp?
like a number 1 hemp.
Okay.
There we go.
I don't even know what that is.
That's a real honest to goodness suture. Okay, Matt, can you undermine this a little bit?
Yeah.
If I come over here.
Yeah. I sure can.
Double skin hooks,
I'm gonna
please.
have to sit down, but.
Oh, yeah. See, that's the problem. Matt's vertically challenged, but in the other way.
You want.
Any other way compared to who?
No.
I'm very challenged in the opposite direction of my wife.
Do you want some scissors or something?
Yeah, scissors. Do we have faceless scissors on this set or curved iris?
Oh, Matt, it was the weirdest thing. Where Priya's touching,
Yeah.
he had like,
What is that?
Sure.
Well, I just, the break in the, see, he's got all this, right? I wanted to resect that, but, I will defer to my colleagues, but that is just so ugly.
Oh, these ones are good. Thank you.
I just thought maybe the upper lip at the commissure could use a little underlining.
Upper lip, yeah. I think I want to pull it towards me.
How am I needed in another room at this point, or are we all good?
They're gonna open, the patient in room 1 is still in there, but they're gonna open that room up for your next case.
Okay,
Okay, but you'll have time to.
great.
Do we have devices off? Not yet, okay.
I think I heard somebody,
Is that a patient or a doctor?
I think it was Face the Future Doctor. When they heard about another one of Dr. Cho's,
Dermosacra?
no, scheduling changes.
I had the bottle.
Oh.
No, do I have
Yeah.
a bottle?
Bipolar on?
Bipolar on, please. I think you're gonna like that bipolar fat.
Yeah, that color is on.
Do you have the, it's on?
When it works.
See that from number 2.
Is there 2 pedals here?
Yeah. One on the right.
One on the right. I have these South Medic bipolars that I just bought.
Oh,
Can somebody push this chair in?
you may not want the chair, Matt.
The bed has to come up and break.
Can be left up.
Yeah, let's.
Yeah.
Oh,
Can we have the
Ray,
chair up?
are you loving that?
Can we
Now,
have the
Ray, just run this out there. Ray has not that we want this.
table up?
Ray does have a big, full thickness graft from the leg that.
Split thickness.
Oh,
took the
oh,
dermis.
okay,
Yeah,
okay.
we took the dermis.
Say when.
Keep going.
Hold on a second.
Like,
Open this.
John, so the nose, I can't tell from this angle, but the nose had to come this way? Or?
Yeah, the nose, Yeah.
Like, keep going. If we can go all the
You
way,
gotta do it from that.
so it won't go no more. Then I won't be hunchback.
Can somebody take this microphone off me and put it on either one of these gentlemen?
I'm wearing one.
Oh, you are?
thank you.
Can I get this back to you? Two sharps. Can you turn your head?
And I gotta do the other side though.
Yeah, I guess,
That feels good.
As if I didn't have enough hanging off my face already.
Where it was like that. Like that. Yeah?
That's on the left. They wrapped all around here.
We're not gonna give credit.
I'm following the cord of the microphone.
Oh, maybe.
So-
We really wanted to stay out of the mouth. Yeah. So I mean, I can take that out without getting into his mouth, but it would be close.
Oh, it's
Right
hooked
there,
up,
so
that's
yeah,
good.
it's like the enemy of
Okay.
good.
There you go.
That's
Now
the idea. primary closure.
I think another forum.
Yeah, well, next week.
I have seen that for years. Yeah.
And I'll fix it. That's where I can check it.
Service staff or neurosurgery, okay.
Intern.
Oh, that would look better though. That would look a lot better. Yeah. So you're actually thinking lower than higher. Yeah. Yeah.
And then the head and neck.
Say. That's these, what do you call that? Yeah, rather, yeah.
Usually use this to put our increase in filters. You don't waste it. Have that part in.
Okay.
Through.
Oh, this is a 5. Yeah. This is a 5.
Yeah.
Oh, like things are seeping through?
Right, I wonder if I'm step away. And
So, yeah. I started raising this with Ellen at all. Good work.
Anyone know where like they keep this chart? Like for the upper kind of bars, like for tracking?
Well, all the bar charts are out there on a table.
Just want to make sure that.
I think that's better. Use it.
Yeah.
Hold on. And I'm not about bringing my little speaker.
are we on video here?
Here's the problem, Mark.
Well, that's what you need to do.
My full-time job with being on call just got in the way of doing it for this mission.
Well, I have my phone here, I have the playlist. Or it was 17 hours long. So
Well, where's your phone?
it's in my loop case, it's in the hallway there.
Yeah, well, yes. I'm gonna wait later.
What's your code?
0282. My birthday. I may never forget it. Yeah.
Your birthday?
February 17th, 0282.
Okay, playlist.
If you go to playlist and go to Dude Rock.
Dude Rock?
Nice.
Let me search.
Yeah. Keep your ones. There you go.
Oh, there it is. I saw it.
Yeah.
Oh, it's not on sure yet.
Turn it around.
Oh, you don't want to. So it stays dry.
Oh, no, I think this is the part that really. You know what, Ray's part is operating with the. I know they do it, and I know all of that, it's kind of making contamination, but it's kind of like, I don't know if we work at all. Like, middle surgery, my hospital, they're, about, yes, I do. I don't care. I don't think it was that great. But I mean, I think this lack of that is pretty bad. I mean, you're right, it's probably better than.
Otherwise, you take it. Oh, you're trying to steal these. Looks like it. Or he does not want this.
Right. I don't
I'll take another photo by Sophie. Give me two more photo by Sophie. Photo by please. I'll take two of them. I'm assuming you want to finish this page down, okay? And then we're gonna set up for our next page and go home. Okay? So, the things that we're going to over, they're not, you know, they have a council, so they work, take them done. Right, so instead of, if they're gonna set it up, you can get a computer, you definitely, the food there, you do. They can do it. You don't have to spend it. You do it. When you want them to do it? I'm definitely gonna go my take. Okay. But if you wanna go, let them do it, you put someone else to do it. We're not cementing in any room, page, right, anybody else. Yeah. I'll do it, it doesn't matter. Al?
A little bit. More? Yeah. That's nice.
There's another photo.
No, that's been updated.
I think we might get some access off. The language is very okay. I think he is right. Yeah, so.
Can you?
Yes. Okay. Yes. Is the underwriting right now?
It's like,
Yeah, no, there's none on the there.
this is a temporal bridal club, you never leave in their life.
No, there's none in here. I already said that.
think you should do it. That. Oh, look, this is why I got it.
Looks back that way, so she looks to be right for the. I'm there, yeah, so it's just a, that. There you go. Thanks. So you can find out the location point.
I can go.
Oh, yeah, here, we're gonna, oh, that's funny.
Super cool.
So Dr. Stowe stuff that we own, and just get that ready. Are you guys using,
Like, everything. I think that gives us something to get.
Are they making a mess up there like these guys were used to doing?
Yeah.
Yeah. Just think of the least of the country, you know. Johnny, I've got to get a picture of that. What do I say, that small elevation you got there? Pretty good. Okay, good. Bria, get in there. Or whatever. Good guy. Show me what you're doing there. We're gonna bring it.
back to it.
I may use it again, so.
Readiness done 2 hours.
Correct.
That 2 PSI, we covered the mobile socket, that's still the thing, but a little bit more and axilla, and taking a son at and then he's done 2 double back wraps, or both back wraps. Yeah, I really think those cars, yeah, it was really a huge right now. And, yeah, that worked.
Yeah, you have those hair curves.
You want another one?
So a little bit of the usual case, and there, even though you guys are big case.
Very, very. Maybe I think they will, fine, Alice, laptop, anything like that? Probably not.
Thanks. No.
They done the stripper, Matt, and they come and let you know from here to down from the blood loss and also separate. And food and things. So,
Oh, yeah. No, at the end of the page. Yeah. See, when you put that flat, that B flat back down, you just make sure that the orbital is flat, covered. It's already covered, okay. Perfect. Yeah. One screw that we got. Okay. Perfect. Ready to use that flat thing that you recommended that we raised? The close, all that flat bolting. So, anyone? I did do some right there, but we could do more. That one? Yeah, right. Right to this side of the county now. You want to take a narrow double promise window? And then a fun, please.
Yeah, I'll take a little time to, for my course, please. So, okay, Mama, what are you people? For not lawnmowers, right, the house operator, the construction machine, James and eight converts in the digital protocol.
Yeah, so we got this thing. Well, I think I'll give you another 5 minutes. Yeah, maybe.
What do you wanna? I'm sorry. I'm not asking for anything right now. Oh, okay.
You guys had a minute, I'll talk.
Here.
Yeah, okay, so, we are gonna be recording this again, like, so.
Okay.
If you can, we had to turn the music off. I asked if you could electronically, done that, but you can't.
That's okay. No problem.
And then again, if you guys just
And you look good. And what you haven't done, is keep up the teaching stuff. Yeah, we really will see this before. We tell them what they can.
Is that like now or in a few minutes or?
Well, as the guy came back, and I guess Ray had the microphone. They're gonna come and put it back on one of you guys choose.
I have a microphone.
You've got it, okay, you got it recording, okay, so you're live and we.
Yeah, we're trying to,
Get that accomplished.
get that to come over,
Yeah,
minimize the standing home deformity here.
yeah. So I think, I can't tell what you think,
I think so, it's a very enough case, but, I think, and you know,
like that, class is gonna come over.
yeah.
Oh, there's no attention here, the question.
What do you do back here? I'll make you take this one, stick it.
Potentially, yeah. It's gonna probably close, it's gonna be under, but he's a very slim man with a ton of scar tissue. So there's not a ton of mobility, but
You gotta get the
we've
weight.
got a very, very large slab here, so I think it's,
That is a.
yeah.
I was saying, that, that I need to tell. I know you.
Or if I
think that was involved with madness, but I think like to see, like to encourage you to take one or two, three of these patients and selectively place ED up there at 6 a.m.
Oh, yes.
You know, you guys. Do not go to anybody. It's
It's a great question.
I'm pretty slick about questions that because you guys get the answers. So reading like this, I think that's what it was good. And thank you.
Now you want it, right? Oh, I see, okay. Oh, it feels good. This feels good. Oh, sitting down, yay. I didn't know if there are anesthesiologists look at the sponges to determine the blood loss. So we have them all there. So we'll have them where we want to put them. Okay. Right, and also, yeah, our assumption is, so. At home, we always look at the sponges too for UVL. Yeah.
That is good stuff.
Huh?
Right? It's less of this, so maybe not there, maybe down here.
Oh, okay, all right. All right, I thought from here it looks like. I mean, it's low, but. Are you gonna need more Vicro, Matt?
Yeah. Quite a bit more.
I'll take some more Vicro, please. Some more Vicro? Yes.
So did you, they talk to me? Face?
After your Vicro, what do you like?
Good morning. This is Dr. Raymond Cho, the Director of Oculoplastic and Orbital Surgery at The Ohio State University in Columbus, Ohio. So the next case that we're doing is a 26-year-old man who was involved in a mine explosion. He experienced a penetrating injury of his left eye, and his eye was removed, and he had an orbital implant placed at that time. He also sustained a large fracture of his left orbital floor without any significant injury to his facial buttresses. So today he also has significant scarring of the posterior lamella, the back side of his left lower eyelid, which is causing his eyelid to turn in, causing cicatricial entropy. So today our plan is to repair the left orbital floor with a patient-specific implant, and this is the CT scan showing the orbital floor fracture. You can see significant herniation of orbital contents into the maxillary sinus, and the fracture goes all the way back to the posterior orbit, and actually also into the pterygopalatine fossa, which will make the surgery a little bit more difficult. There's going to be a significant amount of scarring. So the patient-specific implant is here, and you can see it's been designed to reconstruct the entire defect of the orbital floor. There is a little segment here posteriorly that is designed to be able to be removed easily in case it's not possible to position the implant all the way back to the orbital apex. Once the orbital implant is positioned, then we're going to take a hard palate mucosa graft from the roof of the mouth and graft that into his posterior lamella of his left lower eyelid, and that should correct his lower lid entropion. And I believe that is the majority of the procedures that we have planned today, provided we don't run into any unexpected findings during his surgery.
It's not perfect at all, but it's kind of what people are. So you no, we don't have the intern. Oh, like a, like, they call it the parachute.
Okay.
This guy?
To prepare for an ocular She has her pottery.
So down here. Down there.
Maybe go on the other side.
Or just down here, just come to the middle. There.
You know, after this.
It's like, it could take somebody 7 years old before they, it's not even. Too much, yeah, that's not. Because I know that, I like their, quite a lot. What are you doing?
Okay.
I love this, I love this.
Yeah, like decision to leave. Yes, yeah, yeah.
Face words, but you know, it's like I said, I see like one pretty liberal use of. I think keeping this.
I think we have robust and right sides. But now it's nothing. It's not a basic, it's not, I have.
I mean, you're right.
And that's what you might do.
I just wanna cover your stitches. I get my. So I've got a spare.
Добрий день, колеги. Продовжуємо нашу роботу. Тільки що ви мали змогу почути доктора Раймонда Чо з Сполучених Штатів Америки. Він околопласт, і він розказав трішечки про нашого наступного пацієнта. Пацієнт отримав мінно-вибухову травму у лютому 23-го року, проникаючи сліпе поранення лівого ока, травматичний анафтальм, дефект дна орбити зліва і травматичний перелом вилучної кістки без зміщення фрагментів. Ви бачите фотографії, які ми отримали з медичного архіву. Була проведена первічна хірургічна обробка рани відразу після поранення, потім етап лікування. Зараз у нас, на жаль, лише одна фотографія. Я думаю, під час трансляції ви зможете значно краще роздивитися обличчя пацієнта. На що він скаржиться? Це онеміння лівого боку обличчя, це біль при жуванні, неповне закриття очей, неможливість моргати. І в історії хвороби пацієнта, чат, як то кажуть, є такий пункт, американські і канадські хірурги включають очікування пацієнта перед операцією. І ті цілі, які поставлені перед нами, our expectation, і вони наступні. Це потрібно, щоб пацієнт знову добре зміг закривати ліве око, мав здатність моргати, симетричність очей, поліпшення жування та видалення стороннього тіла, те, що на обличчі залишилось. Такий у нас попередній операційний план хірургічний. Це реконструкція дна орбіти з використанням пацієнт-специфічного імпланту. Це видалення рубця з очниці і використання вільного трансплантату слизової оболонки з твердого піднебіння, щоб закрити дефект, який у нас вийде на повіки. Ревізія лівої бокової поверхні шиї, наявність осколків, видалення. Можливо, буде використовуватися так званий full tissue graft, повнотканинний графт. Тут вже будемо бачити під час проведення хірургії. Компанія Materialize підготувала нам, як завжди, дуже детальний план, як поставити імплант. І зараз я спробую його покрутити, як це робив доктор Чо. Ви бачите, як повинен бути розташований імплант. Операція буде виконуватись великою інтернаціональною командою. Будуть присутні американські, канадські, звичайно, українські хірурги. Хто саме, побачимо, хто як швидше звільниться з попередніх хірургічних втручань. Дуже вам дякую. Переключаємось на операційні, дивимось, що як там робиться. Дякую.
Previously described.
Yeah, we have the court, she has the court. Use Q-tip,
Середини грудня просто розписано кожен день. І, і обладнання теж їздить зі мною. Так що навряд чи чимось, на жаль, зможу допомогти. Так, да, я просто.
We need is a hematoma tonight when we're drinking wine.
This is it? This is it? Maybe a trifurcation stitch there, possibly, or something?
Right
Do we
there.
have any gut stitch? I mean, this is not a two-layer closure here, right?
No. I would do monochrome here. There, Johnny, if you want to put monochrome there, the eyelid I would just do
Yeah.
one. Chromic gut? Yeah, that's fine.
You want the chromic?
Yes, please.
Yes.
Yeah, what do you have?
Size you want?
5-0?
5-0, yeah, 5-0.
5-0, do we have?
Anything that we need to check, I think.
If no 5-0, we'll make it 4.
I don't know, I
Don't want it to be pulled down and
this is true.
everything.
Is there anything to stitch there too? Some scar tissue. You don't even want to pour a Lego right now, do you?
Yes, I do.
Hi guys,
You're
what do you
mixing
want?
me up with,
Do you want a
We,
Penrose,
we
GP?
wanted JP, 10 JP if we could. Just he
Yep.
keeps collecting in here.
I'm a fussy person.
I like that line. Nope, I went through skin. I'm doing a running running subcuticular basically. Okay, the skin just to keep this nice and tight and watertight. So one long stitch, keeping this watertight.
That's it?
So it's a kind of facelift.
This is not really a facelift, this is a cervical facial advancement flap, but a lot of the anatomy is the same as a facelift. And he is going to get a lift because we've taken skin out and it's tightened it. But you would never do a facelift like this. You would hide the scars behind the tragus and up on the hairline and up behind the ear. Yeah. We'll do a facelift on one of our facial reanimation gentlemen. I'll show you guys all those landmarks I talked about. We'll mark them beforehand and then show you the deep plane entry to do a facelift. And it's really quite beautiful anatomy.
Ooh, I just pricked it inadvertently. Look, got bright red blood.
Nice. It's alive. Whoever undermined this did a beautiful job.
Yeah, that would be you.
Yeah,
Like a flat 10.
that works. That works.
That's the only one I can find.
What's a
Okay.
flat?
Flat 10.
Flat
Yeah,
perforated.
that'll be okay.
What you did,
Yeah.
because it's all we got.
I'm sure we can find. You know what? You can take a rubber band and so like you can make some stuff up.
MacGyver.
Yes.
Yeah, but
I have lots of Penrose.
no, I guess that's the only beep I'm gonna do here. Maybe I'll do one beep here.
Yeah, is there anything to attach to?
You want a nylon or a silk to tie it?
A silk
yeah.
would be good, and I
Like right there.
Right there, lateral orbit.
Not a bad idea.
Johnny, that looks perfect.
Really happy.
Look at that.
Kind of surprised.
A 2-0, a 3-0. Before I get this closed,
Short supply.
Evie, can I have a 15 blade?
Oh, that's for the drain.
Yeah. Can I have a 15 blade, Evie?
15 blade. You 15. No.
I just need to make a stab incision. It's.
All right, that's for the.
Thank you. What's that? Ooh. There. And then, can I have that drain?
Oh.
Oh.
Shucks. Sorry. I didn't mean to cut that. It's quite so. Sorry about that.
No, okay.
Matt would like to apologize.
I would.
Or was it Priya? Sorry about that, you guys. Can I have a needle driver, please? Of the empty variety? Yes. Oh, you?
Yeah.
Yeah, that's right.
Just, I'm teaching Dr. about the closing.
Yes.
We are.
I just didn't recognize you when you're.
Okay. One of the things I like to do when I put a drain like this in is take the suction. As we close this, as we close this, it will suction all the blood out.
And also here, we were asking
Yeah.
about, it hasn't specifically been removed, right?
No, it hasn't.
Or
been,
addressed in any way?
This side, we assume it's gone. This side is the side that he had his whole maxilla fractures.
I usually say when it's
This side
less
there
than
may-
30 cc's in a day. So it could be tomorrow morning, it could be the day after, usually, 1 or 2. Yeah, just pull it out. So I'll suture it in place. No, it'll feel like a little pinch, but it won't hurt bad. No.
Sometimes it can be,
The
right?
gland is also gone totally, so
Yeah.
that's.
So it could be the mucosa, right? Like the conjunctiva? They're secreting in there, right? Or not really? No, not to the amount that
Thank
made,
you.
that makes sense.
Okay, can I give you a stitch back, Davey?
Yeah.
And then I'll take a
You're here from Kiev?
chromic.
No, I'm here.
You're here, okay.
Here, you need not come up.
Yeah, Angela's one of our ophthalmologists.
Oh, you were there yesterday in the clinic. I remember you.
Okay,
Sorry, everyone looks different with a mask on.
that's right, exactly.
Oh, that was beautiful. Nice map.
We need to get acquainted with the masks on.
I know.
Thank you.
My name's Priya.
Nice to meet you, please.
Like Toyota?
Not quite,
Toyota
but I
That's Prius, Johnny.
Oh, sorry.
Yeah. Close.
Phoebe,
Yes.
I'm gonna throw these right-handed.
Oh.
Is that okay?
What part?
I'm a right-hand man.
Oh, you are.
Well, I mean, for sutures, yeah.
Okay.
I know it's confusing. I've been cutting with both my hands.
BB, can I get a 50 nylon or a 50 proline, whatever we have? Oh, silk. Yeah, I'll take that too. And then I'll get the 50 nylon.
Oh, that skin is not very
Yeah,
nice.
none of the skin is very nice. Some of it is like just shredding.
Right.
Yeah.
Maybe. We have some fine forces, like Bishop Harmon or something like that. Yeah. No, this is good. But we do have one, like if Free or Matt wants one, don't we have a nice spine pair like this?
We should. This is my rhino set. We should.
I'm okay right now, but I might take it later.
Maybe not so much except after now they're on.
So tomorrow or the day after, you just cut the stitch and just pull. Yeah. BB, I have a sharp here. I have a needle up. And can I get the nylon or the proline?
Yes, exactly. This is chromic.
So you want to try to chrome it out?
I want a proline or a nylon.
So we don't have to take this out.
The number one cause of hearing loss after this kind of surgery is blood in the ear. You probably flush that at the end of the case.
Slippery.
Johnny, he looks amazing.
Happy, really happy.
And no superclav needed.
Yeah, that's crazy.
Bless your heart. Thank you.
Could I have scissors, please? Oh, hey, Britt, can you just get this one for me, Ellen? Well, I think, a lot of that has to go into where you're resecting the scar and where you're going to stop, because you could just keep going, right?
Yes.
And I just basically did like a lateral rhinotomy type. That is good.
Is Natalia got a case going with Ray? Yeah, good. And did that coronoidectomy get done?
Huh?
I think it's getting done.
It's getting done.
Getting done?
They got him intubated, I heard, pretty uneventfully. I could
Perfect.
tell, but I wasn't there.
Well, Angela, at least I don't have to worry that I'm going to cut his eye with my closure. I'm serious.
Yeah.
Don't want to trap his eyelashes either. I have to say, I'm not an eye doctor at all, but I really liked what Dr. Cho did there with the dermis fat graft. It was really, really nice.
Is it exactly what I think it is? You take a
Yep.
big chunk of skin
Yep.
with a bunch of fat and you take the epithelium off and dunk it in?
You do, but Pri was saying that, Pri did it with him.
Yeah, de-up the
You
skin
de-up
while
the
it's
skin
in.
inside you while it's still hanging, and I totally get that. I think that's the right idea.
Oh, cool.
It's
So
on
what did you
tension.
do with this?
And he put it within the scleral pouch that was left over in the eye. And then it gives the eye volume. You put a little conformer in and then
So under the conformer.
is this conjunctiva and, conjunctiva and then the fats in there.
So you close the conjunctiva over top of the fat.
No, it's kind of sewn to it.
Okay. What's exposed? The dermis?
Dermis.
And conformer?
Yeah, it's the conformer, then the dermis, then it's the deep side of the dermis, right? So all the fat.
Yeah.
And then the deep surface of it.
Cool.
Running horizontal here is because it's the greatest tissue.
Do you guys have any questions, Alex, Bermuda?
Because he looks totally different. Really hope this white flex.
Do you guys have any questions?
Not really.
Not really? What can go wrong here? Hematoma. Hematoma can go wrong. So you might get a call tonight saying his neck is getting really big. He's having trouble breathing because the blood is trapped. So if this drain gets blocked, it's not sucking out and it bleeds, it will push on his airway. So then what do you do? What is the treatment for an expanding neck hematoma causing him to have trouble breathing?
Maybe tracheotomy or not.
So tracheotomy is not the first step, but it's definitely something to consider. What's the easiest way to get the pressure off of his airway?
The pressure off of his airway.
Yeah, if it's bleeding and it's pushing onto his trachea and it's compressing it and his neck's getting really big and he's just cut the stitches and open it up. Let the blood out. Yeah, just let the blood out. He'll have to come back to the oven, but on the floor, just cut the stitches and then the emergency is over.
Yeah.
And now you need to find what's bleeding, stop it, reclose it. That happened to me one time.
With this type of surgery?
With this type of surgery, with a giant basal cell with a supraclavicular reconstruction and a hematoma. And I got called to the recovery room. In Canada, we have recovery room. After surgery, the patient goes to a special department where they have one nurse sitting with them until they are fully awake, able to stand, able to use the toilet, and then they can go back to their room. So there's 3 different.
So how long?
It could be an hour to 3 or 4 hours. If they're very sick and throwing up and vomiting, they keep them until they feel better. So it happened to me in the recovery room. About an hour after the surgery, the recovery room nurse called me and said, "This patient's neck is getting very big and they're having trouble breathing and it looks like a giant bruise." And they came and the neck was huge. So I just took a pair of scissors, cut it, put a bunch of gauze and just pushed and all the clots came out and then went back to the operating room.
But better it may happen in the recovery room than before.
It scared all the nurses because there was blood all over the bed, but it took away the urgency of thinking about a trach or a very difficult intubation because the pressure's gone. If somebody has a hematoma and it's been there for a while, like they stayed home, they got bigger and bigger, and then they came in and maybe it's an hour, 2 hours later, often there's lots and lots and lots of swelling, and you do have to do a tracheostomy as well as, but even when you take the clot out, they're often just swollen and you have to give them a safe airway.
Thank you.
Yeah. Do you do many trachs?
What do you mean tricks?
Tracheostomies? Do you do tracheostomies?
Yeah.
Yeah. What else can go wrong here, Johnny? Skin necrosis?
Yeah, it's possible that with any flap, some of it doesn't survive. I think this is healthy.
I do too.
I think this is going to be okay.
Infection?
Yeah.
So abscess?
Especially when there's an orbital implant, right?
Yeah, antibiotics. I don't know who does the post-op orders, but he should probably be on antibiotics for 2 weeks after this.
You know what?
And do he need now antibiotics now?
I would.
Intra-operation?
Sorry, what was that?
Intra-operation antibiotics. Do he need?
He should have had an intraoperative.
He did have some during the operation.
Did he have? What did he have, Johnny?
He had 1.5 grams of something like Keflex.
Ceftriaxone.
Ceftriaxone.
Or ceftriaxone. I would treat him with just oral antibiotics. And I would use clavulin, so amoxicillin with clavulinic acid, or clindamycin. Either one, or Keflex and Flagyl. Anaerobic and aerobic coverage. It would be ideal. So
for 14 days.
For 14 days. Yeah. And then you can tell him that might give him some diarrhea. It might make his stomach upset. It's worth it.
Because of antibiotics.
What I usually tell my patients if they're going home on antibiotics is to use a probiotic.
Yeah.
So use
we
probiotic.
also recommend patients to use it.
Perfect. And that usually helps a lot. It significantly helps the diarrhea. What else can go wrong? So flap necrosis, if the flap starts turning black, that's worrisome. but it's probably more common and more likely for it to be congested and look purple. So it's not dying, but it doesn't look healthy. And I don't know if you have leeches here, but you could use leeches. Do you have leeches? Medical leeches, like that you get from a swamp? A leech?
Do you know what's leech? Leech?
Like a bloodsucker.
It's this big. It's this big, and you put it on the skin, and it drinks the blood.
It's a bug.
Ah,
For the
yeah,
skin.
like sponge.
Almost like a sponge,
Yeah.
but it's
Vampire,
alive.
like
But it's
vampire.
alive.
Yeah. Uh-huh.
A bug.
It's a kind of creature.
You can use that,
Mhm.
and that can often help it. Sometimes,
So, yeah, yeah. Ми їх раніше використовували для чого?
have you had a leech anywhere lately?
I think I did have to do one in the pandemic at some point.
Does the VG store them?
Sorry?
Does the VG store them, like always have them, or do you?
Well, you can get them pretty quickly, so I'm gonna.
Do we have cotton tips?
Yes.
Акцентуємо увагу.
Доктор Чо, дайте з'їду трішечки. Поки доктор Чо.
I'll take a pair of AdSense, please. And cotton tips.
Oh, I
I'll
can
take it.
help you.
Я вже майже скінчила.
Oh, sorry.
It's nice when you have like a mouse guide, like a Dingman or like a console you can have a talk to, but
I think we don't need help.
See this scar tissue? This is what's causing this entropy. Should be. Do you have suction?
Yep. I don't know if it's hooked up yet, but it's there.
Кнопоч, закривати, дирочка Home.
None. Okay. Oh, and Dr. Cho told me what Michael repeat?
5-0, yeah, bicarbonate,
Okay.
and a 6-0 or 4-0 silk.
4 silk.
That should be it.
Okay. Are you good for a second? I think so.
Dr. Cho, do you want a new tip for your part?
Oh, all right, have you used it?
I have. It's wicked hot.
Nah. Good.
I have regular needle tips here. I can swap it out and clean them.
No, I like the egg. Oh, you have it on the field?
Not on the field though,
No.
right on the door up there.
No, don't worry about it. I'll use it.
Yep. It's gotta be longer. I'd rather take longer than shorter.
You have anything in this? No?
Take the Bovie, please. Oh, you.
I'm almost done. I literally have a tiny little. But, you know. Garbage? That's graft. That's graft. The opposite of garbage. I'm so long work for garbage. I'm just gonna get him to stay here. You just close your eyes and that's it. Yeah, just cauterize it and it goes in on its own.
Heard that it's a lot more helpful for patients if they get like a dental splint, kind of like a retainer, you know, made
I found
to,
that it makes a lot of buildup in food. It gets caught underneath it.
between it.
And then it's harder for it to maintain.
Oh, yeah.
Трошки, бо виходить, що працюють.
Curiosity.
Краще завів. Може,
You have a 15 blade?
15 blade, yeah.
може, просто це коліно чуть-чуть. І підняти чуть-чуть. Бачите, вона завалена, бо я думав, що буде знизу вверх. Так, давайте ми її складемо сюди.
Це тоді воно загоїться само по собі. Це часто
You have a
заболить.
Yeah.
Keen or
But maybe it will be the biggest pain of all surgery.
It's
Right,
elevated.
it is probably.
It's pointy at one end.
Number 9?
Yeah, number 9.
I got number 9. I haven't even defined your pick number 9.
I used to always call them number 9, and then at Ohio State, they called them Dean for China. So we switched to Dean.
I call them mold. Mold. I've never heard that. OLT.
I'll take a medium-sized ribbon from top.
Medium size.
Ribbon.
Max.
After shows, you want me to stay and keep helping you, or?
I think I'm good. Yeah, I've got.
I have a set.
Okay.
I want to get in the 2 in the middle.
Thank you for your help.
These are dirty.
Thank you.
Here.
Can we get a freer?
Freer, please.
So, did you say freer?
Yep.
Freer, yes.
Can I have another freer because I only have the dirty one at the moment? Okay.
I don't.
I do know that, so let me go there.
Um,
The freer now.
I'll just use the Molt 9.
Okay, do you want us to roll or? No, but I'm glad.
Have a second one.
So we've made our incision. Once we have the scar relieved to correct the entropion. So now we've made an incision through the periosteum over the inferior outer rim, and we're dissecting in the subperiosteal plane. So, boom. Bones. Can we raise the table just a little bit?
Can you raise table?
Actually, yeah, I think a freer will be helpful.
Okay, freer
Sure,
and
yes.
table is gonna move, okay?
Yeah.
Thank you.
We are ready
Go
to
ahead.
move the table,
Go ahead.
please. Oh,
That's good. Thank you.
thanks. Як ця рана йде до Магомеда?
There must have been some trauma. Same trauma that caused the scarring. Caused this little bone spot.
Thank you. And you guys can do that. At either of those things.
Ray, can you confirm this patient has declined the neck exploration?
The chart says that he deferred it.
Deferred?
That's what it says in the chart.
Okay, thank you.
So these freers have a sharp end and a
Yes.
blunt end.
Blunt.
The sharp end is more useful for subperiosteal dissection.
Hold the head.
Is there a chair available?
Chair, please. Крісло вон стоїть, гарно причому Dr. Cho already visited here.
Most orbital floors, you don't have to dissect in this direction, but in this case, it's such a large fracture. I'm having to go inferiorly. I see above you, please.
Take it. Oh, sorry. Sorry.
Scar tissue right here. I'm being very cautious because I expect the infraorbital nerve is going to be right around here. And I'd like to avoid damaging it if I can. I'll take the freer, please.
Freer, please.
Help me, please. Suction, is it plugged or just fell apart?
Fill up.
Okay. Thank you.
Yes, that's okay. Hold the head. What side do you put in this pocket?
Right there?
So
What,
right
this
here.
side. Okay, to the pocket.
Because that's so sharp.
Yeah.
That'll
You can
poke
see
right
the
into the very
infraorbital.
no longer
Yes.
sterile.
Yes.
Can I get a cotton tip, please? Cotton tip. The cotton tip.
One more?
Uh-huh. The concept is a nice instrument for blunt dissection. It's a lot like a kit. Let me see Westcott, please. So right here, Ilya, you see this structure right here?
Yeah.
I think that's the infraorbital.
Yeah.
Right there. The nerve.
Yeah.
Yeah. So I'm gonna try to dissect everything off of that.
I see the difference. I don't see the difference.
Yeah. It's a suspicion.
Trigger, please. Lots of very dense scar tissue. It's been many months since he's injured. This is mucosa. So this is mucosa, maxillary sinus mucosa. So I'm going to try to develop a plane. I think yeah, that's mucosa. Let me see the bipolar, please. I'm sorry. Bovie. Yeah. I think one thing and I say another. And I'll take the freer, please. So here's the lateral edge right here. Bovie. Can you take this ribbon for me?
So, Ray, they are done with that dental case, and so they'll flip, turn over. You're supposed to do your part of that dermal graft. Can Priya start? Was that the plan, or
Yeah.
do you want us to hold off?
Let's see how things are going. Now let's not delay. What? Can you remind
Like,
me?
we can probably have
What is
it
the-
in 30 minutes.
What
40
is the
minutes?
procedure? There's more to it than just a dermis
Yes,
background,
yes.
right? Yeah. There's some kind of soft tissue
It
reconstruction.
says soft. That's all it says.
That's all it says.
Dermis fat and soft tissue recon. You want me to grab the chart?
Can I see the chart?
Absolutely.
Thank you.
Good for now. For sure.
Here's a bone fragment right here.
Go under there and tighten that.
Is he a concept again? Show me the picture. Oh yeah. Um. What? How long do you think it's going to be before he's asleep and ready
It's
to
up to
go?
you. You can give us a time frame and I'll manage it accordingly.
Is Dr. Kesarwani around?
Let me go find her. Yep, we'll grab her.
Okay. Keep toe in.
Okay.
Okay.
So, in a moment.
Freer, please. You can grab the suction. There, Elliot.
Я сам цього не бачу. Да, сирова нижня частина зранку. Швидкість. Рідкість.
Anastasia, can you do a measurement from the orbital rim to the posterior ledge for me? Please take that chair out.
You want
Take it out. Yeah. Thank you.
Все їхало.
Mm-hmm. 26 millimeters? Okay. You see the bipolar button? Little pedal. Your pedal.
Педаль для біполяру цими ногами, він там з тої сторони має бути, там біля вас.
Дякую. What's the bipolar on? It's on 24? Okay. Hit above it, please.
What?
Bovie?
Бовить.
Jackie, can I get a snap and a ruler, please? Yeah. It's about 38 millimeters. Check the bovie again. Grab the ribbon. Take the ribbon, Elias. Take this ribbon.
Oh, Priya. After the start. And we're
Hey Priya, I was thinking of a glabellar item pedicle flap for he's got that defect in his mediocanthus. Have you done those? What's that? Uh-huh. Does he have a pitch on? Yeah, okay. Yeah. So, somebody, if you or anybody needs to, I think we're doing a lateral rhinotomy and then do a 2-layered closure. Yeah, so let's get that started.
Okay.
And then I can do the dermosacraph whenever.
Попробуйте зараз пограти ліки туди-сюди. По-моєму, нормально, да? Нормально? Розступіть через
If at some point you want or need bipolar, they switch pedals, and we think we have it working now.
Take the bipolar, please.
I guarantee you nothing.
36? Okay. Yeah. Uh-huh. That makes more sense. Thank you.
В плані того, що ваше плече, якби буде страховка, що безпричинно вдариш. Якщо що, так рукою, знаєте, поліцейський прийом.
So I have dissected now all the way to the pterygopalatine fossa. I'll see a freer, please. I have my posterior ledge, which is right there. Actually, it's probably going to be a little higher up. Right about there. So this is just going up to the inferior orbital fissure. Our suction's clogged.
Preference for antibiotic treatment for that on the plate?
Whatever you prefer. And do we have the PSI on the field?
It's not on the field yet, I was just totally waiting until you tell me to.
Go ahead and get it.
All right. CSI on top of the thing with the trees.
Okay. So this is not how things usually look, but there's the medial wall, the posterior ledge. We're going back into the pterygopalatine fossa, inferior orbital fissure is all coming along here.
Very, very, very.
Let me see the bovie. Oh, bipolar.
And for an implant, you touch it as little as possible.
See this artery back here? Probably a branch of the maxillary artery.
Any nerve that may have somehow gotten anywhere, we don't. For an implant, very,
Probably
very
V2's coming through there too.
Then the inside of the coating, I have to get stuff inside the coating.
Bobby? So right there. I think that's V2 right there. All right, let me see the implant.
Ні, там, чекайте, а ви можете трошки виступити, бо я не можу навести вістість. Дякую.
And an absent. Nope, that's upside down. Thought it looked weird.
Oh, yeah.
I know, I'm just like,
Yeah.
because it's not like you can run the.
No, we should have taken either, because we can put these steel packies.
Yeah,
But we should
that's
have,
a good idea.
and then somebody else can get, because there's several 4s, several 5s, several 7s, and 9.
Okay.
And if they get steel packs, if they're.
Let's see a Freer again.
Freer.
I'll grab that one and ask her.
And we have the peel packs to do it.
Anastasia? Is there a landmark for these fixation holes? Not really.
4, 5, and a 7.
Come over this.
You might kind of use what's from all the. This is all 1.5, this is all 2.7.
Are they all in the same length?
Well, so there's 4, 5, that, I would take a 4, leave a 4, leave a 5, leave a 7.
So it should be resting on the rim there medially? Yes? Okay.
Not individually, the row of 5.
So you see a Dean, please?
It should.
Maybe it's more lateral.
That's how they're going to. I'm just trying to see, I have to look at the technical, but I'm just, it's not. Because we're being off. If I could do a 4, 5, and a 7, then Four, all four, all five,
Я попробую все-таки вивернемо до тої позиції на ту сторону.
Набагато зручніше було дивитися в екран. Ми спеціально робимо трансляцію, щоб її було видно.
Там взагалі не видно. Що не видно?
На YouTube ми не можемо знайти де до цього.
Okay. Let me see add something again. So sometimes I will put a freer or something between the implant and the posterior ledge while I'm positioning it.
Камера. Ми стараємось все показати на трансляції. Ну, ви розумієте, що ми от проїхали, так,
Ні, тут не вийде. Навіть не можна, тому що він піднімається.
Jackie, do you have a Dean?
Головою вбиває.
A Dean?
Не хватає фокусу.
Oh, not all nine, sorry.
No, it's okay. I just want to make sure I was remembering it
Не
correctly.
можу навести тільки все, що вище, не можу навести вище. Ти вже попробували, так що ми...
Grab this.
Нижче.
Можемо трошки ще опустити.
Дивіться, а якщо ми так зробимо?
Let's see the medial rim.
Так, і
A
тепер
medial.
сюди.
Yeah.
Это міняти, що я вам відсмоктував ще саму...
All right, right there. I think that's perfect. There.
Да, я ж не бачу просто...
Okay, go lateral again.
От вона є.
So we have self-drilling screws here.
I should have
Okay, I'll take a 4.
four coming up.
Не вистачає, так? Давайте зараз гані трошки вниз.
Four.
Maybe. Okay. Yeah.
So when you sit here sometimes, always look back for the ask. If they ask for a four, tell them what you're giving them, even though, so you know you're gonna take it, right?
Дуже дуже велике.
Взагалі не ворушився.
And usually,
Take another 4 screw.
Не вистачає?
Ще трошки.
sometimes they will.
Давайте ми ще сюди отак підтягнемо. Давайте ще сюди підтягнемо.
But in some cases,
Сюди, за рахунок того, що ми наблизимо, буде трошки ближче. За рахунок цього вигину. Да, чуть-чуть.
Stop. The ledges.
Дайте пробуємо сказати. Ні? Максимум, що можна.
I think it's medial enough. This needs to be more over here. Can I see the screwdriver, please? Yes. And a pickup. Lord. Just screw back. I need the screw back.
Давайте поки що робимо. Поки що взагалі давайте от звідси. Давайте пробуємо поки.
Here's your screw back. I'll reuse these.
Чуть-чуть нижче. Я пішов, бачите.
Let me see the dean again. Oh, Dean.
I'm sorry.
Small 9. I'm gonna take them getting used to. See, thank you. Sometimes my words escape me.
Yeah, that's I don't think I literally think I'm gonna put the same spot.
Take that back.
You have to check the air and auto.
Let's see that section. Okay,
I didn't want you to cut with your hand. I was gonna wait for someone to have a glove on it, or I would have done it.
Well, there's a gap here. Hey, Anastasia? So is the implant supposed to be resting on the ledge posteriorly? Because when I get it on the ledge, there's a gap between the implant and the anterior rim. Give me the sagittal. Okay. Maybe it's just rotated. Let me see 2 pickups. Yeah. Do you have something heavier than this? You know what? Let me see a Dean. Don't worry about it. Still a gap there, though. You see the Hanson?
I told them not to go back in. And then, but the big
Там сидять біля сходів, серед керують і у них краще картинку, ніж краще ще там в Ютубі і на сайті телемедицини є. Нічого не буде. Тут бачите, тут навіть ми не можемо сказати, що він працює.
Section right there. Section right there.
Посушіть туди.
See a 4 screw, please. Screwdriver back. One more.
Краще на полку нижче.
That looks like the medial
На
wall.
полку нижче я би поклав, бо да, то якось так натяжко.
I think we're good. 4 screw.
1.5 by 4.
Thank you. Anastasia, what you want a picture of this? You want to get a picture? Get a larger ribbon, please. The largest ribbon, yeah. And a larger Demar as well. Let me get a bigger retractor.
Thanks.
Oh, let me get you a better view.
Please. Keep it split.
Do you want my headlight?
Thank you.
All right. Let me see. Do we have a like a 5.0 monocryl suture? Okay.
501 is small needle.
Yeah. Like a P3? Yeah. Depends on what you mean by small. I'll take a Westcott and a 0.5.
Westcott and the
0.5 forceps. Yeah. So he has a notch in the lid, so I'm gonna excise that and repair it. There. Can I get a cotton tip, please?
It's really interesting, you know, this kind of work is translation on sense of, we're taking knowledge of the years. Similarly, they're learning their anatomy, and so they're translating knowledge to us, and we're translating knowledge to them.
Можливо сказати ще для цієї камери не показати саме імплант відбігачка камери для бродкасту.
Just doing a focal excision of this eyelid that has a deformity. And the tarsus, there's a gap in the tarsus here. So I'm going to excise that portion and then reapproximate it.
Вони з тої камери вибираються, але ж
Dr. Cho, is it possible to show our implant for our broadcast?
Sure, yes.
Thanks.
We see a suction and a ribbon, the medium ribbon that I was using before. So is the camera able to?
We're trying to show that part.
Okay. So so here's the anterior port fixated to the lateral rim. Here's the lateral ledge, bone, the medial edge over here. Yep. It's going to be very difficult to see all the way back, but the posterior ledge
Close the camera with your hand.
is back there.
Sorry, but you close your hand. Yes. Oh, yes, we see. Now we can see it. Yes.
So the posterior ledge is here.
Yes. Yes, super. Super. Excellent.
Okay.
Yes, thanks a lot. Thanks.
Yeah, I'll take the fibro monocle, please.
And do you prefer the CCR?
Castro Viejo, please. Yeah. And a 0.5. And Demar?
The little one or the big one?
The little one. Both bipolar, please. The Demar?
Might depend on stage of how damaged the tissue is, how old the patient is, after this probably is. Usually surgically wise, but serial technique or.
I'm going to close the periosteum over the implant. This is not something I routinely do with orbital fracture repairs or any orbitotomy, but in this case, because there's a implant overlying the rim, we want to have some the periosteum covering it.
On the edge, top of maxilla, right?
Yeah.
Then on the back. Maybe on the back. I know they were.
But the reality is.
Generally, for most inferior orbitotomies, closing the periosteum isn't that important, and it can cause issues like scarring of the orbital septum, which can lead to lid retraction and lagophthalmos. But this case is a little bit different.
It's amazing.
Well, not here, I don't.
Got a pretty good team going though. Materialize.
Hey, Peter. I think my battery's running low. I have a spare one in my flight bag in the dressing room.
Light bag.
Could somebody? Yes.
Okay.
It's a.
Get it?
Yeah.
Let me see the type of bag.
Yeah.
Don't mind, I'll just sneak under here. I won't take it out of there, of course. Okay. Gotcha. Okay, I'll go see if I can get that for you.
Thanks, Peter.
Right back. Excuse me, I'll get the new bag.
Yes.
Just want to make sure I'm not grabbing orbital septum. Yes.
Yeah.
Did you bring your daughter, Roxalana?
No, she's busy now. Tomorrow.
Okay.
I sent them a picture of the mommy and she said, oh, I want to be there. But she likes to do it. But I really like it. It's cool now. It is cool.
What's that?
I brought you matcha. And it
Oh, you brought matcha?
Yes.
Thank
In
you.
thermocrat. But in any case, it's cold.
Oh, it's supposed to be hot, huh? I like iced tea.
Iced tea?
Yeah.
In the finish.
I think I've got the magic here, right? Let me just
Thanks.
find one first.
It hasn't run out yet, so.
Okay, so do you want me to leave
we'll
it, let
just,
it run out?
yeah, just
Run out?
yeah. It started blinking.
Okay.
Give me a little warning.
Okay, well, I'll put it down there then.
Thanks. Okay. Here's the needle back, Jackie.
Please.
So I will take the 5-0 Vicryl. Yes, please. So this is just a standard full thickness repair. The lid. Do you have 6-0 Vicryls in your clinic?
Yeah, I
6-0
do have mine. Yes, I will.
Do?
Yes.
Thank you. We ordered a bunch of sutures, but somehow 6-0 Vicryl didn't get added. So.
How much do you want? Order. It's the only
Maybe
thing that
I think a box.
I'm not sure what really Vicryl, really Vicryl, or like it's still the polyglycolide.
Polyglycan would be good. Yeah.
But just of the local manufacturer.
That's fine.
Okay. You need to change your battery.
Soon, yes.
You want to pack like 12?
Yeah, like a box would be great.
A box.
So.
Or you need it tomorrow, today?
No, I should be good right now, just for the rest of the week. So this is a vertical mattress closure of the eyelid margin.
Scissors, please.
You have Westcott scissors. Let's cut this right on the nose. One at the mucocutaneous junction and one at the posterior lash line. Do you use vertical mattresses for your full thickness lid? Yeah. I like the wound edgy version that it produces. It prevents a notch. Westcott's.
Scissors. Di tutto. Yes.
No partial thickness. Closure of the tarsus. You concept, please. Thank you.
Навіть такі конференції, які часто це окремо подражання шиву.
You have all kinds of sutures?
No, you show us.
Oh, well, different.
Previous was urine, right?
I think it may be time to change the battery.
Yes.
Could I have my battery pack changed, please?
Where do you have it?
On my right hip.
And FYI, they were just putting the patient to sleep 5 minutes ago, so.
Great, thanks. I only have half an hour here.
Okay, I will run them up. Where do you want me to put your battery recharging?
Where wireless. Okay. Is that bad? I'll use it again.
You'll use skin paper?
Yeah, I'll take the graft.
Is it working?
Yep, thank you. Okay, so this is our hard palate mucosa graft that Dr. Biscup kindly harvested. It's a little bit thick, so we'll thin that out. I'll take the Westcott's, please. And a Raytec. So here's the mucosal surface.
I'm a little afraid if you need to do any cutting or anything with a blade.
I think I'm good. But I'll take a Adson, please.
In your hand. No,
Oh.
not right here. 0.5 we call it, right? Because
Yeah. Can I get some autonomy scissors, please?
Вирізали коагуляцію.
Anonymous scissors.
Залишили. Я не бачив, да, теж. Да, ну тоді включите мені світло, ми спробуємо це роздивитися. Зараз, думаю, можу заважати.
Garbage?
Yeah.
Може, little forcep, it's a little sex.
Ні, це з того боку,
Так. No, I'm good.
Okay, can I see the DeMar, please? Small DeMar. Mm-hmm. And the 5-0 Vacro. Do we have a conformer in the room?
A conformer?
Yeah, an ocular conformer.
We have an ocular conformer.
Can we get a medium conformer, please? Thank you. Take the Vacro. Mm-hmm.
I hold this spot, right?
Yes, that's very helpful. Thank you. You have another 5-0 Vacro ready?
Another 5-0 right now?
Yeah.
5-0 right now.
Maybe I can hold it.
Sure, yeah.
Medium conformer.
Did you have a charger for your headlight batteries?
It's in my hotel room.
Okay.
Yeah. Two usually last the whole day. Cut.
Scissors, please.
I have another 5 whenever you're ready for it.
Thank you. Can I get a 0.5, please?
Oh, and that's right?
And I asked for a 4 silk as well, right?
I do have more also on, yes.
Okay, thank you.
I have the conformer whenever you're ready for it.
Thank you.
Так, вони зараз працюють на місці.
Yes, yes, we are done with the fixation set.
I think these two should be together instead of, I think we should put one with it, it's separate, one or two in there, and then we can decide if we want to separate these or not. But yeah, I think it would be more useful if somebody else uses them at the same time. Because it's all PSIs, right? If it's a PSI, if they use the plates in here, that's a different story. Discuss that at the end.
Well, I need to know now.
Oh, before, yes. Because Emma, yeah, Emma kind of wants to discuss at the end of it. So
Yeah.
that's why I over, exactly.
Of course.
Good. Take the other 5 Velcro, please. And his Thomas looks significantly improved. It'll be even better after when he gets his prosthesis. Okay.
The only reason I keep taking it back when you lay it is because we only have one. But if you hold on to it, but if you need to put it down, just let me know so I can put it up, just so it doesn't fall, because we only have one.
Що один, то обережно.
А зверху його до чого фіксують? Чи вони фіксують вас?
Do we have a single skin
А
hook?
зверху до чого? Зверху так само до краю вертикального соки. Так як вони розсікали. Really thick compared to a skin hook. Там, де вона є, вона скрізь є.
Yeah, that'll work.
Це бачите, де закінчуються віки на нижній губі, це ролі зараз на це трапиться. What is the name of that little one?
That is a Stevens muscle hook.
Garbage.
Де розсікали, на сьогодні вони одразу виходили на нижчі лінії і виходили на гаймору. Зараз що важливо, є живий.
От там, де закінчується кон'юнктива, завжди ж століння має його підтягнути. Так, інакше я не дуже проти. Там у нас була ретракція нижньої крові, хотіли мені не робити, вчора я собі має підшипка, і низ так само підшипка. Якщо конкретизувати, то вибирати яка була варна.
So, Ray, no rush to OR3. You have time to make any notes that are required because they're just putting the patient to sleep. There was further discussion, so.
Further discussion about
Johnny ended up in there, Natalia, and they were talking with Paul about anesthesia, length of case. So,
okay.
okay, so no rush.
Do they have a plan on?
They're saying now 3 hours. You had in the computer 2, so I'm not sure exactly what they
Okay.
changed, but it'll be ready when you are.
Thanks, Chris.
Scissors.
Do we have some Naxotrol ointments?
I gave it, I put it in the OR2. Зверху там знайде анестезіологічний той апарат.
Needle mat?
Sorry, where did you say you put
Yeah, it's in the OR2. Just a
In
minute.
OR2?
They already get it.
Oh, okay.
You finished with this repeat?
Actually, I need it back because my previous sutures came loose. One of them did. Pick up.
We have lots too, we just don't call it Mexico. It is what, it's just Neo, yeah.
Well, it's neomycin dexamethasone, right?
Yeah, thank you.
I don't usually use Vicryl in the skin, but we don't have plain gut sutures. Do you have plain gut sutures?
Yes, we do.
Do you have plain gut?
You need we have plain gut.
Yeah, I don't like
I could be
chrome.
wrong on that. Which size?
Like 6-0?
6 or dot?
Yeah.
No.
I don't need it now. But and I think I might do that. Let's see once the conformer goes in. You have the conformer?
Yep.
And the Maxitrol?
You just want that on like a Q-tip or something?
No, I
or
just
in
squirt
there?
it in here.
Okay, so that's gonna be.
Take the 6-0 or the 4-0 silk, please.
Or silk on the Castro again?
Castro,
or
yep, yep, Castro.
And you are done with the repeat now?
Yes.
And this is your last suture?
Yep.
Ні, через 10 днів. Так. Через 7 днів.
Yeah, saying that your scrub, so your lap,
It's in the same price.
Oh my god, that's hilarious. Yeah, yeah. Next time, don't do this. Don't do this, because you'll look like the whole.
A week.
Тиждень.
Один вирішив.
Один.
Needle back. Wet and dry. Mosquito.
Really wet, dry, or wrung out? Here?
Medium. Yeah, we did a left orbital fracture repair with the PSI.
Quiet, we're giving a timeout.
We also did a extracontrol stench open repair with the buccal mucous membrane graft and repair of a full thickness wedge resection of the left lower lid. There were no complications, there were no specimens. EBL was minimal, and everything went nicely. Thank you very much.
But we have neck section here, yes? Virgin body. Somewhere here. Somewhere here, virgin body. As I...
He did not want it removed. He
don't want
He declined it, yeah.
Okay.
Yeah.
Oh. No, switch off.
А ви не хочете зробити фото?
So he'll
Come on,
probably need his
досить
new
зробили фото.
prosthesis. Well, he can try the old prosthesis. It was like a donated prosthesis, right? So he can try it. Yeah, after 7 days. Yeah, but he
Dr.
may
Shaw.
need to have it adjusted. So, if possible.
Dr. Cho, can we make a photo with you?
Sure. So he'll need, wait, is there like a resident or nobody who works in ENT here? Oh, okay. Wet and dry? Oh, there it is. No,
It's
this
not
is dry.
very, no, not.
Thank
Really dry. Okay.
Clean dry.
Yes. Yes.
Here, they get left on the table.
One thing, so, Hannah, right?
And that's garbage, but I'm here. This is not garbage. And I want to make this baby, this is sterile. Yeah. It's fantastic.
Photo. Photo, please. Can I ask you?
Yeah.
Make a photo with you, please.
Certainly.
Please. Thanks a lot.
You're welcome.
Thank you.
Thank you.
Doc, can I ask you one more, please? I want to take Hudson and want to look in his mouth.
For what is it?
Oh, just look for in his mouth. Press his teeth. Switch off, please.
Switch on.
Ні, так нормально, да. Середньо так гарно потрібно натиснути. Ні, ну там тик, ну так, що таке? О, є. Ну, трішечки ще горло. Можна ще, от, було на 10 хвилин опустити вниз.
А, та, добре.
Шановні колеги, сьогодні ми закінчили свій операційний день. Ми вклалися в час, ми навіть швидше закінчили, чим планували. Ви сьогодні мали можливість побачити 4 цікаві операції, 3 з них були з пацієнт-специфічними імплантами. Завтра вас чекають не менш цікаві операції. Ми зранку будемо про них розказувати. І, будь ласка, задавайте активно питання, включайтеся на портал Карл Шторц. По можливості ми будемо на них відповідати. Дякую вам сьогодні всім за увагу. Гарного вам вечора і до завтра. До побачення.